And this is today is the last one for regarding sinus surgery. And next on Sunday, we are starting with our ear surgery, like we'll to go for the temporal wound dissection from Sunday and the hands on board with ear surgery also. So I will not take time. And I think we should go to Dr. Satish for the surgical starting of the case. I think you'll go with the CT scan. Anything from Paramita? You want to say something?
So
Thank you,
I
boss.
would just like to say, we are truly grateful to Sun Pharma for their tireless efforts in organizing and hosting this event, because that which has brought all of us together today in this arena of COVID-19 pandemic situation, which is not at all easy.
Thank you.
So we have surgeons here, and I'm also thankful to the honorary panel of our distinguished guest speakers who will be sharing with us their years of expertise and critical insights. And also thankful to Dr. Rajiv Pachori towards organizing this webinar successfully. So I think we'll come back to Dr. Satish Jain, sir. We can start with this event.
Thank you. Thank you, Paramita. And thank you all. Thanks to Sun Pharma. And big thanks to the organizing team. Special thanks to boss Dr. Rajiv Pachori and Paramita for the hard work. This is, I believe, is a big day for the Indian Otolaryngology Society to have some stalwarts to teach us, to guide us, and the people who are here with us are truly phenomenal, who have their lifetime given so much to the ENT, which is something unbelievable. So first of all, I welcome here the big boss, the master blaster, Professor Eldo Stem. And you know, when he was asked about his introduction, how to introduce him, what he said, that my biggest title is I am friend of Dr. Sethi. He's so modest, and believe me, the kind of phenomenal work he has done. Thousands of lectures in the international circuit. 4 books he has published which are bestseller. I have went through his books thrice.
Sir, excuse me, Dr. Satish Jain. Actually, I was told by some of the audience that no audio is coming, no voice.
My voice is not coming?
Dinesh, can you please check?
No, my voice is going.
You're not audible, sir.
Yeah, you're not audible. Actually, we've got so many feedback. And please take out this screenshot.
Can't you hear me? Can't you hear me?
We can hear you, but audience is not here.
As an audience, we could not hear.
No, it is going. It is going. You checked. So Professor Eldo Stem himself is a phenomena, and what he has contributed to this science of rhinology is a truly transnasal endoscopic surgeon. What he has propagated over last more than 2 decades. He is presently the director of the ENT and Skull-Base Center in Sao Paulo, and presently associated with the university hospital there. And I give a big welcome on behalf of the Indian Society of ENT Surgeons to Professor Eldo Stem for being with us. And I hope people will have great time to interact with him. From his experience, we are going to be benefited like anything. Thank you so much, Prof, for being with us. Then we have our own Professor Sethi. He doesn't need introduction in Indian circuit, you know. And we all know what he has contributed in his life. Truly, he is the one who has propagated this concept of endoscopic sinus surgery throughout the country for years together. I remember when I attended his first workshop in 2003 and was amazed. And I'm thankful to certain people in India for making so much of efforts to bring him to India again and again. Professor K.K. Ramalingam, Ravi Ramalingam, our dear friend, Dr. Megnath, for their hard work of bringing Dr. Sethi again and again, who has been teaching us for years together. And thank you, Professor Sethi. He is such a modest person, always involved in propagating the science of endoscopic surgery, and still we follow his techniques of Intec-Bulla technique and so many others. And I'm personally indebted to him for giving me so much of opportunity in Singapore. He has served Singapore General Hospital, the prestigious hospital, for more than 25 years. And now he's presently associate professor in the Duke NUS School of Medicine in Singapore. He's still involved in teaching and training like anything. Thank you, sir. Thank you for being with us. And I'm grateful to you for guiding me throughout my life. He has always treated me not like a student, like friend and a brother. Thank you, sir. Then we have with us our own Professor Milind Kirtne, sir, Padma Shri Milind Kirtne, sir, who has, he is known for the task what he takes to the best. He propagated so many things in our country. I remember when I attended my first workshop of sinus surgery in 2003 when he called Professor Stamberger in Mumbai. Amazing workshop, and then it took this science to the heights. Then people, if some people do not know, he is one of the best neurotologists in the world and trained many, many neurotologists in the world. His hidden talent is something is difficult to discover. And more than that, now for last many years, he is a leader in the cochlear implant surgery, and in his guidance, probably more than 10,000 cochlear implants have been done in our country. And we are so indebted to him for spreading this science, teaching us, and treating every junior colleagues like his colleague. Amazing, sir. Thank you so much for being with us here. And I'm sure with these personalities, people will be benefited like anything today. Besides these, we have a young chap, Dr. Gaurav Medikari, with us today. Gaurav, for the people who do not know, you can see this young man full of energy has been a dedicated rhinologist. Truly a rhinologist. The reason is, in his training, first he got trained with Professor Jung in Seoul for the rhinoplasty. And through him, we called Professor Seoul in Jaipur and had workshop twice on rhinoplasty, which had been mesmerizing. Then after that, he did a fellowship in Liverpool, UK, in rhinology and anterior skull-based surgery, and presently is in Vancouver, Canada, for another fellowship in anterior skull-based surgery. And Gaurav, who has worked with us for almost 9 months, and that was my golden time in Jaipur when Gaurav was with us. He came to me for learning, but believe me, I learned a lot from him. Thank you, Gaurav, today for being with us. No. So, without wasting time, we'll start our scientific session today, which is, the outline is basically, we have 4 live surgical cases. We are starting with the basics. Our first case is going to be a nasal polyposis for a full house FESS, which I'm going to start with the CT scan quickly. Then the second case is going to be inverted papilloma, and I will throw some light on what concept we discussed in the last webinar. And this is the classical example of misdiagnosis of inverted papilloma earlier. Then the third case would be a allergic fungal rhinosinusitis, and the fourth going to be a meningoencephalocele. And after that, we'll discuss on finally on complications. So today is the concluding day of this series of webinars on sinus diseases, and we have all stalwarts here to conclude with their remarks, their opinions, and anybody who is, all of you who are watching this webinar, feel free to ask more and more questions. Every single question will benefit everyone. So I want you to make most of the presence of these people today. Thank you so much, and let's go ahead with the CT scan of the first patient. So can you put up the CT scan? So this patient, basically, I tell you in brief, is a 30-year-old lady, had been suffering from classical symptoms of chronic rhinosinusitis for more than 2 years. Had been taking intermittently steroids to control her symptoms. When she came to us, we suggested in November the endoscopic sinus surgery, so that, like we discussed in the first webinar, anybody requiring oral steroids again and again to control the symptom with classical symptomatology and signs of chronic rhinosinusitis, where the polyps are, is the candidate for sinus surgery, so that we can avoid in the future the need of taking the oral steroid, and the patient can irrigate with a topical steroid which can reach deep into the sinuses. That's how this patient was selected for sinus surgery. So once it comes to sinus surgery, as we discussed last time, the radiology has a big role. And we discussed last time as well, to get the best information from the radiology, we should have a complete fine section data in a DVD rather than printouts to get maximum information, dynamic information. So let me run through this. Is the picture good? Is the CT scan picture good there? Isn't it dark?
Yeah, it's okay. It's okay. Good. It's okay.
Okay. So the CT scan of the paranasal sinuses, what we order is a fine section 0.5 mm, 0.6 mm in all planes and in a DVD, and this CT scan is always shot in the axial plane, and then we can reconstruct with our own software into all three planes. So you can see this was the axial plane which was shot. You can see the slices 0.6 mm. The entire area scanned was around 20 centimeter, and what we reconstruct in three planes is the end product is this kind of a CT scan. And this is what becomes a good teaching tool to the junior colleagues when you have a CT in a DVD, full data on the DVD. You can run in all three planes together for any structure you want to see. For teaching purpose, for learning purpose, you can bring your cursor there and you can see all in all planes where you are exactly. So for chronic sinusitis, again, I would reiterate like last time, the need of the CT scan is not for diagnosis, it is for surgical planning and giving us anatomical details. So here, what information we are getting? See, this picture is a complete whiteout. Once this patient was selected for surgery, she has been under preparation of the steroid and the antibiotic cover, and her polyps have regressed a little bit. I will show the endoscopic picture very soon. And what CT scan we have here is, there are certain information which are best gained from the coronal plane, certain from the axial, certain from sagittal, and we should be able to know this and get all this information truly in the three-dimensional plane for that particular patient. Quickly, as most of the patients, most of the doctors are well versed with the coronal plane. As we get the information in the same plane like we are operating in the coronal plane. So we are well versed with the coronal plane, and we should know how to read the coronal CT scan. So here quickly in 5 minutes, I will run through the scan to touch upon the important points. Feel free to interrupt me any point of time. Job of Dr. Paramita, I know, is the most difficult one. On one side, she is focusing on what I am saying. On the other side, she is collecting the questions from the audience and trying to forward here. So good luck, Paramita. Thank you for the hard work. So this patient's coronal CT, if I run from anterior to posterior for junior colleagues, you can see in all planes. So in the, see, like I made the picture bigger one. This is the most anterior plane. This is the frontal bone. What you see here, this is nasal bone, and this is the cartilaginous septum and the ala. As I go behind, every time I move by 0.6 millimeter. See the pneumatization of the frontal bone coming with the intersinus septum, which is almost always eccentric. And you see the opacification of both sinuses. That shows the patient has a frontal sinusitis as well. On non-contrast CT scan, what you can appreciate is only opacification. You cannot discriminate into it what exactly the pathology going on. Then the nasal bone, and see the beak. This is the beak. This is one of the most important things to understand the beak. It is a bearing on the frontal sinus surgery, the biggest obstacle in frontal sinus surgery. Also. If I go back, see in the
tell Prashant, tell all our friends, it's a fantastic book.
See the sagittal plane, how the beak is. If you are working from here to enter the frontal sinus, the biggest obstacle is the beak, and we should be able to see in every concerned patient how thick the beak is, how going is, how difficult is going to be the course to enter into the frontal sinus, what is the cellularity in the frontal sinus for that particular patient. We should be able to see. Like in this patient, once we see, the frontal sinus is best seen on the sagittal plane. And you can see each and every cell which is forming the path of blockage to the frontal outflow. So we should be able to know each and every cell. So from here, if I go behind, this beak forms the floor of the frontal sinus. This is something I'm going to relate intraoperatively as well, as this is going to be my biggest landmark for the frontal sinus. We have been showing this for years together, and today as well. to understand the frontal sinus, to reach the frontal sinus, to open up the frontal sinus, which is considered to be difficult for surgeons. Believe me, if you see three-dimensionally, some structures becomes a child's play. And for frontal sinus here, beak is the obstacle and beak is the biggest landmark as it forms the floor of the frontal sinus. Now, as I go behind, see the beak intact. As I go behind, as the beak goes, the frontal outflow starts. So, from anterior to posterior, if you surgically, when you follow the beak, where the beak ends, the frontal sinus begins. That is how the frontal sinus drains from behind. And you look at the cells in that region, which may complicate the drainage pathway. Like for this patient, particular patient here, this particular cell where my cursor is the obstacle to the frontal sinus drainage. And what you see here on the sagittal plane, this is the big agarnage cell. See this? The bulla is behind and the frontal outflow is narrowed because of the agarnage here. And for this particular, it's a cakewalk for the surgeons. If I go behind the agarnage and fracture it out anteriorly, my frontal outflow will be opened up. So to understand the frontal, the three-dimensional CT is most important. The outflow pattern of the frontal sinus can be studied very easily on this dynamic CT scanning. Now, as I go behind quickly, you have a lot of anterior ethmoidal cells, the bulla, everything opacified. The important thing is, as you go behind the cribriform plate coming in with the horizontal and lateral lamella, and you must see in every case the depth of the olfactory fossa, how deep it is. If it is deeper, you have to stay more careful, more laterally to avoid injury to the cribriform plate. We'll discuss in the complication part. And the important structure here coming down from the cribriform on both sides, either side is the middle turbinate, and it looks like they are also full of secretions or discharge, whatever, completely opacified. So that's how you have to run the CT scan. The idea is to how to go about. Now see quickly as I go behind, the turbinate is moving laterally to the lamina papracia. Turbinate is moving laterally, that is the basal lamella. And as you go behind the basal lamella, all these are posterior ethmoidal cells. And see complete maxillary sinus, everything completely opacified. Pen sinusitis, you can say a little bit of the septal deviation behind. As you go behind now, the important thing to differentiate, which I am going to relate surgically as well as to identify the sphenoid sinus. As you go behind, you have to stay more careful as more dreaded complication happens to occur while doing posterior ethmoidectomy and sphenoid walk. And that challenge can be overcome by identifying the sphenoid sinus properly. And I will show the technique how you can avoid all these complications in the simplest manner for the junior colleagues. So here's on CT scan as well. See the entire roof. This is posterior ethmoid and formed by the frontal bone from pterion to pterion. Entire frontal bone. Now as I go behind, see now the frontal bone disappeared. Frontal bone disappeared. What is this bone? The lesser wing of sphenoid. And that's how this is the beginning of the sphenoid sinus. Two sphenoid sinus, the rostrum here, intersphenoid septa, the orbital apex, the clinoid process, and as I go behind the orbital apex, and that is going to be the impression of the carotid artery. These are the pterygoid processes on either side, and you can see the entire sphenoid completely opacified. The whole idea is to just give you a quick idea how to go about the CT scan, how to get maximum information out of it, and we'll use all this information during surgery to get maximum benefit out of it. Though this topic of reading a CT scan is a huge one, I just quickly summarized it for this particular patient, what information we can get out of the CT scan. Any questions here? Any suggestions? Or I would like here to ask one question from Professor Sethi. Does he do anything differently? I know this habit of reading CT scan, I learned from him when I was in Singapore with him. Can we have Dr. Sethi on mic? Professor Sethi.
Yes, Satish, I'm here.
Yes, boss. Anything different you do?
No, an incredible interpretation of the CT scans. I think when we started off reading the CT scans, we did not have this technology of having triplanar CT scans on a DVD where you have about 1,200 images to go through. In fact, we used to do 3 millimeter cuts and had about 30 images, and that too all in the coronal plane. So, and systematic reading is extremely important, going from front to back or from back to front, that doesn't matter, but we tend to go mostly from front to back because that's the plane that we operate in. So I think CT, what you did is incredible, very nice, and I don't think I need to add anything more than that. The only comment is that what I find is that a lot of people do triplanar CT scans on a DVD. They have 1,200 images there, but they don't know how to read it. So I think doing the scans is fine, but knowing how to interpret that information critically to avoid complications during the surgery, I think is more important. And maybe we can have a comment from Professor Eldostam as well.
Well, good morning. Here in Brazil, now is almost 8 o'clock in the morning. Good morning, everyone.
Good morning, sir.
Thank you very much, Satish, again. And just a short comment. For me, one of the most important prognostic factor, and especially in frontal recess surgery in frontal sinus, is when you look at the sagittal plane, is look at the IP diameter. If you have a good diameter and IP diameter, I think it's a very good prognostic. If the IP diameter is very narrow, it's very difficult to operate the frontal recess in frontal sinus. If you look at this patient, for example, the IP diameter has a good diameter, so a good size. So probably have a good chance to have a very good operation into the frontal recess and frontal sinus, of course. Another very important point, which is new technology, you can do not a coronal section of the frontal sinus, but you can do oblique section in the coronal plane. So you can see all the cell of ethmoid cell inside the frontal sinus. Otherwise, if you use just a coronal cut, a true coronal cut, you cut the cell in different parts. So you have one big cell, you cut in 3 parts, and then you classify type 1, 2, and 3. But the reality is just one cell. This is just a comment about this. For me, in summary, the IP diameter is a very good prognostic factor for this kind of operation.
Dr. Satish? Yes,
Yeah.
I will ask Dr. Shetty, sir, and Dr. Hello.
Hello.
Yeah, just there's so many people are asking how you managed to operate in COVID time, this Corona time.
Oh, okay, boss. I was just washing up, getting ready for the theater, and your question came at the right time, because in this COVID era, we have to have certain more precautions, and we are following the guidelines served by the Ministry of Health from Government of India while operating patients in this era. So, like sinus patients, where you need use microdebrider, drilling, these patients come in a high risk category. And for that, you need to wear level 2 PPE, which is what I am wearing now. So level 2 PPE is, we have to wear the full body gown with the goggles, with the mask, gloves, and another thing is a facial wiper or something like that.
Okay.
Regarding your questions, using all these guidelines from the Government of India, I've been operating since beginning, since the lockdown period also. But earlier, only essential patients and emergencies and cancers, but now we have started operating routine as well. Though the patient list is very less, we are operating only 10, 12 patients a day, not much. But yes, we never stopped. Earlier, only emergencies, essentials, but now the routine as well, with all precautions.
Did I hear you right? 10 to 12 patients a day?
Yeah.
My God.
So list has gone down.
Actually, the per day surgeries 40 to 50 surgeries per day, and that is a normal routine number. Hi, Paramita.
I would like to ask Dr. Milind Kirtanes or what anything he would like to add in this initial few points. In the initial discussion. So unmute.
Unmute yourself, sir. Yeah.
No, I think both Dr. Sethi and Dr. Stam covered it very well. The only thing is my teaching to my students is don't depend on the report that is given to you by the radiologist. Learn to read your own scans and have the scans in the theater. If you find yourself at any point a little lost, go back, refer to the scans and come back, because
picture.
it's not possible to have the 3D image in your head all the time. And now with what you've got now in front of you makes it much easier. Like Dr. Sethi said, when we started off initially, I remember when I went first to Graz, they were looking at polytomograms, which are some hazy images. Then came the coronal CTs. Now we use them in all three planes. But the important thing is, don't depend on the radiologist report. Learn to read them yourself.
Maybe if I can be allowed to add something to that, I think with all due respect to the radiologists, we have advantage over them because we have seen the patients, and we have the advantage that we can correlate the CT findings with endoscopic findings and with intraoperative findings. And this way you can get a complete picture of what is wrong with the patient.
Absolutely, sir. Absolutely. And to improve the situation, I think we have to make a team with the radiologist. That's what we are doing here, so that you can discuss each and every individual case with the radiologist in case required for any fine details, and you learn from each other. Truly speaking, radiologists in their training, they focus more on the brain and abdomen and thorax, not on the PNS and temporal bone. And they really want, I've seen them, they really want to learn more and more. And we, from the radiologists, obviously want to know more about this technology. So it's a teamwork. It's a teamwork, and we should make a team with the radiologist to get maximum benefit to the patient. Are you getting the endoscopic picture, sir?
Yeah, we can. We are getting it. We are getting it. Beautiful.
Okay. This is the primary picture after the preparation part. This patient has been given 7 days of course of steroids. Antibiotic we didn't give because this is a polypoidal disease. We got certain tests done. As I mentioned in my first webinar, we get a battery of tests before moving on to the surgery, and the test why we didn't give the antibiotic is our CRP was normal. There's no point in giving all these patients unnecessarily antibiotics. This is not infective disease, mind it. This is inflammatory disease driven by certain cytokines. There is a pathway of cascade of events leading to this disease. So this is the primary picture. I didn't do any intraoperative preparation so far. So the preparation has a big role. I know every time Dr. Sethi used to come to Chennai and would emphasize on the preparation part. So this preparation starts almost a week or even more before surgery. And the need for the preparation comes for the reason of improving the surgical situation. We really want to improve the surgical field so that the bleeding will be less and less, and we should be able to identify the landmarks much better. So the goal of preparation and preoperatively, as I said, we give a course of oral steroids, not antibiotics in the polyposis. Yes, in the non-polypoidal disease, we do give antibiotics and no steroids and saline irrigation. Okay. Then intraoperative course is equally important to minimize the bleeding. And in general, like we take care of other scenarios, we have to take care of all the aspects of bleeding, the capillary bleeding, the arterial bleeding, and the venous bleeding. In sinus surgery, the majority of the bleeding is contributed by the capillaries and the veins, not by the arteries. So, intraoperative preparation involves the topical preparation as well as the support from the anesthesia side. So, for topical preparation, what do we use? What I am going to show is our own, how we started. This is the marrow cell. We take 2 marrow cells, divide into 7 or 8 to 10 pieces of different sizes.
Pic is not, video is not there, Satish.
Video is not going?
Yeah, wait,
what happened?
So you do not give any local injection and the nasal cavity.
Earlier I used to give over last 7 years. We have absolutely stopped giving infiltration.
Yeah.
The reason is obvious. This is a benign disease for which we can't afford to take a chance of any complication.
Okay.
Okay, are you getting the picture now?
Yeah, now we are getting it. Now we are getting it.
How is the picture, boss?
Not previously it was very good. Now it's okay. Focus out of focus little bit, but it's okay now. Okay, it's okay now.
Let me do the white balancing. Let me know the your feedback so that I can do something to improve the picture quality.
Sir, would it be okay if I added a point to whatever you just said?
Yes, yes, Gaurav.
Sir, also preparation of the patient with steroids, it also improves the sensitivity of the receptors to topical adrenaline that we use intraoperatively. So you'll get a better decongestion if you've given them steroids.
Steroids before. Yes, that's a valuable point. So, intraoperatively, are you getting the picture now?
Yes, sir.
Hello?
Yes, sir, we can get the picture.
Yeah, Paramita, how is the picture now?
It's better.
Better?
Yes, yes.
Not very good?
Hello.
Pretty good, sir. It's pretty good.
Hello?
Yes, sir, it is good.
Okay. So my preparation, intraoperative preparation involves something to control the capillary and the venous bleeding. Since the arterial bleeding directly doesn't contribute to it, we don't believe in hypotensive anesthesia anymore these days. I will tell you the reason behind this. Number one, yeah, I will change the telescope and see if the picture improves. So, to control the capillary bleeding, is the picture better now?
Yeah, it's better now. It's better now.
Okay. So, to control the capillary bleeding, our aim, what we follow is, we use the topical adrenaline soaked in this marrow cell. We use the marrow cell as a vehicle rather than ribbon gauges. This marrow cell is so soft, absolutely atraumatic, and you can introduce in the narrow spaces to open up the space very well. You can use all these pieces differently in different parts of the nose to decongest the mucosa and open up the space. You can appreciate this, how I am doing. This is marrow cell soaked in topical adrenaline, and the concentration depends upon the medical condition and the age of the patient. This being a young patient, I am using 1:2, and sometimes I don't mind using even the pure 1:1000 adrenaline, only for the topical use, not for the infiltration.
Okay.
And it has been proven, and we have observed in our series of thousands of cases, it doesn't make any difference if your pre-operative preparation is good and give enough time for the intraoperative preparation. So this topical adrenaline, what I'm using with the marrow cell, gives the same effect what you get with the infiltration. The issue is why to take a chance of systemic complication by means of injecting adrenaline, which if disseminates in the systemic circulation can lead to fatal complication, and those have been reported in the literature. So we can't afford to take such chance when you have an alternative using topical adrenaline with the same effect. That's how we are using the topical adrenaline. We are using all those marrow cell pieces, soaking them in the adrenaline again and again like this. If I remove this outside, I will rinse in the saline, soak in the same solution, and use it again and again during the entire procedure. At the end of the surgery, if you need to pack the ethmoidal cavity, you can soak them in the steroid solution and pack the same marrow cell pieces without adding on to the cost. So this is the simple decongestion of the nasal cavity with a topical solution of adrenaline and not using ribbon gauges or anything. The second thing what we do is to keep the head end of the table high by 15 to 20 degrees, the reverse Trendelenburg position, which proves to be something useful by means of facilitating the venous drainage from the head, avoiding venous congestion, and that certainly improves the field. Can you see the picture better now?
Yeah, perfect picture now.
See the middle meatus opened up.
Yeah, very well.
Lips even more shrunken. And I remember when I told, shown to, this thing to Dr. Seth in 2005, in 3 days' time, he wrote a paper and sent me back that sent this for publication. I liked it, and I hope he has been using since then now. Professor Sethi, are you using this marrow cell technique?
Yes, we are still using it.
Hello?
Yes, Satish, I'm still using it.
Still using it?
Yes.
Oh, great. When the boss approves, that everything is okay. So he stamps what we have been doing as correct, and this is something proven to be very good in sinus disease. Why we label it as a functional endoscopic sinus surgery? Because our goal is to improve the function, preserve the function, and the function is served by the mucosa and the mucociliary activity. And in any given situation, which I am going to show throughout the surgical course, we have to preserve mucosa more and more. And this is so atraumatic. We are not going to use anything which is detrimental to the mucosa and the mucociliary system. Like we discussed in the previous webinar, in a regular sinus surgery, we don't use hypertonic saline. We use nowadays more and more ringer lactate, which is more physiological than saline, than normal saline. And this was my preparation. Then the next part of the preparation is equally important from the anesthesia side. And there are lots of publications, you see, thousands of publications over the last decade, how the different anesthetic drugs can improve our surgical field, and the more and more emphasis on TIVA, total intravenous anesthesia, as it avoids vasodilatation. And at our center, we have been using a combination of sevoflurane and fentanyl, and in between the infusion of either propofol or dexmedetomidine. All have been useful in reducing, keeping the blood pressure under control, and the most important is keeping the heart rate under control. And what we have found now, changing the concepts. Earlier, it was believed that the hypotensive anesthesia is useful. Yes, no doubt about it, it is useful. If you reduce the blood pressure anywhere, the bleeding will be less. But in the elderly patient, in cardiovascular disease patient, or any labile patient, that can be detrimental. Why to take again that chance? And it has been proven that it is the cardiac output which matters, not the blood pressure alone. So our emphasis is more and more reducing the cardiac output, and which is achieved by means of reducing the heart rate. Heart rate is the key factor in reducing the overall bleeding. Anupam ko bulana?
Satish, just a couple of questions.
Yes, please.
If I may ask. One is, how much adrenaline or epinephrine do you use? Do you quantify it, or is it unquantified? One. Secondly, there have been accidents reported where surgeons have accidentally injected the adrenaline, neat adrenaline, into the patient. So do you color it with something like fluorescein or some kind of methylene blue, so that you don't mistake it for something else, and you know that this is adrenaline that you're using?
Yeah, that is important. The labeling is important to prevent errors. Your point is correct, and we have to label adrenaline separately so that we don't misuse it and use it properly. And secondly, to your question, sir, we don't inject at all. There's no question of injecting. Last 8 years, I have not injected for any nasal surgery. Forget about the sinus disease. We are so happy with the topicals, preoperative preparation, and the anesthetist help in minimizing the bleeding. And see how much time I am giving for the preparation. You need to give at least 10 to 15 minutes to give a good field. And most importantly, see, I am using marrow cell, very loose marrow cell, not tight packing like this. If you pack tightly, it can be counterproductive, giving venous congestion and more bleeding. So all these to be used properly. 60. So my focus and my request to the anesthetist always is to keep the heart rate around 60 to reduce the cardiac output. And this is the most important thing which I expect from the anesthesiologist rather than the hypotensive anesthesia. Though literature supports the use of many other drugs like clonidine and other drugs which prevent the reflex tachycardia, hypertension and all that. But once you are using fentanyl, it blunts all sympathetic response, and it works very well in preventing all those exaggerations in the blood pressure and the heart rate. In spite of using this topical adrenaline, see, my blood pressure and the heart rate is stable.
Satish, can I just say something here?
Yes, please.
Your point about the reducing the heart rate is well taken. And we normally have a calculation that if you take the mean blood pressure and multiply it by the heart rate, the product of the multiplication, if it is less than 6,000, then you're doing okay. If it goes above 6,000, then you have to tell the anesthetist to do something about it.
Yeah.
If you can get the heart rate down, you don't have to bring the blood pressure down that much. Just make sure that this formula of product being less than 6,000 is adhered to. It's a sort of a yardstick you can use.
Yes, sir. That is a great idea. Initially, a lot of people used to do this, but the only issue is, in that situation, you may sometime end up reducing the blood pressure too low. And it has been proven that if your mean arterial pressure goes below 60, can be detrimental to the cerebral circulation.
So that is why it is better to get the heart rate down so that the...
Yes, blood pressure not too much.
That's right.
We never ask our anesthesiologist to reduce the blood pressure too much. We don't ask for hypotensive anesthesia. We always operate nowadays in the normotensive anesthesia. And that is irrespective of the patient profile, whether it is elderly or young or whatever.
Yeah.
So it is most important for the elderly not to reduce the blood pressure too much to test the coronaries or any other.
So your point is well taken. Rather try and get the heart rate down a little bit so that the bleeding reduces.
So now what I have done with the help of microdebrider, I have debrided polyps to get more and more landmarks in view. Can you see that? This patient,
Yes, we can see.
10 days before, this patient had full of polyps almost coming out till anterior nares. With oral steroid, they have regressed. With this preparation further, see now they regress further, and now we have a complete anatomical picture in front of us. The most important thing, like Dr. Sethi emphasized just now, to prevent complications, it is your field which is most important. Identification of the landmarks intraoperatively is a key factor in preventing complication. So all the time, the emphasis is on visualization, visualization, visualization. And here my marrow cell, see this marrow cell is like a magic. I'm mopping with the marrow cell throughout the surgery, remove the same piece, dip in saline adrenaline or ringer-lactate adrenaline, place it for a moment. Placing the marrow cell for 30 seconds or 30 minutes has same effect. Because the aim is to apply the topical solution, not tight packing, just applying simply for less than 30 seconds, and the effect remains safe. Even if you apply for the longer period, it doesn't make any difference. So the second thing which improves the field is the constant irrigation. Intermittent irrigation by your assistant to improve the field, to wash out the blood, to improve the picture. Everything is important. Yes, any question?
So the question from Saudi Arabia, Dr. Shashi is asking that he uses Merocil with adrenaline and oxymetazoline. So can you comment on this?
He uses what?
Oxymetazoline.
Oxymetazoline, yes.
Yeah.
A lot of people use oxymetazoline. Believe me, there are certain studies done wherein the oxymetazoline was compared with adrenaline, and ultimately people found in terms of the side effect profile, the rebound congestion and other things, the adrenaline is relatively safer and better than the oxymetazoline. But yes, that's a good alternative. I don't deny that. You can do that. Now, coming to the middle meatus. Now, the most important role in the sinus surgery as far as the landmarks are concerned is the middle turbinate. Can you see the middle turbinate in picture?
Yeah, very clear. No problem.
This is one of the most important landmark which orients you all the time. And not only that, this has to be respected.
Hello, can I just interrupt for a minute?
Yes, boss.
Yeah, Dr. Aldo Stem has just texted me, sent me an image that the host has stopped him towards starting his video. So can something be done about it?
Yeah, Dinesh.
Pardon? He's
okay, I will tell Dinesh, he will do it.
Disconnected?
Because someone has disconnected him.
Oh, Professor Aldo is disconnected. Wait.
I will ask Dinesh to join him for any issues. Okay. Professor Sethi, can I ask one thing?
Yes.
I have seen you using cocaine. Are you still using?
No, we stopped using it long time back. It's not available in Singapore anymore.
But earlier you used to use cocaine.
We used to use it maybe I haven't used it for the past 10 years, I believe, or maybe 8 to 10 years at least. I use topical 1 in 1000 epinephrine now.
We used it in the UK actually. When I did my fellowship, we used it in the UK quite regularly, cocaine.
Yes.
Yeah, welcome, sir.
Now,
Professor Eldo, you want to say something?
Further, I'll take you to the landmarks quickly. So this is the right side nasal cavity, this is nasal septum, this is the anterior part, this is the prominence of the nasolacrimal system, and behind that, this mobile structure, the only mobile structure in the entire nasal wall, is the uncinate process, is the vertical process, and this is the horizontal process. Then this is the bulla ethmoidalis with some polyps coming out of it, and in between them is the hiatus seminaris, which is leading laterally to the infundibulum. Then this is middle turbinate, the first vertical part in the sagittal plane of the middle turbinate, and this is the concha bullosa we saw on CT scan, and this is full of secretion. See the full of secretions. I can see the concha, and we'll have to do something to it so that it doesn't bother later on. Coina, this is middle turbinate going behind. This is the second part going in the axial plane. Here right up to the roof of the nasopharynx, and this is the nasopharyngeal cavity. I hope the picture is good.
Yeah, very good.
40. So now we move on to the surgical part. On this patient, I am going to demonstrate the steps of sinus surgery on only one side, and then we will move on to the next case. I'm not going to demonstrate on both sides the same step repetition. So on one side, what again I am doing is just debriding some more polyps.
Satish, can I ask you, are you using a 45-degree blade?
Yes, red 40.
So can you comment on that? Because generally people recommend that we shouldn't be doing any dissection with the red 40, but only with the straight blade.
Yeah, boss, I believe this red 40 is a versatile blade. I will show you again. In my most of the sinus surgery work, I will be using red 40. Though I use a combination of 5 blades. The straight one, 40, 60, 120, and the reverse one, the so-called adenoid blade, which we never use for adenoids. So 5 blade combination for sinus surgery to do a complete job. So now my first part of the surgery will start with the removal of the uncinate process. And you know, this technique again we learned from Dr. Sethi. Earlier people used to use the sickle knife to take the uncinate in toto, but the only fear is the orbit is very close. And if you're not careful, you can get an orbital entry in the beginning, and that can affect your temperament if you get entry into the orbit in the beginning. So what we have been using is the reverse biting. See this? Nagashima reverse biting. Just engage in the hiatus seminaris, engage completely and turn it down. This is most important. To turn it little down to stay away from the nasolacrimal system and come anteriorly and bite through until you get the hard bone here. And that is most important to prevent complication. And now what I am doing is, see, this is the upper part of the uncinate and this is the lower part. And what I am doing is fracturing the lower, out fracturing the lower part, just destabilizing it to get into the maxillary sinus. Can you see this?
Yeah, very clear.
Full of polypoidal disease. So I am just little bit debriding the polyps and opening up more and more space. This is the upper part of the uncinate, and this is the bony uncinate plate. You see the horizontal uncinate?
Yeah.
Yeah, we can see.
So how much are the chances of CSF leak while lateralization of middle turbinate? Dr. Girish from Dhilai wants to know this.
This has always been taught that there is a traditional teaching that not to maneuver much with the middle turbinate. The reason is, we all know, as we saw on the CT scan, the upper part of the middle turbinate, this goes behind to insert on the lamina papracia at the junction of horizontal and lateral lamella. And in that scenario, if you try to avoid this turbinate, try to, work more forcefully on it, it can lead to a distal fracture. So you have to stay little more careful, particularly in the upper part. In the lower part, it may not transmit to the cribriform plate, but yes, I will tell you the exact area which is most sensitive in terms of giving CSF leak. When I go high up in the ethmoids, I will tell you, I'll keep in mind that in that region you have to be very, very careful. So this is middle meatal, and trust me, you can say, I've opened the maxillary sinus, you can say wash. See the little bit of the cobblestone mucosa in the maxillary sinus, which I'm not bothered about right now. And as I said, this is a eosinophilic disease. Our aim is to deliver the topical steroids later. What we need to do surgically is to make sure that that topical steroid reaches everywhere. So we have to open.
So what is the role of Stemberger punch at this level, at the floor of sinus cavity?
Pardon?
What is the role of Stemberger punch at this level? Enterostomy.
Stemberger punch. See, any punch, the role of punch is to bite through. So that you don't avoid the mucosa, you bite through the bone.
Yeah, yeah.
So without traumatizing, without peeling the mucosa off. That is the role of the punches. Wherever you use, the role is same. Boss, is picture okay?
Yeah, it's okay.
Now this is the upper part of the uncinate.
Yeah, yeah.
So here the most important thing comes at this step. First of all, this is the area where you are closest to the orbit.
Yeah.
So you have to be careful. See now what I am doing. I can remove via through biting this upper part of the uncinate, or remove with a microdebrider as well.
Yeah, yeah.
Your microdebrider should have a good suction backup for the maximum effect. See now, I am removing the upper part of the uncinate.
Yeah, yeah.
Going more and more high up, you can see the bulla completely. And
Yeah,
at this
clear.
point of time, you reach the medial wall of the orbit. That is the medial wall of the orbit here. See this?
Yeah.
And that gives you an idea of the lateral limit of your corridor. Can you see here?
Yeah, very clearly.
Very clear?
Yeah, yeah.
And now I am removing the upper part of the uncinate here. At this point now, I will change to a 70-degree telescope for the reasons I am going to tell you. My bulla is still intact, and that is how we learn from Professor Sethi the advantage of this technique of intact bulla approach. Intact bulla approach means keeping the bulla intact and walking onto the frontal sinus to take the advantage of bulla, like preserving as a solid landmark for the anterioethmoidal artery to preserve. I'll tell you how.
Okay, just one comment, Satish. You see that by now you have identified two very important landmarks.
Yes,
and
boss.
this surgery is all about identifying landmarks as you proceed in the doing the surgery. You have identified the roof of the maxillary sinus, which is a very important landmark, and you have identified the lamina propria, which is a very important landmark. Now, the next landmark that you'll want to identify will be the frontal drainage pathway and then the skull base. So once you have these landmarks in control, you can then proceed with the surgery safely. You can continue to dissect posteriorly, keeping the skull base and the lamina propria in view. Aldo, would you like to make any comments?
Yes, yes, absolutely agreed, boss. This is the surgery of landmarks. This is truly the surgery of landmarks. And the whole idea behind following the landmarks is to carry out safely. See, the threshold of safety in this surgery is relatively less. The relative closeness, or I would say the location of the orbit and skull base in close proximity makes the possibility of complication likely.
Satish, I think Professor Stam was going to make a comment, so maybe we should let him make a comment.
Yes, yes, please, please.
Yeah, one for me, the bulla intact technique. This was described initially in German and then by Mark Lowry and popularized by Sethi. I think it's one most important point is to preserve the bulla at the beginning of the operation because of good landmark, a perfect landmark. But in frontal sinus recess, you are doing now. For me, one important landmark is the agarnase cell. So you should identify the agarnase cell. Exactly. In this case, you can see very clear, and especially the medial wall of the agarnase. Is the medial wall, I call it the vertical bar. Usually the frontal sinus drainage pathway is medial to this agarnase or posterior to the agarnase. So if you identify the agarnase, you can enter the frontal sinus very, very exactly, perfect. So you can enter the frontal sinus very easy. So frontal sinus surgery is the surgery of the frontal recess. It is in summary.
Absolutely, sir, absolutely. And this is a message to everyone. Frontal sinus surgery is the surgery of frontal recess. And for here, the first and the most important landmark is the agarnase. And see what I've opened. As I showed on the CT scan, this big cell is the agarnase. This is not frontal sinus. The frontal sinus is behind this.
Yeah,
and
perfect.
Here is the role of 70 degree. I'm using 70-degree telescope for certain regions to give me three-dimensional visualization of the limits of the frontal recess. Why people consider frontal sinus surgery as a difficult one? Why they are scared of? The reason is the possibility of complication which this can give. The reason is close up proximity to the skull base, to the orbit, to the anterioethmoidal artery behind. And so the 70 degree when you use and taking certain landmarks in view, you can certainly avoid all these complications. So one by one, number one, keeping the 70 degree in view like this and keeping the middle turbinate in view as your medial limit. See this middle turbinate? If I stay lateral to the middle turbinate, can see this? If I stay lateral to the middle turbinate, I am away from the skull base, number one. Number two, this is your beak. Let me show you. Give me the debrider. As I showed you on CT scan, the beak is the anterior-most anatomy forming the floor of the frontal sinus. See, I'm taking up this wall of the agarnase. Beak is the anterior-most limit. If you follow the beak and stay between the limits, you are always safe. Let me show something more. Here. This is my medial limit. This is my lateral limit. You see the orbit there. I have shown you already.
Yeah, we can see.
Now give me the marrow cell, my magic, to control this little bit of the oozing so that I can show you better how to exactly enter into the frontal sinus. 120. Exactly keeping all the limits together. If you stay within the limits, you can certainly avoid complications. If I breach my lateral limit, the lamina papracia, I would be in orbit. If I breach my medial limit, middle turbinate, I will breach the skull base. If I keep my bulla intact, see this bulla? This is going up to the skull base. See this bulla? As long as bulla is there, my anterioethmoidal artery is almost always covered by this. Now see the beak is coming into the picture. Can you see? Now, here, let me show you my limits. This is my medial limit, you can see? Can you?
Yeah.
This is my lateral limit, you can see? See this?
Very clear.
That is lamina. That is lamina. And see anteriorly, that is the beak. That is the beak. And see, I am staying between my medial and lateral limits. Can you see very clear?
Yeah, very clear.
And I cannot go anywhere but the frontal sinus. See this? This is beak, thick beak.
Yeah, very big.
This is beak. So I am staying between the lateral and the medial limit. This is my beak which I am following, and where the beak ends is the frontal sinus. See my frontal sinus up there?
Yeah, beautiful.
Yeah. See the frontal sinus? What I did initially, again let me show you, this is the most important point for the junior colleagues wanting to do the frontal sinus surgery to settle their fears. Using 70 degree, number one. Number two, keeping three landmarks in view. Again, number one, the medial limit, keep the middle turbinate in view all the time, you can see. The lateral limit, keep the lamina in view all the time. And posteriorly, this is the bulla, which is kept intact to protect the anterioethmoidal artery, which runs behind the bulla. I will show you once I remove the bulla, where the artery is moving. And now, in between these three landmarks, see this?
Yeah.
This is your beak. I'm following the beak between my lateral and medial limits. Follow the beak in the middle, and where the beak ends is your frontal sinus. Okay?
Yeah, very clear.
Now, once you do the frontal sinus work, you have to do a complete work. The reason is the resultant stenosis in the frontal sinus region is more troublesome. And you see the recent international frontal sinus cell classification, the resultant stenosis, neosteogenesis, fibrosis, closing the frontal sinus outflow is the most difficult, grade 5 to treat. So once you treat the frontal sinus, you have to do a complete job. What we do always is a draft 2A. If, like Professor Eldostem said, you have to work in the frontal recess, then it is type 1. When you work at the frontal sinus ostium, that is 2A. See a lot of polypoidal issues inside. Now, out of all these 4 limits, from here if you see, the safest one is the anterior one. Medially the danger, the skull base, laterally the orbit, posteriorly skull base, and here anteriorly is absolutely free of any critical areas. And that's how the draft has introduced the concept of expanded approaches in the frontal sinus, wherein you remove the more and more anterior wall. See what I'm using here is my punch to show you how you can enlarge it anteriorly very, very safely. This is because this patient has a massive disease. I really want to give a big opening to introduce more and more topical steroids in the post-op period. So
Satish,
here,
very good work, excellent. And I want to just emphasize on the point that all this surgery, you have managed to open the frontal recess so wide, despite keeping the bulla intact. Now, keeping the bulla intact has prevented you from injuring the anterior ethmoidal artery and the skull base. That is a very important point to me.
Yeah, that's what we learned from you, Chief. See now, I am just giving an irrigation. See, there's a lot of mucopus. Still, this opening is not complete. I will show you how much frontal sinus work I need to do in every case. We have standardized here to widen it to the limits. Earlier, people would calculate in terms of millimeters and centimeters. That is, frontal sinus opening should be at least 7 millimeter, 10 millimeter, 15 millimeter. It is all bullshit. You have to enlarge it to the limit depending upon the anatomy of the frontal in that particular patient. And if you reach to the limits and remove all cellular septas, it will not bridge the mucosa to block the frontal recess again. So widen to the limit, whatsoever size is going to be adequate for that particular patient, and then irrigate with the solution. Now still my posterior limit is not widened. Can you see this? Anteriorly, laterally, medially I have reached.
Yeah.
What I'm going to do now for posterior limit is equally important. See a lot of polypoidal disease inside the frontal. A lot of polyps. See this? I'm just doing a surface debridement.
So can you tell us, for the benefit of youngsters, how do we identify that this is actually the frontal sinus with regards to scalloping and color?
Having done this in the entire work of the frontal so far, we haven't bothered about the anterior ethmoidal artery. The reason is our bulla is taking care of it. Yeah. As long as your bulla is extending to the skull base, as long as you keep it intact, your ethmoidal artery is taken care of automatically. So now I will show you how this bulla was protecting the ethmoidal artery. And I will see, yes boss.
Yeah, Dr. Deepak Dalmi is asking, what are the indication of doing work in frontal recess area in polypoidal cases, normal polypoidal cases?
In
normal polypoidal cases, when you do intervention in frontal recess area or frontal sinus area?
Yes, we do, depending upon the disease profile. I just said, in this particular patient, who is highly eosinophilic disease, with so much of inflammatory load there, our goal is to ensure that topical should reach in abundance to the frontal sinus. I intend to make a wider and wider opening. I still make wider, but not in every case, depending upon the situation, depending upon the inflammatory load. Now this is bulla. Still I am with a 70 degree. See this? I am behind the bulla. See this?
Yes,
see this space behind the bulla?
Yes.
I will use my debrider so that I don't avulge anything. here. See, I am going behind the bulla, pushing the bulla on one side, just to give you an idea where exactly the skull base is. See the glimpse of the skull base behind?
Yeah.
See the glimpse of the skull base there?
Yes,
and can you see the artery behind?
Yeah, very clearly. Very clear.
artery.
See how it was protected by the bulla.
Aldo, would you like to make a comment on the intact bulla technique? I think we started it together, 1997. Are you still practicing?
It was a long time ago.
Yes.
yes. Dr. Satish mentioned one very important point in this technique of the bulla. Is the bulla preserve the skull base and the bulla preserve the anterior timoral artery. So you can see anterior timoral artery after remove the bulla, especially the anterior portion of the bulla. And not only the skull base, but protect the orbit as well. So for me, bulla is one of the most important anatomical landmark for operation of the frontal recess. No question about. And I learned it from my great friend, Professor Seti. Thank you, Seti, again.
I was waiting for you to say that.
So, boss, see the mucosal preservation. That is most important thing.
Yeah, that is the key. That's the key.
And this microdebrider is the tool for me. I am so used to it. It's the key thing in mucosal preservation for me. See now the entire skull base, the anterior model skull base.
Yeah.
Absolutely clear.
Yes.
Now give me the reverse one.
See, the only way to protect the anterior ethmoidal artery is to identify it.
Yes.
You have to identify it in every single case so that you can keep away from it.
Positive identification.
And not to discover it, that you accidentally come across it.
Boss, can you see what blade is this?
It looks like adenoid blade.
Adenoid blade.
Yeah.
This is so-called adenoid blade, but I call it as a skull-based blade. See now why? When I use with a 70 degree, it becomes front-facing. Can you see this?
Yeah, very clearly.
He's using the adenoid blade for the posterior table.
Yes, this is the blade for the skull base. I call it as a skull-based blade, as it becomes front-facing while using with a 70 degree. See this? The entire work of the skull base can be done so safely. The cutting edges are in view away from the skull base, and you can really carry out very, very safely under vision. So this is my work for the anterior model skull base. See the frontal sinus therein. I will do something more there. And there is a cell above that is a fovea, and then is the artery, and then behind is the skull base again. And see, again, the same thing, what we started in the beginning about the concept. This is your medial limit, the turbinate. This is your lateral limit. Stay in the middle. Follow the beak. Remember now, follow the beak. Where the beak is the frontal. And see when you're working with a 70 degree, when you're working with a 70 degree up anteriorly, your ethmoidal artery is left behind. It is miles away. On far posteriorly, there's no question of damaging that. And more than that, it is covered by the bulla ethmoidalis. So that's how you can carry out your work in a very, very safe manner. In sinus surgery, the goal is not only to accomplish the surgical part, at the same time is to avoid complications. And like Professor Satish said, at every point, you need to take one or other landmark in view. One more point.
You use this saline irrigation. Exactly what is it? This is normal saline or it's warm saline?
Ringer lactate. I have almost given up the normal saline now. As it has been proven that ringer lactate is more physiological than saline, as it contains additionally the potassium and the lactates. Number one. Number two, repeated irrigations keeps your surgical field good, remove the mucus also, and makes your life
You put any antibiotic in this or anything in the solution?
Not at all. Nothing. And for that matter, as you asked this question, is sinus disease overall? There's hardly any role of antibiotics.
That's what I'm asking.
This is not infective disease for everyone. This is inflammatory disease. And this is what the work been done in last 2 decades. Less on the surgical technique, more on understanding this disease. See, some visible polyps with polypoidal mucosa 120. I am going to debride just to reduce the inflammatory load in the safest manner. Though when this mucociliary clearance establishes, then the steroids start going inside, this is going to revert back to normal, but I will still remove some visible polyps to make my life, the life of the patient better in the immediate post-op period. Can you see this?
Yeah.
You don't
I want to
have
ask
to be, you
I want
don't
to
have
ask
to be, you don't have to be very, very aggressive about the polyps. You don't have to be very aggressive about removal of the mucosa. See, everywhere, almost everywhere, the mucosa is being preserved.
Yeah.
This is functional endoscopic sinus surgery, FESS, where the mucosa is going to serve the function. If you remove the mucosa, it will no longer be a FESS, it will be mess.
Yeah. Can I ask one question to Kirtane sir? We have seen him, his journey from using and doing surgery without debrider, and now he's using. So what is your experience in the last 30 years of doing FESS without debrider, then new instrument, now the best quality of debrider? So your suggestions, sir, your points, sir.
I think what he summed it up in one sentence. It's all about preserving the mucosa, and when we didn't have these instruments, mucosa preservation was not easy. First, we were doing it with just ordinary forceps, then we used the through cuts. But the one point I would like to make over here, what Satish demonstrated very well, he was debriding inside the frontal sinus, deep inside. But at every possible time, the tip of the blade was under vision. I think it's extremely important wherever you're debriding, whatever instrument you're using, the tip, there should be no blind, just pushing the instrument inside and debriding. Cutting instruments at every point of time should be under vision. And he showed it beautifully with the 70-degree looking deep inside the frontal, but you could see the tip all the time. That's a point to be noted. You will not cause complications if you keep the tip under vision.
Yes, sir. Thank you, sir.
Thank you, sir. And now I'm back with a 0 degree. And what I'm doing is removing the remnant of the lower part of the bulla. Here, like Professor Sethi mentioned about the positive identification of the anterethmoidal artery, I would like to emphasize one more point. For the people who have a fear of damaging the vessel in terms of positive identification, while changing the vessel, I tell you a simple point. See, this is the vessel there with the 0 degree now.
Yeah, very clear.
Now, the fear of this vessel is where the fear is existing about the vessel on either side. If you are working laterally close to the exit from the orbit, where the vessel exits the orbit, if this vessel is transected, can lead to orbital hematoma. That is one of the most feared complications. And another fear is medially where it pierces the lateral lamella. Because there, if you injure the vessel, that injury is good enough to injure the lateral lamella as well and give a CSF leak. So now knowing this fact, what you can do while chasing for the vessel, if you really are looking for positive identification, and there is massive disease in this region, many a times there is massive disease here and you are not able to identify the vessel. My suggestion is identify your medial and lateral limit. See this? Yeah. This is your lateral and medial limit. Stay in the course in the midline and look for the vessel. Even if you happen to damage the vessel, puncture the vessel, there is no fear. Bleeding is hardly a issue in this, anterethmoidal artery injury. This is such a small vessel having a diameter of less than a millimeter. You pack with a marrow cell, surgery cell, gel form for a minute and it stops. Bleeding is rarely an issue. You can use a bipolar. But if you happen to injure on either side, laterally or medially, can be a big issue. So in those situations, difficult situation, if you are not able to identify the vessel, start finding in the center of your limit so that you don't end up giving a major complication. That is something, an important point in case required to do that. Okay?
Yes.
Now, having done this, the anterior work, we have done the anterethmoidectomy, we have done the middle meatal enterostomy, and we have done the frontal sinus work. The next work is the most important part of the sinus surgery before we move on to the next case, and that is the posterior-ethmoidal and the sphenoidal work, and which is the major source of graded complications of sinus surgery.
Yeah, that's true.
When we talk of complication, we must refer to the Stankovic article, which is the person who has most extensively described the complications. His own complication, his own the learning curve, he described very honestly in his first publication. in 89 or something, his complication rate was 28%. 20 years down the line, his own publication quoting less than 1%. This is how the learning curve, how the experience counts. So the idea is to stick to the landmarks, identify landmarks, and here I will show you our own experience, how to minimize the complications in the posterior part, because now where we are going is the source of major complication. And the same thing, Mosher mentioned 100 years back, the easiest way to kill a patient is a ethmoidectomy, because behind are the important structures, including the carotid artery. So now, for the rest of the work, now my landmarks are, number one, this middle turbinate, this is, we all know, is the first part. There is a concha in it, which I have not dealt with yet. This turbinate is turning laterally to insert on the lamina. Can you see this?
Yeah, very clear.
This is the second part lying in the coronal plane. The first part in the sagittal plane, second in the coronal plane, and third in the axial plane here. So this ground lamella divides the cavity into two anatomical as well as functional planes. The cells anterior to it are draining anteriorly, and the cells behind it are draining behind. That is a very important distinction, because on that concept only we are working, what Master Klinger introduced that time. The drainage system of the sinuses we need to know and understand and facilitate with the sinus surgery. So, in order to go behind this, to enter into the post-ethmoid, number one, now the safety concern starts. For me, for junior colleagues, number one safety concern, take this roof of the maxillary sinus. See this? We call it as a maxillary line, as a life-saving landmark. I will show you, tell you why it is life-saving landmark. So taking this roof of the maxillary sinus as a landmark and drawing a line close to the first part of the turbinate into the ground lamella. I am entering into it, gently I am entering into it with the microdebrider only, into the ground lamella. See now what happens at this point. The post-ethmoidal cells are larger cells. See now I am entering into it.
Very clear.
Now at this point I will stay more medially and see something coming into the picture. Can you see something?
Superior turbinate?
Yes, this is superior turbinate. Can you see?
Superior.
And some polyps in the recess. See now the superior turbinate coming? What I am trying to show, I don't intend to dissect the post-ethmoid at this point of time. The only fear is, if I keep on dissecting the post-ethmoids, I may not know when I enter the sphenoid sinus and I end up damaging the critical neurovascular structures there. So I need to develop some checkpoint, some safety point. So what I am trying to show here is, this is what we have been propagating for years and done thousands of cases with this technique. So when you enter the post-ethmoid, the first thing you need to go medially and find the superior turbinate. See that? And medial to the superior turbinate. What do you see? Yes, sir? Now medial to the superior turbinate, what is this? This is the nasal septum.
Septum, very clearly.
You see? Now I am removing the lower third of the superior turbinate without any issues. Now at this point, I will take into consideration again the maxillary line. See this? At the level of the maxillary line, medial to the superior turbinate, medial to the superior turbinate and flush with the septum. See where I went? Can you see?
Sphenoid ostium.
Sphenoid ostium. I was supposed to do the post-ethmoidectomy, and ready I am doing a sphenoidotomy. There is a reason behind it. To enhance your safety, I am trying to develop a landmark. Let me show you. Once I set out this mucin. The first important thing, see the easiest way to enter the sphenoid sinus for the junior colleagues and the safest way. The reason is, number one, the easiest, go medial to the superior turbinate and go flush the septum. That is most important. Not flushing the superior turbinate, but flushing the septum. Always flushing the septum like this, okay? And this level is important, the maxillary line. The reason being, if I don't consider this as a landmark and keep on going little high up, what is going to happen? See this? this sphenoid sinus ostium is never at the level of the floor. This is quite high up in the sphenoid sinus. So suppose I don't take this maxillary line into consideration and try to enter the sphenoid sinus high up, I may end up damaging the plenum sphenoidal, and that is a disaster. That's why I call this maxillary line as a life-saving line, number one. Number two, once you have opened the sphenoid sinus ostium, this is a great landmark for me. I have not completed the post-sigmoidectomy and don't intend to unless I define my landmarks for behind. So what I am doing now, further removing the lower 1/3 of the superior turbinate to widen the sphenoid ostium. Can you see now? Much better?
Yeah, we can see it.
Now this is the amazing landmark I have got, the sphenoid ostium. The reason is, now I will accomplish my post-sigmoidectomy keeping this as my posterior limit. I will do my post-sigmoidectomy without any fear until I reach the level of the sphenoid ostium.
Yes.
My carotid artery, optic nerve, however abnormal they are never going to come anterior to the level of the sphenoid ostium. And see now, I can accomplish my post-sigmoidectomy with much more safety, much more confidence. Now see, in no time, I can accomplish my post-sigmoidectomy.
Yeah, very clear.
The only thing I need to keep in mind is the level of the sphenoid ostium. So that is to enhance the safety. Now, whatsoever the situation is, maybe ONOD or anything, as long as I don't cross the limit of the sphenoid ostium, that is not going to come behind. Okay? If I don't take this into consideration, imagine, if I don't take into consideration all this thing and keep on doing a post-sigmoidectomy, if there is ONOD or something, I keep going behind, I may happen to damage the optic nerve any time. ONOD is very common. In our country, the incidence is less than what is there in Singapore. I hope Dr. Sethi will agree with me. The incidence of ONOD is very high in Singapore in Chinese population.
It's almost 65%. So we treat every patient as if they have ONOD cell.
So for them, every patient is an ONOD cell-like. They have to assume it until proved otherwise. So now see, this is the skull base. You have seen the anterethmoidal artery above.
Yeah, we can see posterior.
Now see behind, this is the post-sigmoidal artery, which is quite prominent. It's unusual. It's not very usual to see the post-sigmoidal artery so prominent. The reason being, these ethmoidal arteries traverse through the thickness of the skull base, and the anterethmoidal skull base being relatively thinner, they are relatively prominent. Post-sigmoidal skull base relatively thicker. So generally we don't generally see the post-sigmoidal artery traversing there.
Satish sir.
Yes,
Sandeep.
For the benefit of the juniors, which is more.
Some disturbance is there. Dr. Sandeep is asking, what are indications of doing septal correction in before going for FESS? When you do the septal correction, or where you do in starting or doing after doing the FESS surgery?
Yes, that's an important question. For that matter, I tell you, in my opinion, in my practice, almost every case needs some sort of septal and turbinate correction, and that is a part of the surgery. The reason is, nowadays the goal of sinus surgery has more and more changed. The goal of sinus surgery more and more is to give access to the topical medications, reaching deep inside the sinuses. So if this septum, if it is deviated, it may not allow the solutions to reach so effectively directly into the sinuses, number one. Number two, if my suppose septum is deviated, if I decongest the nose and try to get space and work through the deviated nose, you can accomplish surgery. But what will happen? By means of traumatizing the opposing surfaces, you will end up giving synechia to the patient, and that will defeat the purpose of entire surgery. It will not allow the solution to reach inside. So better to correct the septum if it is deviated. Better to correct the turbinate. See, this turbinate, I am waiting the entire work to do before I do something to this turbinate. I'll do something to this turbinate at the end of the surgery. Why not in the beginning? Because in the beginning I wanted to utilize this as a sole landmark for many regions.
Rajiv,
Yes.
Aldo Stam has been locked out again from his video. Could you just...
Dinesh, please do something.
Yeah, we'll see.
So now we reach the post-ethmoids. Okay? We have done the post-ethmoidectomy. See our limits of post-ethmoidectomy, laterally the orbit and medially the superior turbinate, the remnant of the superior turbinate. Okay? Now going behind is the sphenoid sinus and there is a lot of polypoidal mucosa. Now, the standard teaching is you are not supposed to do any sharp instrumentation inside the sphenoid unless you are very sure about it, unless you are very experienced to relate the landmarks three-dimensionally. See what I'm doing? Under the close-up, I'm widening the sphenoid ostium so as to ensure my topicals would reach inside effectively. And this sinus also contains a lot of eosinophilic disease, wanting steroid 40. See this?
Yeah.
See, this is how preserve the mucosa everywhere. The goal is to preserve mucosa every point of time. I'm using the red 40 with keeping the blades towards me to avoid any injury to the vital structures. See this? This is something I don't recommend to the junior people to do. Don't do if you are not very sure where you are exactly working. So now,
can I make a comment?
Yes, please.
Yeah, Professor Aldo Stam has to leave for
Argentina.
For so, and he is giving a lecture to Argentina, I believe.
Yes, I remember. He told me that
promised that he'll come back.
Sometime.
He's promised that he'll come back. So Aldo, before you go, if you'd like to make a comment, that would be
Yeah, just a short comment. I agree completely with Satish regarding the posterior ethmoid cells. It's absolutely essential to identify first the sphenoid sinus before the posterior ethmoid, because many times the people make a mistake between the posterior ethmoid cell with the sphenoid sinus. So I agree completely with his technique. First, identify the ostium and the sphenoid, and then back to remove completely the posterior ethmoid cells and identify the skull base, of course. So it's really good. I appreciate a lot, Satish. Your technique was fantastic.
Thank you,
I really enjoy a lot, and I learn a lot. And I will be back, I promise.
Yeah. Thank you so much. Thank you for sparing your time.
Come back to Argentina, Aldo.
Yeah.
Bring Argentina.
Congratulations. I will inform the Argentinian people about this meeting. So, and then I give the instruction. Thank you very much. I'll see you later.
Thank you. Thank you so much.
Bye-bye.
We'll do for you, sir.
I'll be back.
Thank you.
I'll be back.
We'll wait for you, sir.
Yeah, thank you.
Okay. So this is about the sinus surgery. The last thing I need to do is something to the turbinate. Now I have number of options. Number one, already. I have number of options. Number one, to do some bolgerization, but I have some cell and the disease inside the cell which I can't leave like this. Second thing is, after we said the bolgerization, is partial resection. Now, in this eosinophilic disease, where you need to introduce your topicals very efficiently into the sinuses in the post-op, this turbinate can be a big hindrance, particularly this floppy with the this thing, concha. Yeah. My first choice would be to do a partial resection, keeping the upper part of the turbinate intact. See this?
Yeah.
This is something works very well. I'm seeing the literature which support this. This is a very good strategy in the massive eosinophilic disease patients. See now, the turbinate never come in your way in either irrigations reaching to the sinuses, number one. Number two, this is something which will promote your irrigation reaching everywhere, and this will no longer be a hindrance. We utilize the turbinate as a landmark, and in case, in future as well, we have left the stump of the turbinate above as a landmark. Can you see that? We have not completely chopped it. Can you see?
People have started using this turbinectomy in all the cases. Do you recommend it?
Not all the cases. If required, if unstable concha, particularly in the massive eosinophilic disease, not in all, wherein your irrigation should not be, hindered reaching to the depth of the sinuses. That is the indication. And massive eosinophilic disease, this is one of the strategies now to partially resect the turbinate so that it doesn't bother hindering the solution reaching. So this is about sinus surgery on this side.
Basic, yeah.
Any questions? We'll take the complications later on. This is what we discussed in last 2 webinars. The goal of sinus surgery, in the first one, the indication, and this case, the indication was very obvious. With massive inflammatory load requiring oral steroids again and again to control the symptom was key indication for the sinus surgery in this particular patient. Now, we have opened all sinuses and now our irrigation will take care of everything. So post-op also, the topical steroid will give for some time and steroid irrigation will start day after. And hardly any role of antibiotics. You can give a broad spectrum for 5-7 days, otherwise no role of antibiotics. And obviously the post-op debridement and other thing we'll discuss later are the important part of the post-operative management. Follow-up and everything is important. So any question or we move on to the next case is already ready, that is inverted papilloma.
In this case,
Satish, can I just make a comment here?
Yes, sir. Yes, please, sir.
I think what you demonstrated beautifully, that you went for the sphenoid first. I think one thing to do is to widen the ostium of the sphenoid quite generously and go right up so that you identify the skull base already in the roof of the sphenoid. So then when you come forward, removing the posterior ethmoidal cells, you have a very clear indication as to the level of the skull base. So when you have a lot of polyposis there, going into the sphenoid, going upwards, removing the anterior wall to identify the roof, I think that becomes a very safe way of then tackling the posterior ethmoidal cells and taking them off the skull base. So getting that landmark is important.
Yes, sir. Hello, sir.
Yes.
Jain, sir. I have not taken any questions till now, and there are many questions which I'm loaded with. Can you just answer all of them quickly before we
please.
to the next?
Please go ahead.
Yes, sir. So, sir, actually, yes, sir. What is your technique for hypertrophic inferior turbinate? Dr. Ramesh Kapoor from Muscat wants to know this.
Okay, for the hypertrophic inferior turbinate, first of all, it depends upon what hypertrophy it is. It is a soft tissue hypertrophy or bony hypertrophy. For bony hypertrophy, we have two procedures. One is the submucosal turbinate resection, or we do a partial turbinectomy with an edge of mucosa along with. That's it. And that works very well. For the soft tissue hypertrophy, where patients are mostly allergic, we do either a submucosal debridement along with a posterior nasal neurectomy. That is the neural supply to this turbinate tissue. That's a postganglionic supply to the turbinate tissue along with a partial turbinoplasty with a micro debrider, or even cobblator inside the mucosa, submucosal, and that works very well for the mucosal hypertrophy of the turbinate.
Okay, sir. Sir, Dr. Pranita from Warangal wants to know, is it advisable to open all the sinuses irrespective of the disease, or should we just open the disease side?
It was, you see the pre-op CT, it was complete whiteout. It was complete whiteout. Why? What you found less disease is because of the pre-operative preparation. The polyps have shrunken, the disease the load has come down because of the preparation, and that made us do so bloodless. See, the field was so good only because of that preparation, and that is very important in terms of giving us opportunity for more complete work at the same time avoiding complications.
Okay, sir. Sir, when do you decide to excise the middle meatus, the middle turbinate? I mean, when?
Like I mentioned.
Okay, so can you repeat it once again, because many are asking the same question again. Hello, Satish Jain, sir? Hello?
Sir is there. Yes, sir. What's your protocol on post-op care after surgery, sir? Sir can give us the answer? Means after the surgery, what's your protocol, sir? After this, you pack the nose in FESS case, normal FESS cases, or what's your protocol in post-operative care?
No, if like what you saw just now, I don't think there is any need for packing at all.
Okay.
And post-operatively, we would call the patient. You need to do a little bit of cleaning. Sometimes there are blood clots that you find, so fibrous adhesions. You just want to make sure that you clear that out. And then after about a week or 10 days, we would start them off on nasal rinsing and the nasal steroid sprays. But doing a cleaning once or twice as required is important to prevent blood clots from remaining there. And especially if you've created some raw area, then that is important to make sure that you clear it out. Otherwise, you're likely to get adhesions.
So we used to do lots of vulgarization in all these cases, or suturing also. So
if you feel that you have destabilized the turbinate a little bit, if you feel that it's a little floppy, then it would be a good idea. I normally just take a stitch through the turbinate to hold it. If the turbinate is as stable as he has put it over there, there was no movement of the turbinate, then you may not have to. But we will vulgarize it if you felt that the turbinate was a little unstable.
Okay. Paramita, you asking?
I want to know what about the anterior ethmoidal artery bleeding from Dr. Sethi as well as from Dr. Kepane, sir. We want to know how will you manage if there is a bleeding with the anterior ethmoidal arteries?
Sethi, would you like to take that?
Hello?
Yeah, yes.
Am I audible, boss?
Wait, Dr. Sethi is giving some answer. Yeah.
Yes, sure. I think most of the times, I don't think we completely transect the artery. And most of the times, either a little bit of oozing from there, or if it's a partial tear in the artery. I've never come across someone who completely transects the artery and it retracts inside the orbit. At least I haven't seen it. So when you partially transect it and there is bleeding, the first thing to do is, of course, to recognize it, that it's happened, and not start panicking. Just keep your cool and pack it. Pack it with maybe with epinephrine, either diluted or in 1 in 1,000. Hold the pack, hold your breath, and then get hold of a bipolar. Get a bipolar, and then very gently, by the time you have got your bipolar and you have packed for a few minutes, you'll find the artery constricts and the bleeding, although it doesn't stop completely, but becomes less. And you are able to identify the tear in the artery, and then bipolar it. And once you bipolar, you'll find the bleeding will stop. And all this will take barely about 3-4 minutes. And if you don't panic, if you panic, then of course it can take much longer. The important thing here is not to use a monopolar. And I had one instance where someone used a monopolar and it trying to stop the bleeding caused a CSF leak by causing a defect in the lateral lamella. So in trying to control one problem, he had another problem. So important thing is not to use monopolar, but bipolar to stop the bleeding. So that's how I would do it. But if there is let's say a complete tear, it never happened to me, and the artery retracts back inside the orbit, and you develop an orbital hematoma, that's a completely different ballgame, and I think we'll talk about that a little later. Even worse situation is, I haven't had it myself, but I have one case that a colleague of mine in US encountered it. Not his case, but it was transferred to his facility. Professor Scott Graham lent me that case, and the artery actually retracted inside the brain. And they didn't find out about it till the next day when the patient was unconscious, and then the CT scan, and the artery had retracted inside and with profuse hemorrhage in the anterior cranial fossa, and that patient required a craniotomy.
So that's a message, that once you are dealing at the level of the skull base with the vessels, you have to be careful so as not to allow them to retract inside the cranial cavity.
Absolutely.
That can be a disaster. Yes, and we have a case today. Meningoencephalocele will emphasize that particular point, because in that surgery also, the vessels coming down through the meningoencephalocele can be the source of problem if not taken care of. So, can we move on to the next case, or any further questions?
Oh, sir, there is few more. We need to know about the balloon sinuplasty. Do you do it for frontal sinus?
Not really. I gave my opinion about the balloon. In brief, it cannot replace the sinus surgery, number one. It is not a scientific answer to the problem. We discussed 4 hours first day about understanding the disease. The goal of surgery is redefined. This surgery is not a mechanical. You can't tell your patient that I'll remove your polyps, I'll operate and you'll be all right. It is a medical disease for which the medical treatment begins after that. That facilitates the medical treatment. By means of enlarging some sinus little bit, by breaking the septation a little bit to drain the sinus is not the answer for the future. So that cannot work, and majority of such patients are coming back with the problem. I tell you, that's why this has gone to disrepute at majority of the centers. The cost along with I'm not discussing, but even the basic fundamental is something which is never so appealing. But it has certain indications. In my practice, if you ask me, for pediatric patients having isolated sinusitis like empyema in the maxillary sinus, sometime you can use the balloon with the minimal trauma in the region, because the pediatric patient are not going to do any douching like adult patient post-operatively very judiciously. In immunocompromised patient with some isolated sinusitis to drain, like HIV patient, you can use balloon. In post-operative situations, sometimes some sinus is bothering, which has gone, stenosing, you can use balloon to time being deal with that. Otherwise, as a standard practice, it has no role in my practice, as a standard rule.
Yes, Satish, I think that's a very important point, understanding the pathology, understanding the disease that you are dealing with. And that is actually an evolutionary process, because we keep on learning more and more things about the disease, and we keep on basically changing our techniques of dealing with the surgery at the same time. So you've got to keep up to date with the literature if you have to understand, if you want to understand the disease.
Sir, Kirtner sir would like to have your opinion as well on the balloon. If you are using...
No, I was never very fond of it. I don't think I subscribe to that idea. But Satish, I think the comment that you made is very important here, that we are treating a medical disease. So the surgical treatment is not to cure the disease, it's the starting point of the medical treatment. And I think the ultimate answer to this problem is going to come from the medicine guys. Surgery is just the facilitation of reaching the medicine to the site. And of course, when the patient is obstructed, to give him symptomatic relief.
Absolutely, sir. Absolutely. Paramita, any more?
Sir,
Next case is ready. That is inverted papilloma. All set. Induce. Absolutely ready. And I am all set with the radiology. If you have any quick questions, we can.
One question, very good question from Dr. Leena Jain. What is the best approach to deal with isolated posterior ethmoidal sinus disease?
Isolated posterior ethmoidal disease.
Yeah.
See, isolated single sinus disease most often is a mycetoma. Most often. Is a maybe sphenoid sinus, maxillary sinus, even posterior ethmoid is mycetoma. And mycetoma is one aspect of the fungal disease where fungus is not initiating any immune reaction of the patient. It is just collecting and increasing and obstructing the sinus, the drainage. That's it. And you have to remove that isolated fungus. It is not any part of any systemic disease, so you don't need to treat all sinuses. You just go there, open up that sinuses, remove the antigen, that is fungus, remove that and establish the ventilation drainage. That's it. The minimal, that is something where the role of minimal sinus surgery stands.
So what if the uncinate process attached to the skull base? What different technique?
Yes, that's important. And for that, you need to go first to the radiology pre-op very well to understand where the uncinate is going by three-dimensional radiology. And if it is going to the turbinate and the skull base, like I removed the uncinate today with a micro debrider, sometime I fracture with a curate, go behind and fracture it entirely. You can't afford to do that. In that situation, it is best to use a through biting to bite through the uncinate to separate it from the critical areas and then make your openings better, rather than pulling it out or doing anything else.
Okay, sir. Okay, sir. So before you start with the next case, can you just show us externally your setup? Because in this COVID situation, they all want to know what precautions are you taking. There are many ENTs who want to know.
Okay.
Almost
I was about to show in the last case, but we went along with the discussion, so I couldn't. In the next case, I will show it properly. Okay, definitely.
Okay, sir, before we start the next case, to once again tell us the exact adrenaline concentration along with the lignocaine that you use, there have been many doubts on this again.
Okay, I will tell in every case because that is different in every case. The last case it was 1:2 being a young patient. The next case papilloma is again young. In all cases I am not going to infiltrate anyway, and I am going to use the adrenaline, younger, more and more concentrated, only topical. So coming to the next case, can you switch on to the radiology, Dinesh? So this is a classical example of what we discussed the role of radiology in the last meeting, last webinar, how it can change the management. This patient presented somewhere with a polypoidal mass in the nasal cavity on one side, and there they did a non-contrast scan and posted that case for the sinus surgery. That was the real story. And this is the CT scan, the non-contrast CT scan of this patient. Let me reconstruct to all three planes for you. Yes. And see the picture, what we are having here. Can you see this?
Yeah. Very clear.
See this maxillary, isolated maxillary sinus disease kind of a thing. And if I show you a better picture, see this. Something I told you that day you have to be suspicious of in life when you look at the CT scan. This is non-contrast because looking at the polyps in the nose, we always order non-contrast. But see something giving me suspicion. Can you see this bony? Hypertrophy, some hyperosteosis, bony projection, some osteolysis. All these are good enough to give you suspicion that this could be something else. Next thing is, see where the osteomeatal region is completely something ballooning out. Can you see? This is
very clear.
which was giving me suspicion. Gaurav, look at this. We discussed that day. So these two things were good enough to give me suspicion. So I ordered an MRI. This patient came to me. I said, boss, I have some doubts and really I want some more information. So I ordered an MRI. Now see, with this MRI, this is mesmerizing. First of all, I will show you the T2 weighted image. Can you see something?
Same like last discussed with that case.
Yes. Can you see something?
Yeah, converse CBC pattern.
On T2 weighted, this hypodense is the lesion and whatever surrounding hyperintense is the secretion, hypertrophic mucosa, inflammation. And this is on T2 weighted, this hypodensity is not inflammation. This is a tumor. And to add on to this, let me put up the contrast image together. So once I put up the contrast together, now you see. What can be this? Yeah, this is T2 again. Let me put up the no. I will put up the contrast, sir. Contrast is important. Yes, this is contrast. Now see the difference in the image on the contrast and T2. Something is enhancing, which is not enhancing, not hyperintense on T2. This is the secretion all around, not enhancing. So this is definitely not a simple polyposis. Can you see? Now, more than that, I have something like giving me a clue of CCP. Can you see here?
Yeah, very clear.
That is giving me a suspicion of inverted papilloma. So I have a strong doubt this patient might be having inverted papilloma. The only thing which is worrying me, not making me very, very sure about it, is not being very enhancing on the contrast about the tumor part. Though it is enhancing, but not so much. Otherwise, I would have been very, very close to 100% on the diagnosis of inverted papilloma. But this is something very clear that this is not a simple polyposis. Number two, on endoscopy, those were not very smooth polyp kind of a thing. It is something like mulberry appearance with not very smooth surface on it. So that is definitely not a polyp. It looks like something is coming from the maxillary sinus floor on this side and then going towards the in the depth of the lesion, which is classically the inverted papilloma goes like. Now coming to the axial sections now. This is T2 axial section here, and see again, this is classical picture of a something like CCP. You will see here, the classical picture of a CCP. So let's explore this. This is not a simple polyposis, and let's see how it turns out to be. We have the diffusion image also, and on diffusion, this is hypodensity. There's restriction. Restriction is not in favor of sinusitis, is in favor of tumor. If it is too much of restriction, could be malignant. Otherwise, it is a benign tumor, and to me, it is most likely some benign situation which we are going to deal with very soon. So any questions? So how radiology is important, you can understand. Without having MRI, if somebody tries to explore it, keeping target of doing a sinus surgery in mind, he would definitely come to surprise. And that's how your surprises can be avoided by means of focusing more and more on radiology, and MRI is the answer in majority of these situations. Any questions?
Questions. So many questions are there. Pramita?
Oh, sir, they're asking, is there any malignant transformation seen in this case?
Not really. Had there been many malignant transmission, let me show you again to the T2. On to the T2. See this classical CCP, classical. That would have been lost had there been any malignant transformation. That is certainly not. This young guy will no other sign of bone destruction around. You could see the CT scan with no signs of destruction at all. You have to take both the CT and MRI together to get the complete information. If had there been any malignant transmission, there definitely would be some bone destruction, and the lesion would have been going beyond the confines of the paranasal sinuses. That can happen even in the benign, but that is because of the expansion. But in malignancy, it is true invasion and destruction going either coming anteriorly, laterally, or superiorly into the orbit. Something like that, which we have not observed. You see the very, very smooth appearance of the limits of the sinuses all around. Can you see?
Yeah, very clearly. Satish, would you recommend biopsy or MRI in such cases?
Would you do biopsy?
You would recommend biopsy or MRI in such cases? Because
yes, we always recommend a biopsy in case of doubt of a tumor to get histology, because this is the era of histology driven treatment of the paranasal sinus tumor, and there are a lot of good publication onto it to emphasize on it. So histology is very important.
What is the biopsy report? Yeah. What is the biopsy report in this case? Done on?
It was non-conclusive. See, on papillomas even, most of the time, your question is valid. The tumor is deep-seated and a polyp over it on the surface, which we see on endoscopy. Even if you take a surface biopsy, may not be able to pick up always. Now, more than that, if you take a deeper biopsy, sometimes from the sinus inside, you can pick up a papilloma, which you don't you are suspicious of that. More than that, if there is malignant transformation, that always starts in the depth. Even if you take good biopsies, multiple biopsies, you may not pick up that malignant transformation. That's why on doubt or in the depth, you always should take a good specimen for histology to rule out any malignancy. It's not that you rely on the pre-op histology and don't take a biopsy further to rule out malignancy intraoperatively.
The site of attachment on this case.
Hello? Yes, sir?
Satish, sorry, interrupting you. Have you arranged for a frozen section for this case?
Not really, because looking at a young age and not sign of having any malignancy, I didn't even think of that. But yes, you're right. Most of the time we do frozen section when you are in suspicion or when you are doing operating on tumors with even a smallest of doubt of malignancy. We always send for frozen section. Not only tumors, in invasive fungus also, we always take frozen section to prove it.
And in this case, I have a couple of comments coming from Venezuela on excellent demonstration for the surgery. So people are watching you in Venezuela.
Oh, thank you. It's all because of you, boss.
Well done, man.
Thank you. Do we
Have
go
you
ahead with
identified
surgical
the
part?
site of attachment in this tumor?
Yes, that's an important question. The second information which we can get out of this is something, see, coming from the lower part of the maxillary sinus to coming into the nasal cavity. Can you appreciate?
Yeah.
So what I believe, this is an attachment on the lower part of the maxillary sinus floor medially.
Yeah.
Or this is the turbinate, and this is the medial lateral to the turbinate in the inferior part of the maxillary sinus. What do you believe out of this MRI?
Yeah.
See, all this information you don't get on CT. CT scan is just opacity. You don't get any single information except the bony erosion out of CT scan.
What about the hyperostotic sign that you see at the point of attachment? Did you see that?
Yes. On CT scan, that's what I showed. That's what I showed in the beginning.
Okay.
If you see in the beginning on CT scan, let me show you again. That gave me suspicion. See this unusual bone formation. Can you see here?
Yeah, very clear.
Yeah.
Can you see this hyperostotic bone here, which you generally don't see on the turbinate? This is part of the turbinate, maybe inferior turbinate, got hypertrophied because of the tumor from this side. So this hyperosteosis gave me the suspicion. You can see this one.
Okay. Yeah.
I don't see any hyperosteosis on the lateral wall, superior wall, which are much common sites of attachment of the papilloma in general. So now this dictates your approach as well. There are 2 points to make. I will make 2 points over here, important points. Number one, having known the site of attachment information from the radiology, you can plan your surgical approach. Suppose it is attached to the medial wall. You don't need to do a Dankers and go far laterally onto the tumor. If it is laterally, suppose attaching to the lateral wall here, I would certainly go with the Dankers. So in any given situation, if I am not able to expose, go endoscopically with proper visualization to the 0-degree or angled scope to the site of attachment. I will not think twice before doing a Dankers. Number two, here our distinguish. How do we distinguish here in the favorable and non-favorable papillomas? Favorable are those papillomas where we can give a cure. Cure means the only thing which makes the difference is the removal of the disease from the underlying bone by means of drilling away the bone thoroughly. If you can drill away completely, if you can remove that attachment completely, you can give it a cure. We call them it as favorable. Now suppose if the tumor is attached to certain sites where you can't be so radical, like suppose it is attached to the sphenoid sinus posterior wall, you can't be so radical in removing that bone. That is unfavorable. Suppose if it is attached to the skull base, you can't be many a times so aggressive, but still I stay aggressive. In certain areas on the frontal sinus where you can't be so aggressive, those are unfavorable sites. So this is pure favorable situation of if it is an inverted papilloma for us. And let's go ahead and let's see whether we need any extended approach for this lesion or not.
Definitely.
If required, I will not think twice.
Yeah.
Any more questions?
We can answer questions when you're operating, I guess.
Okay, I'll take 3 minutes, 3-4 minutes to get ready for the case, to wash up. And meantime, you can take Paramita, you can direct question to Keetne sir, Satish sir and Gaurav.
Sure.
And I'll be back in next 5 minutes.
So there's a question from Afghanistan. Dr. Masum Jain wants to know how can you protect the nasolacrimal duct during the medial maxillectomy in case of inverted papilloma? Dr. Ketane sir or Dr. Satish sir, would you like to say answer this?
Can you repeat the question? I'm sorry, I didn't get you.
Protect the nasolacrimal duct during medial maxillectomy in inverted papilloma.
Sorry, I lost the picture there.
Okay.
No, all right. So it's basically sometimes you don't protect it, you have to transect it in doing a medial maxillectomy, all right? Depending on how extensive the tumor is. And if you're doing a medial maxillectomy, most of the times you will have to deal with the nasolacrimal duct. You'll have to identify it. And if you need a wide exposure, you'll have to transect it. The other way is to transect it and transposition it so that you can come into the anterior part of the maxillary sinus. So, and I don't see if you're doing medial maxillectomy, I don't think there is any need to protect it. In fact, you'll probably have to identify it and sacrifice it and do a formal DCR sometimes.
Okay, sir. Kirtane, sir, can you tell us how common is inverted papilloma in other sinuses than maxillary sinus is common? Hello?
Sorry, sir.
Kirtane, so the question is directed to you.
Yeah, I know. I mean, classically, they say you talk about the Schneiderian membrane is supposed to start from the maxillary sinus area over the inferior turbinate. But we have come across inverted papillomas going into the frontal sinus. We've had them in the ethmoid even. And I think if you have a recurrent inverted papilloma where somebody else has operated, then you're likely to find it coming from a variety of sites, probably where it has been implanted by the previous surgeon.
So I have a question. Have you ever encountered multifocal attachment for an inverted papilloma?
Sorry, I think, sorry.
Multifocal attachment.
Yes, that's what I said. You can get multifocal attachments, but that's more in revision cases. Very often we get cases which have been operated once, twice, thrice, and in these you get multifocal attachments much more common.
Okay.
Not so much in a primary tube.
Yeah.
Okay, so there are audiences who are asking what is CCP. So CCP is a cerebral convolution pattern, which he has discussed already in the previous webinar.
They should go for that the second series. Everything was well.
I would like to tell again to the audiences, the ones who have not yet watched the previous two webinars, it is still present in the YouTube. You can just type Dr. Satish Jain and with Dr. Rajiv Pachauri on chronic rhinosinusitis. So I think we are ready with the case.
One simple question from many people that Dr. Sethi sir and Dr. Kirtane sir, how will you approach this case? Means sub-level approach, or those who cannot do this endoscopic surgery, can they go with sub-level approach to remove this inverted papilloma since it attaches very laterally?
Well, I think that's what they used to do in the past, but the recurrence rate was quite high. And with endoscopic approach, I think you can do a much better clearance and look around the nicks and corners of the disease. In this particular case, the blind spot would be the lacrimal recess anterolaterally. So those are the areas that you cannot examine with the open approach. So I have no experience with actually open approaches. My training has always been as an endoscopic approach. But I suppose the tendency to leave behind tumor is much higher if you use an open approach in such cases.
Sir, your point, sir, Kirtane sir.
I couldn't get the question. I mean, I think my connection went off and it came back. What was the question?
Can we try this case with sub-level approach, or any open approach?
Hello.
Sub-level approach.
Sub-label.
Yeah.
Hello.
Yeah, Satish.
Can you hear me, boss?
Yeah, we can hear you very well. No problem.
Are you getting the picture?
Yeah, we are getting it.
So this is the left nasal cavity, and what you see is this polypoidal lesion. Can you see this?
Yeah, we can see very clearly.
It doesn't look like a simple polyp, first of all. Can you appreciate?
Yeah, very clear.
That is a reason for suspicion. Number two, that hyperosteosis on the CT scan and that kind of ballooning of this mass lesion out of the middle meatus region. Number three, on MRI T2 weighted was not a simple polyposis. The only thing which is again holding me back is the contrast image not showing very much of enhancement. that is something, a negative thing against the diagnosis of papilloma. So my second DD would be an inflamed polyp. So let's see. Let me start debriding first. See this?
Yeah, yeah.
I will just debride the luminal component first and get onto the lesion to get more anatomical detail, more sort of information about the extension. See, it is completely occupying the nasal cavity. So anyhow, it had to be removed.
Yeah, yeah.
Yeah, but Satish, I think this is a classical inverting papilloma.
Looks like
it's classical.
Yeah, that's what I think, but
let's see, I'm very wrong sometimes. But based on the look, as you can see, the appearance is changing now, becoming more fleshy.
Yeah, we have seen couple of such cases of the infected polyps. I don't know. So funny, but this should not be. This should be a tumor.
Yeah, I can see that its consistency is changing now.
Yeah, yeah, it is more firmer now.
Yeah.
More harder component coming.
I think it's more fleshy.
Yeah, more fleshy now.
So Satish sir, Dr. Deepak Dalmia wants to know that if the biopsy report is inconclusive, then and the attachment is either flawed, then why not sublabial approach or combined approach in place of endoscopy alone?
See, the question of sublabial or endoscopy depends upon the surgical expertise. No reason I cannot, in this given extension, there is no reason which I can't, address to the endoscopy. I can very well reach by the endoscope. Under more visualization, like Satish sir said, I can reach to the area as compared to sublabial. Sublabial was an approach which is now taken over by the endoscopy for its better visualization. And see this? This component is quite hard one. Can you see this?
Yes.
Yeah, yeah, very good.
And this, see, until now I didn't take a biopsy because it was quite superficial. There was no point. And now I will take this solid lesion for histopathology. See this?
For sure.
It's a big one. And I will take some more. See, nowadays we have started getting immunohistochemistry of papilloma. There are certain pathological signs by means of which you can predict the future possibility of malignant transformation. Those are histological criteria, including mitotic index. You can at least predict. You have some more information than nothing. Something like that. So here, now I will have much better space now to deal with. And I will follow it better and focus more and more on the middle meatus component. Let me finish off this luminal part. See, now the nasopharynx is clear?
Yeah, yeah.
Sir, I want to ask you, have you ever had to do a lateral rhinotomy for an inverted papilloma before?
See, in this era, no question.
Okay, so there hasn't been a tube.
The endoscopy, if you are well versed, you can reach all these areas. It's not that you are avoiding incision is the advantage, not at all. If some approach or some technique involving an external incision but giving a better outcome, I will certainly go for it without thinking twice. It's not the incision. That is the last thing to take into consideration.
Yeah.
It is the visualization that matters.
Yeah.
It offers brilliant visualization which cannot be otherwise possible with the open approach. Now see, I am not using Merocell much in this case, unlike sinus disease, because in sinus disease we are more concerned with the mucosa is immunocompromised. We are dealing with the immunocompromised situation and the impaired mucociliary clearance. Impaired mucociliary activity, which is not the case here.
9 we can make it. Yeah. Because initially
I am using ribbon gauges which are more effective.
We have you can join. You all can join between.
And see, that is the upper part of the
audio was not there when you introduced our. So you would like. So what time I will let you know. Once I will do, sir. I will send you a message.
Hello?
Yes, sir.
Yeah, yeah.
So here I'm using the ribbon gauges, unlike the sinus disease for the reasons I told you. Now this is the upper part of the uncinate. I'm seeing the frontal and other sinuses are absolutely perfect. See the other areas absolutely okay. So I don't need to go anywhere beyond that. Now focusing on this region, I've already cleared the nasopharynx, remove the luminal component so that I can focus more and more on the area of interest. So my area of interest is laterally inside the maxillary sinus now more and more. And then we'll decide whether I will be needing any expanded approach or not once I see the further course of the disease there. Now see the lumen. See the nasopharynx nasal cavity is absolutely perfect.
Yeah, yeah.
And I don't need to go further anywhere behind. It looks quite okay. Now give me 70 degree. First I will take the angled scope here, 70 degree to look into the maxillary sinus, and then we'll take a call about the expanded approach.
Sir, Dr. Pranita from Warangal wants to know that is medial maxillectomy needed always to prevent recurrence?
Pardon? In case?
Is medial maxillectomy needed always to prevent recurrence?
Medial maxillectomy? Hello?
Yes, sir.
Medial maxillectomy? Yes. So we'll do a modified Denker's if required. It's a Denker's approach is done, the same approach done sublabial is modified as being done with the endoscopy. So the same Denker's approach, if done with the endoscopy, is modified Denker's. Now see what we found on MRI, the secretions around. Can you see?
Yeah, yeah, yeah.
See, this is hypertrophic mucosa. This is not tumor. You can distinguish very well with the endoscope. Can you see?
Yeah, yeah.
And this is tumor. Can you see?
Yes.
You can distinguish the tumor. See, this is tumor. But I will go to the site of attachment. See now. Suction. Can you see the incipient secretions there?
Yeah, we can see very clear. No problem.
Give me the wash. Let me wash it. See, you can irrigate them.
So this is not a warm saline irrigation, right? Or is
Not
it?
really. No, not really. Warm saline we do use, but not for this reason. We don't want to traumatize unnecessarily nasal mucosa. Warm saline I particularly use in the transclival surgery or any sphenoid-based surgery. See now, this is the tumor. Can you see?
Yeah, yeah.
This is the area of the hyperosteosis which Gaurav had asked. I had shown him on CT scan. And this is how this is. See this in the upright position. See, this is the region of the inferior turbinate. Can you see?
Yeah, yeah. I think normally we get lots of bleeding in such a tumor actually during surgery dissection.
Yeah, we are irrigating all the time, so hardly any bleeding. See this. Now see the upright position.
Yeah.
See the interior of the maxillary sinus, that is up where the orbital floor is. Yep. This is medial part. That is posterior wall. And see the tumor is coming from here inferiorly.
Yeah, yeah.
Can you relate with what MRI was showing to us?
The site of attachment.
Hello?
Yeah, yeah.
Hello? What
Yes,
is classical information what MRI had given us? Yeah. Can you relate now?
Yes,
this tumor is coming from here inferiorly. Gaurav?
Yeah, I can see, sir.
So now my area is very clear and my tumor visibility, if I go with a pure endonasal approach, will be at question.
Yeah.
So now I need to access this area lateral to the turbinate here. So now this is the indication for me for the Denkers. See now? So it is always an intraoperative decision looking at the, by confirming your radiology, we are all prepared for that. I was prepared for that, assuming that the tumor, as I told you, was coming from the maxillary sinus in the region of the inferior turbinate inferolaterally. And so now I will change to 0 degree and will immediately convert to the Denker's drill.
Amit Kesri is asking how do you differentiate between undifferentiated carcinoma and inverted papilloma at this level?
At this level, difficult. See, I told you the carcinoma is a histological diagnosis, and many a time you may miss it. Only radiology can tell you my MRI was not showing any sign of CT or MRI not showing any sign of malignancy. His age is against the diagnosis of malignancy in inverted papilloma at 28 years of age is highly unlikely. No sign or symptom of malignancy. Why to think of that? And still we are suspicious. We'll send the final specimen at the sign of attachment. That the most representative specimen, I would say, we will send for histopathology. Okay? For the Denkers, some of the classical steps of the Denkers here. Denker is a very common approach. In our practice, almost every day, I do Denkers for some or other regions, some or other tumors. So here, my next tool is the man of the match, that is cobblator. See here the cobblator, this is pro-size max vent. Now this is the level of the orbital apex that is important. Since we have opened the maxillary sinus, we have a better landmark here inside just to relate you the level of the orbital apex you can see. By and large, you stay 1 centimeter beyond the level of the axilla to prevent entry into the orbit from here. And my aim is to remove this medial wall and part of the anterolateral wall to get head-on entry into the maxillary sinus for complete access with a 0 degree telescope. Okay? So I'm using the cobblator for the reason of its ability to give us the cutting as well as coagulation bloodless. Can you see this?
Yeah, very clear.
This area is otherwise so vascular.
Sir, I just want to add one point to answer Dr. Pachori's question. Actually, you taught me this. You remember that we had this conversation long ago. There is this free circulatory antigen which is called as SCCA, squamous cell carcinoma antigen, which is one of the first markers to rise in blood.
I mentioned last time.
Yeah, we discussed this. So even in some patients, actually, even before the presence of a macroscopic tumor, you can find that the SCCA level will actually rise. So like if you want to say
that is important from follow-up point of view, not here.
Yes, sir. No, I'm just saying, like, if you have a suspicion, then there is a possibility that you can do an SCCA blood level.
Yes. Yeah, so that's a valid point. Yeah. When we diagnose any papilloma, it is always better to get the serum squamous cell carcinoma antigen level.
If you're in doubt of cancer, you can get it.
Even in the confirmed cases, that is more useful. So that post-operatively, when you get that level 5 days after the surgery, you will find the level. If you have removed the tumor completely, it will come back to normal.
It will drop significantly.
In the follow-up later, you can follow with that blood test every 3 to 6 months. Even with the slightest recurrence, which is difficult to appreciate radiologically, you can have an idea with the rising titer of serum squamous cell carcinoma antigen. So that is an amazing marker. Okay. Now see, coming to the steps of the Denkers. This is my upper limit. I came anteriorly. Can you see the piriform aperture?
Yes.
Yeah, very clearly.
Okay. Now I will raise this in the subperiosteal plane on the anterolateral wall of the maxilla. See this?
Yes, sir.
And now this, how much anterolaterally you need to go depends, or it is dictated by the pathology, dictated by the need of exposure. In this case, I don't need to go far laterally, I tell you. In angiofibromas, many a time extending far laterally, going out of zygoma, I may have to remove this wall completely sometime.
Okay.
So depending upon the need. See this? That is the anterolateral wall. See that?
Yeah.
Now, this is the medial wall. Let me explore the medial wall also. the most important bone here in the medial wall, which is a separate bone here, is the inferior turbinate. See, this inferior turbinate is a separate bone. See this?
Yes.
Give me cobbletter. It's a separate bone.
So do you counsel your patients for possibility of numbness of teeth in these cases?
Yes, it remains for some time, for few months, and the reason is the violation of the anterior superior alveolar nerves.
Yes.
But we went to the literature. I have almost 10 articles on the anterior superior alveolar nerves, their branching pattern. There are 3 types of branching. And finally, in all these patients, after 3 months, the nerve regenerates through the other branches, and this symptom of numbness no longer remains after 3 months.
Okay.
So that is something you need to counsel your patient. Your point is valid.
Sir, Dr. Kemle wants to know that will there be any oroantral fistula in future since the attachment is in the floor?
If the attachment is drilled away.
In the floor, because the attachment is in the floor, is there a possibility in oroantral fistula?
Yeah, let's see the attachment, how deep we need to go, how it is related to the alveolus. It all depends upon that. Now see, I have segregated the turbinate. Can you see that?
Yes.
And expose the medial wall of the maxilla.
Yes, sir.
Expose the medial wall of the maxilla. This is all what we are doing. This is for the exposure, to have a head-on exposure of the area of interest.
Yes.
And this part of the turbinate I am sacrificing.
Yeah.
Once you remove the turbinate like this, many a time you come across the bleeding. With the cobbletter, it is minimal, because all the vessels in the turbinate are actually the branches coming to the bone from behind, that is from the sphenopalatine artery.
Sir, what we should do if the cobbletter is not available? If we don't have...
Then you have to struggle a lot. See, this tool is a magic, this wand is a magic wand, I would say. In one tool, you have the ability to cut, you have the ability to coagulate, you have a suction along with to keep your field clear, and you have an irrigation to prevent the collateral thermal damage. It doesn't allow the temperature to rise too high. And that is the beauty of this tool. It's amazing. I've been using this everywhere with the possible advantage. It is very, very safe. Even for the intracranial use, we have used several times. It is an amazing tool.
Sir, Dr. Sham Somani from Latur wants to know that which part of tumor undergoes malignant transformation? Which part of tumor to be sent to the pathologist?
Which part of the tumor?
They want to know whether the site of attachment or the free end of the tumor.
Yes, site of attachment. I have already mentioned that is the most representative part. Now see, this is the area of the bone which is not allowing us to see head on into the maxillary sinus. It is all clear? I have flushed it with the floor of the nose. There is no bleeding thanks to the cobbletter. And this is the anterolateral part. Now, I will tell you, let me show you how to enter into the maxillary, just to show you the interior of the maxillary sinus first. Okay?
Yeah. So what's the lateral margin of elevation of this soft tissue plane? Is it the infraorbital nerve there?
Pardon?
What's your lateral margin for elevation of the soft tissue plane over the anterior wall of the maxilla? Would it be the infraorbital nerve?
Infraorbital nerve is far beyond, Gaurav. Let me show you. My most of the time the limit is the infraorbital nerve. See, if I elevate further, the infraorbital nerve is far beyond. It's still far beyond, and that is a practical limit most of the time. Okay.
Yeah.
So I am far off from the infraorbital. Now I am not going far laterally. And see the drill I am using. Can you see this drill?
The coarse diamond.
Beauty. I cannot work without this on the skull base. I am so addicted to it. This is a inherent 15-degree angle on this transnasal burr. Such a sleek instrument. And this particular burr head, see this is not diamond. This is coarse diamond. I am not using cutting at all, section. Just to show you an entry into the maxillary sinus section. Just for the sake of demonstration, where the maxillary sinus is.
How often you get epipora in these cases
Can you,
after
see
the,
can you see the interior of the maxillary sinus?
Yeah.
Clear? Now, the only important structure which comes in this way, which we have to sacrifice, is the nasolacrimal system. Okay? And I will tell you the way by means of which you can almost certainly prevent the complication of epiphora. I will tell you, it is not a Dankus, you remove this wall anywhere. To prevent that epiphora from happening, once you remove this wall, you have to flush with the floor of the orbit. Flush exactly and then cut the nasolacrimal duct sharp. Flush to the, that is the only way, certain way of preventing the epiphora. That is what I am going to show you.
Sir, even in this case, did you give pre-op oral steroids?
Pardon?
Even for this case, did you give?
Yes, I give all nasal cases as they improve the mucosal condition by means of reducing the inflammation. Because whatever even the tumor these patients have, they have so much of mucosal inflammation in the sinuses because of the secondary collection.
Also, how many days prior will you stop the steroids, oral steroid before the surgery?
Pardon?
Before prior?
How many days? Minimum 5 to 7 days minimum.
Okay.
We give all steroids to all patients for tumor surgery, even for all angiofibromas.
One of the important reasons to give the steroid is also.
Now let me show you something better about the interior of the maxillary sinus. See this picture now? Now, let me show you something. I can remove this bone in no time. I can use a Gaussian hammer just for the sake of demonstration of the concerned landmarks. I am showing this. See now, inside the maxillary sinus. Pani rakh now. Can you see the picture of inside of the maxillary sinus?
Yes, sir.
This is polypoidal mucosa. It's the tumor. This is because of the inflammation. Laterally is absolutely free. See, my disease is where? Here inferiorly. Can you see here?
Yeah.
And we knew it 40 because of the MRI. So we have to take the advantage of radiology. Paramita, you mentioned the name of a person, Dr. Sham Somani. Hello?
Yes, sir.
Yeah, Latour.
You know this man, he amazed me once.
Yes.
He organized a workshop at Latour
Yes.
on the sinonasal diseases. Operating workshop, I was there with Ashish Bhumkar.
Okay.
And believe me, the collection of cases he had, 18 sinonasal tumors, 18.
He does great work, sir.
18 cases of sinonasal tumor he collected. Amazing. See this? Gaurav, I am showing you, just to show you the lateral wall, everywhere is free. See this?
Yeah. Yes,
All
sir.
mucosal hypertrophy, nothing else.
Yeah.
The tumor is centered on the infero-medial part. Is that clear? Let me give a wash and show everyone the exact story where the tumor is. Just giving straight dena yaar. Kya de raha?
Sir, with your permission, I just want to add a point.
Yes, please.
Of the bone at the attachment of the inferior of the tumor actually. So most often this bone is actually, it lacks the strength of lamellar bone. It's usually woven bone, which is very weak. And that is why the tumor can easily break this bone and invade that bone. That is why it's so important to take out this bone.
Tumor erodes the bone.
Yeah.
Tumor has a tendency to enter into the Haversian system of the bone. Tumor goes differently in different situations. It's not. Many a time you'll find a complete bone destruction.
Yes.
Sometimes you'll find hyperosteosis. See now the interior of the maxillary sinus and tumor is centered inferior-medially. Is that clear to everyone?
Yeah.
That is what our MRI showed. Now, see, this is the anterior edge pyriform aperture. See now what is there behind? This is your nasolacrimal duct. Can you see this?
Yeah, from inside.
This is your nasolacrimal duct. Why I am trying to show this? This is the level of the roof of the maxillary sinus, the floor of the orbit.
Yeah.
I will cut this duct flush to the floor. If you cut this duct below, flush, even sharp, the hanging part of the lower part of the duct with moving, the mobile part of the duct will involve fibrosis and stenosis. So never ever cut the duct lower down, always cut flush, absolutely flush in the bone along the floor of the orbit so it never gets stenosed. That's a very important point to prevent a major morbidity. That's why I was trying to show you the interior of the sinus that where I'm going to cut this bone duct. Okay, is that clear?
Yeah.
Now
Dr.
see,
Rajan Bhargav is asking, after doing so much of bone removal, chances of empty nose syndrome or dry nose syndrome afterwards?
nothing. Boss, we are anyway at the end of the surgery, I will show you, will not leave any raw areas. Most of the area will be mucosa line, number one. And with a good irrigation, saline irrigation, ringer irrigation in the post-op, it heals so fast. We have many patients, hundreds, thousands of patients, skull base, we have without any issues. So, yes, but you have to counsel the patient for initial few months for the judicious irrigation. That is important. See now what I'm trying to show. I'm trying to remove this thin bone with a lux only. See that?
Yeah.
Just to simplify it. See with the lux?
Yes, sir.
Once you use the drill laterally and thinned out, it can come easily with the lux as well. And see the duct now. Can you see the duct?
Yeah.
If you cut this duct hanging like this, it is 100%, 100% it is going to stenose. See that?
Yeah.
So I will flush it thoroughly and then cut, and that will be the sort of insurance that my duct will not get stenose. Now give me the drill first.
There's a question, the squamous cell carcinoma antigens that you said, that does it from malignancy as well, or it is just to follow up the recurrence of the reservoir?
Then Paramita, can you repeat the question little louder? I heard squamous cell carcinoma antigen. What about that?
Is that we discussed that it is helpful for follow-up for recurrence and residual. Does it also help to recognize if it's a malignant disease for malignancy?
Not really. Not really. Actually, this antigen is used to detect malignancy generally. But this antigen is a receptor in inverted papillomas. That's why you use it for here. Originally, this antigen was used to detect the uterine cervical malignancies and other squamous cell carcinomas, but for inverted papillomas, it is quite specifically, it has receptor and this antigen levels rise.
Deepak Dalmia is asking, everybody doesn't have this so beautiful drill. Can we remove this tumor by sublabel endoscopic approach along with the nasal route?
Endoscopic?
Sublabel mini cardiac approach by endoscopy.
Can you this illumination, try to understand.
Yeah.
This illumination, this magnification, all this beauty, you cannot get with the sublabial approach.
Because for such beautiful dissection,
if sublabial for this any region, if any approach is superior to this, I will go for that. I am not biased.
No, everybody doesn't have this cobbler as well as the so beautiful drill. That's the.
See, the equipments are important. I have no answer if we don't have. But yes, we have to think of something better. Science is evolving. We are striving for the better results. I don't have answer if I don't have this, but yes, you have to struggle a lot. You can still do it. See now the wall of the nasolacrimal duct.
Yeah, we can see very clearly.
See still what I am doing, spending 5 minutes extra to flush it with the floor.
Yeah.
And then you will find will be no epiphora. That is so important. Debrider. I need debrider. See now, I am flushing to the floor. I will show you exactly the point.
We first time saw this debrider in 2000 when Dr. Kirtane sir brought this for his case in 2000. I think to 99 or 2000. So this was the starting of the debrider. Now it is the must part of any surgery in sinus surgery.
Yeah, this is the important part of the armamentarium now. Any special comments from Professor Sethi? Any suggestion at this point of time?
No, Satish, doing a great job. And yes, excellent. I just did a similar case not too long ago, maybe about 2 weeks ago. But that the hyperostosis was on the lateral wall of the maxillary sinus.
And you had to do Dankers?
So very similar approach. The only thing I may have done a bit differently, sometimes I raise a flap on the floor of the nasal cavity so that we can drape the bone after once we have removed the inferior turbinate and done a complete medial mycorrhectomy. Now, Dankers provided a very nice approach here, very wide exposure. Other options could have been, because the pre-lacrimal recess I saw was not involved with the tumor.
Yeah, pre-lacrimal, I understand it's a narrow approach.
Yeah. So that could have been an option, but in this case, I think this gave you a better exposure, certainly.
Yeah. See now the level of the level of the duct.
Yeah.
Flush with the floor of the orbit. Can you see now?
Yeah.
Exactly. See, this is the floor of the orbit. Exactly.
Yeah.
Absolutely flush. And now I will take a call to cut this sharp in one go. See, the duct has gone.
Yeah, beautiful.
Yes, now see if I press. See this.
Yeah, beautiful.
So this is not going to come in my way. This is not going to hang. And certainly this is something by means of which you can prevent the scarring. Okay.
Sir, can you hear me?
Yes.
Sir, I just wanted to, for the benefit of the junior colleagues of us, is there any indication for a pre-lacrimal approach in cases of inverted papilloma involving the maxillary sinus?
That Dr. Sethi has already emphasized. The reason is Gaurav. For audience, let me tell you. Two reasons I don't do. Number one, pre-lacrimal is a narrow corridor anterior to the lacrimal duct where I made the opening, in the initially, where I made the opening, enlarge it until the nasolacrimal duct, and that space anterior to is used for tumor removal. You raise the flap and replace it back. That is pre-lacrimal. But the thing is, in papillomas, I have two reasons for not to do. Number one, I don't want to compromise with the
exposure.
And second thing, in papillomas, we have started taking 5 millimeters margin now.
Yeah.
5 mil from the site of attachment, 5 millimeter all around, and a safe margin of mucoperiosteum.
Yeah.
This has recently been emphasized in the literature. Some good, impressive articles I went through. And see now, I am going to the attachment. See now, all over, all around, everything is under control from all around. See this kind of exposure. See, with a 0 degree, I have full control over the tumor in the maxillary sinus. Can you see?
Yes, sir.
That is what I want. See this vessel here? That is the tumor vessel. That is the feeding vessel.
Yes.
Now I can debride it, everything, and I will drill away. See the tumor vessel, I will show you again.
Sir, also there's another reason not to do a prelacrimal approach is like in the post-op, when you want to keep an eye on whether there's a tumor recurrence, you won't be able to do it with a prelacrimal approach because you close it back.
Yes. See now, this is the site of attachment. This is the hyperosteosis. Can you see this?
Yeah. Yes, sir. Absolutely.
Now, my next goal, give me the drill, is to completely excentrate this region with a 5 millimeter margins all around. That's it. We'll finish off with this.
Definitely.
So number one, the lesson in this case, number one, you have to be suspicious while looking at the CT scan once you find something abnormal, and that is something dictating the MRI.
Yeah.
Take the use of technology to improve the diagnosis, and for particularly this condition of inverted papilloma, you know, a chunk of patients, majority I would say, are diagnosed as a surprise finding when the case is taken up for sinus surgery.
Yes, sir.
Same thing was going to happen with this patient as well.
Sir, there's a question from Saudi Arabia. The Dr. Shashi wants to know that they used lacrimal stents for 6 weeks post-operatively. So what is your view regarding this?
They use
lacrimal stents.
Lacrimal stent is not needed for this particular transection of the duct. What we have done, absolutely flush. And what additionally we tell these patients to keep on pressing on the medial canthus region to flush off the any clot or anything which forms in this region to prevent fibrosis.
Is this a electronic drill that you're using?
Pardon?
Electronic drill, is that the using? Which drill are you using, sir?
This is the stylus from Medtronic Pandal.
Okay.
This is stylus from Medtronic, and now I am removing all around the site of attachment. See the 5 millimeter. Completely drilling to the normal bone. Can you see?
Yes, sir.
This is the most important steps towards the prevention of recurrence.
Yeah.
We can use normal drill also. Like suppose everybody doesn't have this drill, we can use normal drill also.
Yes, you can. See, there is an alternative for everything, boss. See some vessel.
Yes.
But what is the optimum is most important.
Yeah.
Sir, can Denker's approach be used for recurrent maxillary polyps unapproachable?
What approach?
Can this approach, the Denker's approach, be used for recurrent maxillary polyps which are unapproachable from the maxillary?
No, not really. Never. That is too radical. For a recurrent maxillary polyp, what additional you can do is you can take the help by going through the suction quarter. You can take an additional route, the sublabial, to introduce your micro debrider from there. Okay?
Okay.
See, that's some abnormal vessel.
Yeah. Otherwise, we don't get such vessels.
Yeah, no issues.
So what amount of cosmetic deformity does these patients develop after the surgery?
No.
What? Pardon, funny.
What amount of cosmetic deformity does
Not really, not deformity. See, I tell you, that's an important question. See, when I started this surgery, I mentioned about the anterior limit that was piriform aperture. See that? You are not supposed to come too anterior to damage the nasal ala. See this ala here? If you damage the ala, can lead to drooping.
Okay.
And then you need Gaurav for rhinoplasty.
Okay.
See this region where the vessel was coming from?
Yes.
Usually there will be one vessel like this which will bleed a bit, which is actually feeding the tumor.
Always.
Yeah.
And that is diagnostic.
Yeah. So one of the things we need to remember here as well is up to what point do you drill the bone? So you need to drill the bone until you start seeing healthy lamellar bone rather than immature bone.
See, this vessel was a branch of greater palatine. I tell you. I will do my job, complete job of drilling that bone, not bothered about this vessel. We'll control it again, coming from the depth. But we should not compromise.
So there's a question from Dr. Ravi Shankar Muscat. He's saying that what about the biopsy from the tumor attachment area?
We have taken one piece. We have taken one piece. We have taken one piece which came in debrider, and we have taken for histopathology. The last piece which came from here.
Okay.
See, this is the region of the greater palatine.
Yes.
Yes, sir.
Yeah, that vessel was coming from as a branch from greater palatine.
So Dr. Gopi Shankar from Mumbai wants to know that can canine fossa approach be an alternative for Denker's approach?
Which fossa?
Canine fossa.
That's what Deepak Dalmia was asking. That is
Sublabial
alternative approach. If you are not well versed with endoscopy, then you can, but again, that cannot match the endoscopy. See the brilliant illumination. See the value. Even a microscopic component you can see very well.
So what are protocol for recurrent inverted papilloma? Means regarding investigation and treatment protocol?
Yeah. First of all, that is never a true recurrence. It is always a residual with regrowth.
Residual, yes.
And again, the same principle. You have to thoroughly drill the underlying attachment completely. The reason for the recurrence is lack of complete removal. Drill. See this, how radical you have to be at the site of attachment. You can see again. Don't bother about the vessels coming. That you should be able to control. I want a flush bone, completely flush bone. Can you see now?
Yeah.
Yes, sir.
Amit Kesri is asking, you changed any cobbletter setting in this case? What was your cobbletter setting?
Cobbletter setting is full. I keep on full mostly, 9.5.
Okay, 9.5, okay.
Yeah, cutting 9, coagulation 5. And you see the normal area now?
Yeah.
See this 5 millimeter surrounding?
Yeah.
Completely drilled off.
Yes, sir.
5 millimeter denudation. This is the recent recommendations. It's always good. Now there are only two ways for the recurrence, so-called recurrence of these papillomas. One is the multicentricity, if unfortunately the patient has.
Yeah.
Okay. And second is the tumor biology. In some of the sporadic reports, some of the sporadic cases have been linked to the HPV 16, 18 and some other regions which has still not been proven, They are aggressive lesions where the possibility of multicentric lesions are more, and that tumor biology is something beyond the control. Okay, but 99.9% of the time, debrider, if you do an adequate surgical work, believe me, recurrence is unlikely, and we have a huge series. And mostly in our series now are the revision cases. So we have seen all funny attachments of the papillomas you can think of.
And suppose this case get a biopsy report of squamous carcinoma, though it doesn't look like, then
Very
what would it be?
boss, I can say this, you can, with time you can understand, you can start seeing whether it is malignant or not, something like that. This is not malignant, I can say.
Yeah, it doesn't look like.
No doubt. On a slightest doubt, I would go radical, oncologically safe resection. Even with the malignancies, we have done many papilloma malignancy with a proper endoscopic radical dissection, not a total radical maxillectomy, a sort of subtotal maxillectomy, complete radical oncologically sound operation, that too endoscopically. So it's not that a malignancy cannot be handled endoscopically. Depending upon the site of attachment, I told you, you have to classify whether it is favorable or not.
Yeah.
So that's the final picture of this region. Can you see?
Yeah, very clearly. Wonderful. Wonderful.
That was the vessel.
Yes, sir. Yes, sir.
And yeah.
Any more question we can take?
And what about packing? Will you go for packing in this case, or?
Yeah, we'll put a marrow cell, definitely.
What about to avoid excessive crusting post-operatively? There's a question. This question is from Kathmandu. Dr. Naramaya wants to know.
Yeah, can you repeat, Paramita? Sorry.
Post-operative crusting.
Crusting a little bit. That's why a judicious post-operative irrigation is important. I told you that day, all these patients after endoscopic surgery, whether sinus surgery or skull base, we keep them additionally post-pack removal for a day to train them with a douching. And that is so important. Believe me, the post-operative course is so important for the patient.
Yeah.
Is there any role of pre-operative greater palatine artery block?
Why?
Role I would not deny, and that was an initial study from P.J. Wormold, who has proven that reduces the overall blood loss. But see, now with the advancement in the anesthesia technique, the advancement in the drugs and all that, that is really required, making a significant difference. So we don't do that. We have done that. That's a good technique. I don't deny it. It does make a difference, no doubt about it. But you have to weigh the pros and cons, for everything.
We will also like to know this Dr. Sethi sir's opinion on this. So what do you think about this?
For greater palatine blocks?
Yes, sir.
No, I don't do that. I think that you can see Satish has a very nice operative field here. And I very rarely give greater palatine blocks. I used to for extensive nasal polyposis in the past, and that was like more than 10
Ramita, this is the final picture. I am coming out.
Yeah.
I'll come with the radiology of the next case. The next case is already induced.
So give us 5 minutes. Sun Pharma people are there. Mr. Mahid Varman is there. Before that, there are 2 announcements that regarding the OT setup, we will show you in last case because of the compatibility with the camera and the attachment. So we'll show the OT arrangement in last.
Yes, we will show what precaution we are taking, looking at the
last
COVID.
Case,
Yes. Now next case we'll show.
And second, Mr. Varman is there from Sun. He has some announcement.
After that announcement, I am ready with the radiology of the next case.
Yeah. Okay.
Yes,
Sir,
Mr. Varman.
please go through more 2-3 questions.
Good evening to all once again, because
Hello.
audio problem in the
Now it's
in the beginning, then we could not share what we wanted to share about the company. So just in 2 minutes, I will take. I don't want to take much of time. Sun Pharma. My name is Mahindra Varman, Deputy General Manager of Pharma Care Division, which is a division of Sun Pharma Industries Limited. And our logo for the company is reaching people and touching lives. And Sun Pharma, it's the world's 5th largest pharmaceutical company, generic company, with a revenue over $4 billion, which is roughly coming to almost 29,000 crores. And we are spending almost R&D for 8% of the total sales what we earn. And we are ranked 5th largest pharmaceutical company in the US. And India, we are the #1 company in our country. And we have a market presence over 150 countries, and globally we have around 30,000 employees. And for R&D, research and development, we spend approximately 8% of the total revenue what we get. And we have manufacturing footprint across 44 manufacturing facilities across the world. And we have product portfolio of more than 2,000 products across the world. And we are we are having 8% of our market share. If you take the India business, we have 8% of market share. Now it is on the increase. Prescription trend, we have #1 rank among 10 different specialties. And especially in chronic segment, we are very good and market leader in various segments. And we are 30 brands in the country, which is top 300 brands, which comes in 300 brands, 300 brands. And our division, Pharma Care, which is a division which mainly deals with the brands like Cipodum, Recifer, and Montecapex. This is short about my company. And thanks for the opportunity given to us for organizing this surgical webinar for the first time in the pharmaceutical industry, I would say. And this is, we have set a revolution and a milestone for the industry as well. And this has become possible with the help of Dr. Rajiv Pachori, who has mooted this idea, and Dr. Satish Jain has accepted for this this webinar. And thank you very much for all the acceptance. And I'm very much delighted to have the galaxy of the stars. I mean, Dr. Sethi, Dr. Kirtane, and Dr. Parimita, and Dr. Gaurav. And it's a wonderful opportunity given to us. And thanks for the support which you have been extending. I request you to kindly extend your support, I mean, as usual. And Sun Pharma is very keen in supporting all these scientific events, even in the coming years also. So thank you very much. Thank you very much for the opportunity given to me. I mean, in between your scientific discussion. Thank you, sir. Thank you very much.
Thank you, Mr. Verman. Thank you. Thank you so much.
Thank you, sir. Thank
you. I'm really grateful to Sun Pharma for giving this opportunity, for making this event happen. So,
yes,
are you ready with the? Are you getting the picture?
Yeah, just we are getting it.
Yes, sir. Yes.
Sir,
Okay.
1 minute, sir. Before you start, sir, there many surgeons wanted to know what was the coagulator settings that was there for the previous case.
He told.
Ablation 9, coagulation 5.
Okay, okay.
Okay. Anything? So let's go ahead. This is an 11-year-old child with a history of earlier he had little proptosis, so he presented somewhere and got a CT scan done. And see the CT scan. There's a classical unilateral disease with some hyperdensities on this soft tissue window. Let me change the window setting to show you. See the soft tissue window? See the hyperdensities. See the thick bony septations. And this is classical of a, see this hyperdensities everywhere. This is the picture after the steroid treatment. And the fungus and the polyps have significantly reduced after that. Let me reconstruct this and show the entire picture. See the all three planes. Let me reconstruct to the bone window. Now this is bone window. And see the sphenoid completely expanded with a lot of hyperdensities coming anteriorly. Follow these hyperdensities with some polyps in the nose, maxillary sinus, and the ethmoids, as well as complete pan-opacification with opposite side being normal. Now, looking at the clinical scenario, what I've given to you, young 11-year-old child with hyperdensities, unilateral disease is almost always a fungus. That's my point. This is classically a situation of a unilateral disease which happens in AFRS most often. Young children are classically affected more often, and these hyperdensity is one of the criteria. Like if you go to the Bantam-Kroon criteria, 5 criteria. So we have seen the fungal situation discussed in the first part. There are 3 types of fungal infection a human being can acquire. Fungus is ubiquitous in the air we are exposed to, and we inhale every time we breathe, and we have our sinonasal immunity to combat that. And this fungus is trapped in the mucus, and the ciliary activity expel this in the nasopharynx, and it doesn't affect us. Now scenario number 1, when the fungus is trapped in the mucus and not able to clear it, happens to get trapped in the sinus and gives a fungal mycetoma with no reaction of the patient. Number 2 is like this. The patient was allergic to this particular fungus, and the moment fungus got trapped in the sinus, the human body reaction, that type 1 hypersensitivity reaction bringing eosinophil and the mast cell and the IgE into action and giving a classical strong reaction of the body to the fungus, giving this picture of AFRS with a lot of fungal and eosinophilic material. And third is the picture when the fungus invade the mucosa. This AFRS is still not invasive. Third is the situation when fungus invade the mucosa and the human body's immune response is not able to stop that. The second part in the AFRS, the reaction is more than required. In the third part, the reaction is less than required. And first part, there is no reaction of the human body. That's how the three types of the fungus we have. So in this particular fungus, it is a type 1 hypersensitivity. That is the second criteria of Bent and Kuhn. Third is the nasal polyposis, fungal stain positive, and the classical mucin containing the fungus and the eosinophil. That is how the 5 criteria you can diagnose with. So, as I said, it is a type 1 hypersensitivity. Fungus is behaving like an antigen and body is reacting with the antibodies. So, antigen-antibody reaction like any other disease in the body, the answer is steroid. Now, for the steroid to be effective, first of all, we have to get rid of the antigen. So, the first and foremost answer is to remove the fungus. Remove the reactionary polyps and establish the ventilation and drainage of the sinus and then follow with the steroid. And once you open up the sinus, you give the opportunity for the topical steroid to enter into the sinus. So, you don't need oral steroid later, but we give oral steroid for this particular condition at least 2-3 weeks because there is strong human body reaction to the fungus. It's quite severe reaction, and that's why the steroid is the mainstay of treatment. No meta-analysis so far has proven the role of antifungal as a standard treatment for this condition. I have given the role of antifungal in 1 or 2 situations as a steroid sparing agent or to buy some time pre-operatively to reduce the inflammatory load. That's it. Otherwise, no role of antifungals. Dr. Sethi, do you agree with me or you have any other concept?
Absolutely.
So I hope you don't give antifungals to this AFR patient post-operative.
No, we don't give antifungals.
Absolutely. So this is about the radiology. You can see unilateral, all sinuses affected, and I'm very soon going to take up this case as we have another case lined up, that is meningoencephalocele. So we'll do a full house FESS on the left side. There's a classical indication again, like previous case, this is again an indication. So we discussed in the first part the indications for sinus surgery. Not every patient requires sinus surgery. We had a question, very good question from Dr. Kranti Bhavna last time, that how many patients you are able to avoid surgery with a medical treatment. So these are the examples where the surgery is essential as a part of management. These are the patients which cannot be converted to medical treatment alone without the need of surgery. But there are many other indications where the medical treatment is good enough and you can certainly avoid surgery.
Yes,
Any
yes,
more
yes.
questions?
Yeah, one from Amit Keshri. Again, the same question. I think so much doubt is there that
Yeah.
was pre-lacrimal approach for this tumor will save lacrimal system.
That would have been too narrow for me. Would have been too narrow for me, and I don't want to take a chance of compromising the exposure and taking a chance of recurrence. So with this exposure you have seen the dankers. What an amazing exposure. You have a head-on exposure with a 0 degree, and you can reach to each and every part of the sinus around the tumor. That's how we could reach and drill away effectively the base and the surrounding completely. So why to compromise with the exposure, particularly to the situation which is already known to be notorious for the recurrence?
Yeah. One question from Dr. John Shadow from Australia. There is one article out in France. I think that advocated using monopolar on the attachment after it had been drilled out.
See,
cautery, roll of cautery after drilling out the attachment.
See now, it is a simple matter of understanding. The goal is to remove the tumor which has gone inside the underlying bone until you get the normal bone. You saw the way I drilled and found the normal bone inside.
Yes.
There was only, we flushed to the level of the normal bone. There was no scope of any cauterizing anything underneath that. But yes, if you do an under job and try to cauterize that, you still leave the possibility of a so-called recurrence coming up again.
Same
So,
point
Doctor,
regarding AC polyp, though it is not the case. Same point regarding AC polyp, recurrent AC polyp. Is it advisable to do cautery, monopolar
Yes,
cautery at that?
yes, I do that. That is a different situation because the pathophysiology in AC polyp is different. That is a situation of a lymphedema and a sinus blockage.
Yeah.
And that where the lymphedema starts at the base, it is always better to cauterize. We do that and it works. I believe it works.
These are the 2 points. Very good.
sir, Dr. Prakash Munka wants to know what about the reconstruction of the lateral wall? How to do it?
Convey my regards to sir. Sir, good evening. Being such a senior person involved in this.
He's always with us.
I know. So reconstruction of the lateral wall. See, with this much of bone removal and following the mucosalization and the fibrosis later on, practically doesn't need any reconstruction and it doesn't involve any morbidity as such. As long as you have treated the nasolacrimal duct properly, you don't need to do anything else. You just give an opportunity for the irrigation, opportunity for the surveillance for the future by means of keeping that area open. These patients requires long-term surveillance at least for next 2 years because the recurrence are mostly reported in 2 years time period after surgery.
Okay, sir. Sir, please show us the external setup. Many surgeons
Last case.
In this case, I'm going to show you.
Okay, sir. Okay, sir. Okay, sir.
Question to all, Dr. Sethi, Kitne sir, and how often you get means after doing surgery in one side, this recurrence, or you can say same tumor in other side, inverted papilloma.
Inverted papilloma coming back to the other side.
Yeah.
Unlikely. See, it can come on the same side, somewhere, sometimes attributed to the multicentricity, which is still not proven, but yes, it has been reported. After a radical removal on that site and no tumor coming up for next 2 years on that site and the tumor coming to the other side, which was not involved previously. So that is surely multicentric, that you cannot do anything to it. Otherwise, it's not been reported.
Okay, sir. So I think we can move on with the next case.
Dr. Sethi sir, want to say something?
Yes. Because Satish mentioned about the multicentricity of the tumor, which is an established fact where inverting papillomas are concerned. So what we did here was a medial maxillectomy, which is the right approach, no question about it. And Satish did an excellent job, I would say, with the Denkers, very nice exposure, very quick, and he proved his mastery on the surgical technique. My question is, because this is a multicentric tumor, would we have combined it with a complete sphenoethmoidectomy?
Yes. Had there been some issue with the sphenoid and the ethmoid sinus, in this particular case, had you seen the, if you remember the radiology, were absolutely clear. Sometimes you find a retained secretion somewhere.
Whether it will come back on the other side. Now, not to come back and ask the question whether it can occur on the same side but in a different sinus because it's multicentric.
Yes, exactly. Your point is valid. I think that is the answer.
Dr. Rajan Bhargav asked actually this question from Kanpur.
Sir, I think we can move on to the next case. Till then, I can ask Dr. Sethi something about what about the post-operative nasal douching, sir. Dr. Amol Hekare wants to know about Mumbai. What is your what mixture do you use? For how many days do you use?
I showed that day through my laptop the positions we use for advocate to the patient for douching, lying head back, and the anterior position, that is a prayer position. I've shown the picture earlier.
Yes, sir.
Those are the two positions we advocate patient to do douching to allow the solution to reach everywhere.
Yes, sir.
So
Sir, I would like to know Dr. Sethi sir's opinion in this. What does he do in his practice?
For a post-operative care?
Yes, sir.
Where we advise patients for this kind of, with the medial maxillary like that and with so much of bone exposure that we have had, crusting is going to be a big problem there. And what I've seen is a major crusting, and a lot of significant mucosal edema after this operation. And irrigation care. And usually we prescribe Neelmed saline irrigations with the sachets, and the patients are asked to refer to the website. Neelmed has a very nice website where they explain how to do this nasal douching and all. But basically, I don't go into the details of explaining to them exactly how you should do it, and I refer them to the website, which gives a very nice graphics and explains it very well.
And so post-operatively, how frequently do you call the patients for follow-up nasal
All right. We have a
endoscopy?
very stringent post-operative care, and I usually will see them on the day of the surgery, of course, in the ward. And then next day, when I discharge them, before they go back home, they will come to my clinic where I will do a nasal toilet for them, suck out all the blood clots and all, so that when they go back home, they're not bleeding and they're more comfortable. Then they come back twice a week for the first 3 weeks, twice a week. And during this week, I will do all the nasal toilet, very meticulous nasal toilet, clean the cavity, and irrigate myself, in the clinic itself. And the reason for doing that, sometimes patients are not very compliant or they are not doing it properly. And it's also to show them that, okay, have you been irrigating? And despite that, there is so much of, clots and so much of pus in there. And then teach them, show them on the monitor that this is where the problem is, so that they can be more proactive about it. So I see them twice a week for about 3 weeks for this kind of thing. Okay. And then after that, I will assess. In the meantime, we'll see whether there's any, how significant is the edema, and whether there's any pus. And if there's any pus, I will take a culture and then start on culture-directed antibiotics. And if there's significant edema, then we'll start them on steroids after that. Okay. And if the edema still persists, then I will add Pulmicort to the nasal irrigation, so that they can. We give them residues, and they will put one residue in 200 ml of saline and irrigate. And initially, I'll tell them to irrigate at least 2 or 3 times a day, and this will come down to about once or twice a day. Usually, by 6 weeks, you will start seeing some improvement, and then with this kind of surgery, crusting, and you see the exposed bone is going to granulate, and granulation takes a long time. It can take up to about 3 weeks to about 6 weeks, sometimes as long as 2 months, even 3 months. And during this period, after about 6 weeks, then I start seeing them once a week, or maybe depending on their improvement, I will see them maybe once in 2 weeks. And once everything has healed, then I see them once a month for 3 months.
Okay.
After that, I will see them on a 3-monthly basis for about a year, and then on a 6-monthly basis for after that. And they will require lifetime follow-up in my context.
Okay, sir. Thank you so much. So we'll come back to Dr. Satish Jain. We in the operation theatre, sir. Hello?
Paramita, can I ask a question to Dr. Kirtani and Dr. Sethi, if you don't mind?
Yeah. You carry on.
Yeah. So, Dr. Sethi and Dr. Kirtani, so we know that 95% of the recurrences actually happen in the first 5 years after surgery of an inverted papilloma. So, in your experience, have you ever had a tumor come back after 5 years of surgery?
Yes, I had one that came out after 10 years.
Wow. Okay. Can you tell us about it? What was there any risk factor or anything?
I have a very nice video of that, and it wasn't picked up on a CT scan or something like that. It was in the frontal sinus. This tumor I removed from the frontal sinus. It was a small little nodule, just a small little nodule in the frontal sinus. And had I done just a CT scan, the CT scan would have missed it completely. And it was because of the endoscope that could pick it up. And it didn't even require surgery. I could just remove it. It was so small, I could just excise it in the clinic. So to answer your question, I think even meta-analysis has shown that it can recur after 10 years.
Yeah.
Although
I've got this orthopedic surgeon who's undergone 3 surgeries already.
Okay.
And we thought everything was okay, because for the next 5 or 6 years, he had absolutely nothing. And now he came to me very recently, almost 6.5 years after the previous surgery. And again, now he's definitely got tumor. Now, whether this is residue or whether this is a fresh real recurrence is the point, because you would have expected the residue to grow much earlier.
Faster.
Yeah, and therefore maybe it's a truly recurrent tumor. But I have seen patients coming after years and presenting with recurrences.
So just to follow up that question, so having this information now, would you recommend, so normally every textbook asks us to follow up the patient for at least 5 years, and after that we leave it to the patient whether or not they want to follow up with us. So having this information now, do you recommend that we continue follow up at least once a year after 5 years as well?
Once a year,
is,
yes.
Yeah. Okay, for the rest of their life then.
Sir, I would also like to know in pediatric cases if there is adenoid. So adenoidectomy and FESS can be done at the same setting?
Okay, adenoidectomy, what age group are you talking about? You know, usually I try to avoid doing endoscopic sinus surgery in children under the age of 6, you know, especially. So usually we do just adenoidectomy for them, not endoscopic.
Okay. Okay, sir. Okay. So, sir, can we come back to the operation theatre? Dr. Satish Jain, can you hear us?
I think he's still scrubbing up.
Okay.
So in the meantime, you can address the questions to Dr. Kirtane and Dr. Sethi if we have any questions.
Was you want to show us the setup of the operation theatre?
Yeah, external setup. Yes, that's what we wanted to see. I think they're still connecting. No problem, sir. There's a question from Muscat. Dr. Sharmila wants to know whether ultrasound of neck is required in inverted papilloma cases.
Not really. What are you looking for in ultrasound?
I think what she's trying to say is, do you suspect that it's a malignancy? And if you suspect that it's a malignancy, do you need to do an ultrasound neck to find out any neck nodes?
Yes,
if it's a malignancy, yes.
Yes. Otherwise, no.
Otherwise, as a routine, I don't think we do it. But you know, there are some centers that when you're doing the microdebrider, they put a trap between the suction and your handpiece so that all the tissue that is removed, you know, not just the site of attachment, but all the tissue that is removed is collected in a trap, and the whole bunch of tissue goes for histopathy, so that you don't miss out if there's a malignancy in one particular part. I mean, that was one thing which I wanted to mention, that you put a trap and collect the tissue in a trap and send it to
Yes, immediately extend on that what Dr. Kirtane just said, that some surgeons actually use a trap for every wall. For anterior maxillary wall is a different trap.
Hello.
So that you don't, if there is a recurrence,
Hello.
Or sorry, if there is a malignant.
And you know where it came from.
Yes, yes.
Hello.
Yes, sir. Yes, sir. Yes, sir. We can hear you.
Yes, can you hear me?
Yes,
Yeah,
yes,
we can hear you. No problem.
So you can see the overview of the operation theatre. Can you show the camera all around?
Yeah. We can see.
This looks like a sort of a movie contagion. Man.
Actually have to wear level 2 PPE. According to the Ministry of Health, Government of India, we have to wear level 2 PPE, and this is a, can you show here until down? This is a full gown. Yeah, this is a full gown you have to wear. This is a waterproof gown with an N95 mask, gloves, with a specs, and the shield, face shield. You all have to wear all this sort of level 2 protection. And this is with my assistant, and he's an anesthesiologist, and these are two my assistants.
Okay, great.
And this is the modular operation theatre, which is the requirement, again an additional requirement from the Government of India to handle the airflow in this situation. But believe me, wearing these for longer times is very, very difficult.
Yeah, but very difficult.
Yes, sir.
But you can't help.
Sir, thank you so much, sir, for arranging this for us in this COVID-19 pandemic situation. We are really grateful to you, sir. Thank you so much.
Thank you. And now we are all set with the next phase endoscopic picture, please. Endoscopic picture, please.
Yeah, we can see.
Yeah, endoscopic picture. Pani there. So, irrigation, Lena. Can you see the left side of the nose?
Yes.
Yeah.
This is unprepared. As I told you, like previous case, We don't inject. Now I'll prepare with the marrow cell pieces. See, the polyps have significantly come down. Even the fungal load must have come down with the amount of steroid this patient was given pre-operatively for 7 days. Earlier was massive fungus pouring out and the polyps completely blocking the space.
Yes, sir.
After this, our next case will be a Manning-1 cephalocele, like we discussed during the last part, how the radiology can have an impact on the outcome. Again, it was a misdiagnosis earlier with CT cystinogram, with MRI corrected. So, with this series, this is, as I told you, this is a concluding session of this series of sinus series of webinars. We'll continue in between with some more cases to show more variety like angiofibromas, invasive fungus, chronic invasive mucormycosis, other tumors, CSF leaks later on in between so that you can have a complete idea of each and every pathology and role of radiology in each and every pathology.
On Sunday, we are starting with the temporal wound dissection in afternoon.
This Sunday, 10 o'clock.
10 to 2.
We'll start with a series of otology webinars. So now
Dr.
quickly.
Satish, one good question is there from Ramel Yogadin. Why not to use healthy inferior turbinate concha or mucosa as a flap to cover the maxillary floor after you remove the tumor? In the previous case.
No, I don't want to cover that area for the surveillance. See, you are dealing with a tumor.
Yeah.
You can't do that in tumor cases, Pandal. That is not inflammatory disease. Tumor, you have to have surveillance for long. That's why I believe in this more extensive approach like Danker so that you can have a long-term surveillance. Even the slightest of the issues you can detect endoscopically very. See the fungal element?
Yeah.
That is the nasopharynx, the choana, very clear. And this was the polyp, see, medial to the turbinate. See, this is one factor leads to, affect the stability of the turbinate once you have massive polyposis medial to the turbinate. See this middle turbinate? All these polyps are divided are medial to the turbinate. So this is just what I've done is what I'm doing is a debridement of the luminal component. So now more polyps here. This is a child had a big sphenoid sinus because of the expansion by the disease. Has a good frontal sinus as well with the disease into it. So this is again the polyps in the middle meatus. I'm just debriding the polyps, nothing, and you can see the component of the fungus behind everywhere. This uncinate and the mucosa which is coming out.
So have you got all these patients COVID profile done, the COVID test done?
Pardon?
Have you got the COVID test done for all these patients that you're operating?
All by default. Okay. All patients, not only COVID test. See, you go through the guidelines by the Ministry of Health. Right from the outpatient department, you have to follow certain protocols. Protocols for entering the patient into the hospital. We have a designated an area outside the hospital, even for the outpatient department patient, to be thoroughly screened before entering the hospital. for their history, their contact history, whether they belong to the hotspot areas, high-risk patient, immunocompromised, and if slight, then referred for the COVID testing to the designated hospitals. Similarly, only one patient at a time, one attendant only with appointment. So many, you go through the guidelines. And surgery also, there is a long, guidelines they have drafted. We have to follow.
Okay, sir.
You have seen earlier, so many hospitals were sealed where they found a COVID positive patient, though they have stopped now doing that practice. But to save yourself, you have to follow guidelines. Simple.
Okay, sir.
अनुपम को बुलाना हार्ट रेट देखो बोलो
Like in previous case, we saw, Satish?
Yes,
we saw that posterior thyroid artery very clearly. So what are the chances of its damage actually? What are the consequences? Because we not cover it.
Heart rate देखना है. So posterior ethmoidal artery damage is uncommon. I told you the reason is the thickness of the posterior ethmoidal skull base is relatively more.
Yeah, more.
Secondly, if in any given situation, if the posterior ethmoidal artery happens to get retracted into the orbit, that is a disaster. That the consequences are worse than the anterethmoidal artery retraction.
That's why I want to answer.
The reason is posterior ethmoidal artery is close to the optic nerve at the level of the orbital apex.
Yeah.
In a very narrow space. Even if a slightest blood accumulation can result in compression of the nerve or the vessel supplying the nerve without any obvious proptosis. The beauty with the anterethmoidal artery is, fortunately, the patient develops sudden proptosis and we get an alert from that situation that something has gone wrong. With posterior ethmoidal artery, even it makes the patient blind, you will not realize until the patient tells you later, because there would be no proptosis.
Yeah.
And that is very, very unfortunate scenario. So posterior ethmoidal artery injury is worse, particularly if it gets retracted.
Also, immediately after the injury, you will not see anything on fundoscopy. The fundoscopy will be normal in case of posterior ethmoid artery injury.
Yes, because that is behind.
Yes, it's behind.
Now see the level of the middle meatus. Divided a little bit of the polyps, some fungus. This is the region of the uncinate. You can see that?
Yeah.
Uncinate is best identified by its mobility. See, this is the bony projection from the. This is uncinate. This is the bony projection because of the compressed bulla. See, the bulla is gone completely compressed and become a plate. Can you see that?
Yeah.
Because there was fungus, lot of fungus here. So now, our area of interest, see, be careful here in this situation when there is distorted anatomy. This is our uncinate, and in order to look for the maxillary sinus, be careful. Yes. See now, this is the Parsons window.
Yeah.
Now, give me the debrider. And my instrument of choice for these situations is a red 40 debrider. The force.
Please define again the Parsons window, because it is very good point.
See,
commonly asked question for PG and so many exams.
Uncinate has the upper and lower part. This upper part is lower part. And what we did with the backbiter is we made a window in the uncinate to go laterally. See the fungal material?
Yeah, we can see.
And that opens up the infundibulum. So Parsons window is what? Infundibulotomy, you can say, making a window described initially by the person.
One thing we'll observe is whatever little oozing that is seen right now in the mucosa, as soon as Dr. Satish Jain removes all the fungus, this bleeding will be gone all of a sudden. We'll see that as we progress through the surgery.
This is all inflammation little bit.
Exactly.
Otherwise, there is hardly any issue.
No. There's not a lot of bleeding, but what I'm saying is whatever little bit we're seeing, that will also be gone as soon as the fungus is removed.
Yeah, I mean,
since he is only 11-year-old boy, what are the chances in the future? Future, what do you think? What he has to follow, because he must be
the
allergic.
follow-up for these patients is quite long. And come back, and that's why for these patients, after the surgery and healing, we subject them to the allergic testing to the fungus. And if we find, if you are able to pick up, we follow them with the immunotherapy. And that is the only way to change the natural course of the disease, because the natural pathology is he is allergic to that particular fungus.
Yeah.
If we can change that, we can give him a cure. Yes. See now, this is the upper part of the uncinate. The lower part you can see I have removed, and I have given a little larger middle meatal enterostomy. Hello?
Yeah.
I have intentionally given a little larger middle meatal enterostomy. Now see the upper part of the uncinate, what I am doing?
Yeah, very
fracturing. Go behind and fracture anteriorly. Why little larger middle meatal enterostomy? Because these patients require a lot of steroids, irrigations, and long-term follow-up. That long-term surveillance is very important to detect problems if it recurs earlier. Now this is the upper part of the uncinate which I have removed.
Vinay.
And see the fungus in all narrow crevices, everywhere is the fungus. So why I purposely kept this case to tell you this is a different endotype of CRS.
Yeah. So a very high recurrence rate actually.
We saw in the first webinar we discussed, there are variety of endotypes of the CRS. Every CRS is not same. If you try to treat every case of CRS indiscriminately with the same line of management, it cannot work. So this is the time of precision medicine. We need to reach to the diagnosis of the pathophysiology of the disease so that we can address that. And the other endotypes we will, in the times to come, we will demonstrate in the next of the webinars, like AERD case, like cystic fibrosis case.
Yeah.
We'll keep them. In times to come, we will demonstrate that.
What is the definition of appropriate enterostomy?
Definition of?
Appropriate enterostomy. How will define it?
No hard and fast definition.
Because we cannot say it.
What I can define is a mega enterostomy. When you go posteriorly, like see in this, posteriorly I reach almost to the level of the posterior wall by means of removing what? At what expense? The expense of removal of perpendicular plate of the palatine bone.
Yes.
Yeah.
If you want to do a type 3 further, mega, I can remove this part of the inferior turbinate over here and flush with the nasal floor.
Yeah.
And type 4 is when I do a sort of medial maxillectomy. Complete gravitational drainage.
Yeah.
Flushing with the floor of the nose. See, the fungus has already made a lot of space here to work. So in next 10 minutes, I will be through. See now, this was the work I have done with a 0 degree. See this?
Yeah.
Clear. I have to flush the maxillary sinus. I have not flushed with the fungus. I will do later.
Yes, sir.
I will show another tool here in this surgery called hydrodebrider.
Yeah, most awaited.
Hydrodebrider is the tool which can be very useful certain times in this fungal disease. The reason being, sometimes you get this incipient fungus into such difficult corners, difficult to remove by your regular instruments. And in this surgery, the goal is to remove the antigen, that is fungus. If you leave even a small bit of fungus, the memory T cells will again come into action and the same precipitate the same situation without a new trigger. So you have to remove the antigen thoroughly, and this hydrodebrider is a jet which can certainly remove effectively from any given areas with its ability to work 360 degree. I will show that. Can you see the frontal sinus region? Hello?
Yes, sir. Yes, sir.
I am with 70 degree.
Yes, sir.
So allergic fungal sinus disease means steroid. Removal of the antigen and steroid. These are the two main stages of treatment, you would say. And to avoid the oral steroid in the future, we are doing this sinus surgery to make the topical steroids penetrating deep without the need of oral steroids. See now, what I am going to use now is the hydrodebrider. See, there is a lot of fungus in the frontal.
Yeah.
Diffuse fungus in the frontal.
Yes, sir.
And this is my tool. I can angulate it as much as I want. See that?
Yeah.
And see, it's a huge, strong jet of water. Strong jet, you won't believe. It will remove every bit of fungus from there. Let me bring out and show you. Yeah, suction.
Beautiful. Beautiful.
Suction. See? See the amount of fungus.
Yeah.
Yes, sir.
And it should be
So
removed.
so sticky everywhere. Remember, boss, we used this earlier in the Agra workshop 2 years back.
Yes. Yeah. Wonderful.
The hydrodebrider.
Sir, what is the role of histopathology in AFRS?
Role of histopathology is to prove the disease, where it was fungus, whether stain positive. Academic interest, there is a clinical diagnosis. I told you, the Bent and Kuhn criteria, if you go through, one of the criteria is the fungal stain positive. So just to substantiate your diagnosis, that is not going to change your management.
Gautam, the freezer was in the sun.
Sir, any antifungal wash intraoperatively, will that give any benefit?
No.
No, absolutely.
No antifungals, please. Antifungals have role in the invasive fungus. That's it. Invasive fungus, invasive fungus is not surgical disease. Invasive fungus is medical disease. Role of surgery is just to remove the necrotic areas to facilitate penetration of the antifungal. That's it. Role of surgery is to open up the blocked sinuses to establish ventilation and drainage. In invasive fungus is a pure medical disease for which for chronic invasive voriconazole is the treatment of choice. For acute invasive, the amphotericin.
Can I add a comment with the permission of the speakers and the moderator?
Yes, Gaurav.
So I had the opportunity of working with Dr. Amin Java, who in fact was trained directly by Dr. Frederick Kuhn, who actually created the Bent and Kuhn criteria. And Dr. Amin Jawar, we call him as the father of modern mycology in ENT today. He's
Can you
done
see here better
extensive
now,
work.
Gaurav?
Yes, sir.
Yeah.
Yes, sir. Yes, sir. So he's done extensive work on fungal sinusitis. And one of the things that we use in a situation like this where you have trapped fungus is hydrogen peroxide. So we use 1:1 ratio of hydrogen peroxide with saline and we flush the sinus. So what this does is the effervescence of the hydrogen peroxide actually lifts the fungus off of the sinus wall, and that helps us to clean the fungus out with relative ease. So that way we don't have to put a lot of pressure and damage the mucosal lining of the this is for those people who don't have a hydrodebrider. In fact, a hydrodebrider is much more gentle in the way it does it. It targets all that force to one single point and flushes the fungus out. But otherwise, what we usually resort to is we use a 50 cc syringe with a curved suction tip, and we put a lot of pressure to do that. So if we can actually use hydrogen peroxide, even in the post-operative period, sometimes we see that the patients come to clinic with a lot of fungus inside their sinuses. We put a little bit of hydrogen peroxide and that lifts the fungus off, and it's easily suckable after that.
What is the concentration? How will you dilute it with? Can you just repeat?
So we just use plain hydrogen peroxide, 10%, diluted 1:1 with saline.
Okay.
Sometimes we even use pure hydrogen peroxide. If the fungus is very resistant and is very sticky, especially in the clinic, we just put some plain hydrogen peroxide and leave it there for about 30 seconds. And that really breaks all the bonds in the fungal filaments. And with that, we can actually remove it with great ease.
Okay,
That's good
okay.
point. Good point.
Yes, good point.
Thank you.
Hello,
Satish, what is
Gaurav.
the yeah?
Gaurav,
Yes, sir.
let me show you the hydrodebrider, what it is. See this?
Yes, sir.
What is the cost and where it is available? Means what is the cost of the debrider?
See this? See this? I can make it 360 degree. Can you see?
Yes, sir. Yes, sir. Yes, sir.
See this? I can make it 360 degree. Now, see in the maxillary sinus, there is a lot of fungus and trapped. You see there. You have
Satish,
seen there. See there?
Udvavi is asking what is the cost of this hydrodebrider?
Around 5 lakhs. Too much.
Only.
Now, okay. Yes.
Yes, sir. Yeah.
See, this is to dislodge the fungus from those difficult areas.
Yes, sir.
Yeah, beautiful. So one myth is there. So we should not use a steroidal spray in AFRS cases before surgery or a post-op surgery.
What?
So many people are asking why to use steroidal nasal spray in pre-op AFRS cases or post-op AFRS cases, because it being a fungus, why to give a steroid? And but I think it's we should. It is not a fungus; it is a reaction actually.
To understand, this is not fungal disease.
That's why.
Basically, this is the immune reaction of the patient to the fungus.
That's why I pointed.
Fungus is not primarily the disease. Number one.
Yeah.
Number two, it is a type 1 antigen antibody reaction for which steroid is the answer.
Yeah, that's why.
This is just an antigen. Nothing to do with that, Mark.
Yeah. That's a myth.
Number one.
They should clear it.
Number one. Number two, regarding the spray and the irrigation. Sprays do not cross beyond the anterior 1/3 of nasal cavity. Now, in the pre-operative situation, we cannot irrigate us unless the sinuses are open. How will the irrigation solution go inside the sinus? So, in the pre-operative situation, the only option of the steroid is the nasal sprays. Post-op, once we have opened the sinuses big like this, now we have the opportunity to penetrate the steroid deep into the sinuses by means of irrigations. High volume, high power irrigations. Nasal sprays have no role. No role in the sense they will not cross beyond anterior 1/3 of the nasal cavity.
Yes.
So for people, it should be very clear. In the pre-operative situation, the option is only nasal spray. In the post-operative, we should irrigate rather than nasal spray. I hope it is clear.
Yeah. Right. So many people are asking this question.
And this disease, this is not fungal primarily disease. Fungus is the antigen for which the body's immune reaction is working. And it is because of the immune reaction we are getting this pathology. So it is primarily the body's immune reaction. See now the maxillary sinus very clear?
Yes, sir.
Yeah, yeah.
This much of the fungus, sometimes it is so frustrating. Sometimes when there is too eosinophilic reaction, we find a sort of butter sauce kind of a picture, cheesy.
Yeah.
And that is difficult. It clogs the suction so frequently.
Yeah.
Straight. Now the only thing left is the posterior group of sinuses, and then we are through. Next case ready. The next case is ready, and that's an interesting diagnosis. A meningoencephalocele.
So Dr. Shirish Ghan from Nasik wants to know that uncinate prevents direct ventilation of maxilla normally. So does uncinectomy gives rise to any symptoms?
Yeah, it doesn't make too much of the difference. Patient gets the physiology adapts to that situation, and it doesn't have any negative impact overall in long run.
So there's a question from Muscat. Indications and technique of Manuka honey sinus irrigation now, right?
Yes. The sinus irrigation of Manuka honey indications I discussed in the first part to treat the possible biofilms, the resistant infection by means of topical antibacterial agent, antibiofilm agent, and that can go inside once the sinuses are open in the post-operative situation only. And Manuka honey is lethal against all bacteria, irrespective of the strain, whether it is a Pseudomonas or Staph aureus. We have been using it quite extensively, and I am a strong proponent of Manuka honey.
On that day, one question was left. People are asking the role of xylitol. What is the future and what exactly it is?
Xylitol can be the future.
Yeah, how means what is?
Xylitol is basically a 5-carbon alcohol.
Yeah.
That is quite effective against all these bacterial infection. Topically, it is very safe to use. That is why it is a promising agent, very safe to use. A lot of studies are being done. It is being established as a very useful agent, but yes, we have to wait for some time for the xylocaine to establish its role. And then it could be a magic. Xylocaine is a drug which is not expensive. That's why it can be the future.
So Dr. Sanjeev Mohanty from Chennai wants to know that can the hydrodebrider be integrated with the same handpiece as microdebrider?
Not really. It is basically a jet.
Okay.
You can develop at your home with some jet system and introduce this concept. Somebody will do sometime in life. That's why I told you 5 lakhs is too much. Okay. You can make a suitable alternative to it, but it is a very good concept.
Okay.
Amazing.
Okay. And so Dr.
Is the sphenoid sinus full of fungus?
Yeah.
Yes.
Is the sphenoid?
Yeah.
Full. And that is the postsigmoidal roof, the cells along the postsigmoidal roof.
So can I add a few points about Manuka honey if you don't mind?
Yes.
Yeah.
So there are 3 mechanisms actually by which Manuka honey acts. The first one is that there is very high glucose content in Manuka honey, which actually provides energy for the phagocytes to act against microbes. Secondly, it's got an acidic pH, because of which it can kill the microbes directly. And thirdly, there was a chemical compound which was called as inhibin, which was produced in Manuka honey. But now we know that inhibin is nothing but hydrogen peroxide. That's why it's so effective. And also, so
Manuka honey as a chemical, methyl glyoxal.
Yeah, that is the most important component. In Manuka honey, the concentration of methyl glyoxal is actually almost 100 times of that of normal honey. So that is the reason why only Manuka honey is the one which works in the nose. None of the others, except there's another type of honey which is called as Jara honey, which is more active against Candida species. So if you are suspecting Candida species, then we can use something called as Jara honey.
Yeah, and Gaurav,
Yes,
for
sir.
medical use, see this
Yes,
Manuka
sir.
honey, once it was propagated, for medical use, there was a lot of fear.
Yes, sir.
So one of the companies, Watson and Hill Laboratories,
Yeah.
took the approval for the exact concentration, calibration of the concentration of methyl glyoxal.
Yes, sir.
Then after a lot of studies done with that concentration and above and below, and it has been proven that the ideal concentration for the Manuka honey, which is very safe to the patient mucosa, at the same time lethal to the bacteria or biofilm, is 1.8 milligram per deciliter.
Per deciliter, yes, that's correct.
That is the concentration which is available by the companies in New Zealand, which we are acquiring. That is very, very safe to the patient.
Yeah. In Canada, it's available as HoneyDoc. That's the name of the brand that we used to
There
have.
are a lot of studies done at a concentration of 3 milligram, 7 milligram, and those were toxic to the cilia.
Yeah.
So you cannot use this like anything. You have to have a proper recommended concentration.
Concentration, yeah.
Ravi from Muscat, he's asking, suppose unilateral AFRS case, will you go for other side also, or will you open the sinuses other side?
No, not really.
Because we have seen many cases after some time.
Our goal of surgery is what? To remove this antigen.
Yeah, but we have seen many cases after some time on other side, in spite of having normal CT.
That's why the natural course of the disease, that's why I told you a different endotype. We have to treat the pathophysiology.
Yeah.
That is a antigen antibody reaction. Patient is allergic to that particular fungus. So that's why the post-operative immunotherapy is recommended. If it works, the patient can be cured. Otherwise, you have to keep taking steroid in form of topical if you have operated.
So we did this retrospective data analysis of how many of our patients actually progress to have disease on the other side, to answer your question, Dr. Pachauri.
Yeah.
So we found that out of almost 312 patients, only 2 of them actually developed disease on the opposite side and required a revision procedure on the opposite side. So for 2 patients out of 312, it wouldn't be fair to the other 310 to undergo the procedure on the opposite side for no reason. And this is a follow-up of 8 years. So that is the reason why we don't do it on the other side.
Kapil sir, your experience, sir, because how often you see on other side after doing one side, because clinically I think it is more than was.
Not too often, Rajiv. I don't, unilateral disease, you treat it, opposite side getting involved very seldom. I mean,
yeah,
it's not so common.
Hello.
So no need to go.
And I think if the other side does get involved, you can always operate on that side as and when it gets involved. There's no need to preemptively.
Hello, boss. Can you see?
Yeah, wonderful.
It's almost done.
Beautiful, sir. Beautiful.
And what I'm doing additionally for my post-operative irrigations. See, there were a lot of disease medial to the turbinate. Huh?
Yeah.
Make this turbinate unstable, and this is a patient which will require long-term steroid irrigation. This is a child where irrigation, we have to make sure that it should be effectively reaching. That's why I'm giving more space.
Yes.
By removing this unstable turbinate. This is the indication for that.
Okay,
yeah.
Funny.
So Dr. Sandeep Karmarkar.
Now see the steroid will reach so effectively. Everything you put your 0 degree in your outpatient department and you will find, you'll be able to see all sinuses. See that?
Yes, sir.
So that is all about this case.
Sandeep Karmarkar.
Yeah, Dr. Sandeep Karmarkar from Pune wants to know that will a small inferior meatal window facilitate fungal debris removal in this situation if we don't have a hydrodebrider?
Not required. Not really. That is more of a blind procedure again. I agree with him. That is something better than nothing. It's a good idea. Dr. Karmarkar is a lateral skull-based surgeon in Pune. Very promising. So that's a good idea. You can irrigate through the inferior meatal enterostomy. But don't forget, don't consider it as a channel for drainage. It will never be. This is what Master Klinger found. The ciliary activity takes the secretion towards the natural ostium, not towards the inferior meatal drainage. But yes, you can get another channel for irrigation. What you can do simply, take a trocar and cannula and go through the sublabial route and irrigate from there. That is much easier, much simpler, without any morbidity.
Okay.
Much simpler. We have been doing for massive maxillary disease. We just make a 4 mm opening by the trocar and cannula, and then put our debrider through that. You can put your suction cautery through that. You can put your any instrument through that to work and get another channel to the most difficult areas of the maxillary sinus. The most difficult areas of the maxillary sinus, anteromedially, inferiorly, anterolaterally, and you can access 360 degree maxillary sinus.
Okay. So, Dr. Vidyasagar has one interesting question that why is this unilateral always if it's immune mediated?
Boss, Dinesh, ये लगाओ इधर. CT scan. Hello, yes?
So why is it unilateral most of the time if it's immune mediated?
The fungus happens to get trapped in one of the sinus on any side. Sometimes it is bilateral as well. So it is a chance, because wherever the fungus gets trapped, the reaction is going to happen. So if it happens to get trapped in one side, it can be unilateral. It's bilateral, sometimes bilateral. We have done many of the bilateral AFRS. So it depends. But the bottom line is it can happen unilateral as well, which otherwise generalized mucosal disease will not. If it is a pure eosinophilic disease, it will be bilateral. But since it is a fungus as an antigen, it can be unilateral as well. कहाँ है? हाँ कैमरा लगा ना? ये वो LED लोगा. So in 1 minute or 2 minutes, I'll be ready with the MRI picture or the scanning of this next patient. उतारना. It's difficult to remove all these.
Toning is most difficult.
So Kirtane sir, Dr. Gaurav Medicari just told us about the H2O2. Hello, Dr. Kirtane sir. Dr. Gaurav Medicari just told us about H2O2. So here even Dr. Prakash Munka wants to know that does H2O2 helps remove all the fungus and crust? What is your opinion?
It will loosen it up if it's a little stuck. Sometimes it is sticking to the surface, it will loosen it up. And then you would still have to irrigate and remove it. Just want to tell you one story here.
Okay, sir.
One of my colleagues did AFS where the frontal sinus was expanded and was full of the debris, and it wasn't coming out so easily. That the posterior wall table of the frontal sinus had been eroded, so the dura was exposed. Not being able to remove the fungus or the allergic mucin, he flushed it with hydrogen peroxide.
Okay.
Not realizing that it can lead to a fairly high temperature. You know, it gets warm.
Yes.
The patient in the ward afterwards developed so many behavioral changes because the frontal lobe had got heated up. So you certainly want to use it maybe in the maxillary sinus, but not in the frontal sinus to loosen it. And maxillary sinus, it's a little easier to remove it going through various approaches. If you have a lot of thing in the frontal sinus, repeated irrigation would be the only way to do it. Of course, what Satish has shown us is something amazing.
Yes.
So that would be the alternative.
Hello.
Okay, sir. Yes,
Yeah,
sir.
yeah.
Yeah, there.
Yeah, Satish, we can hear you.
Hello, can you hear me, boss?
Yeah, you can hear you.
Okay, so I'm all set with the next patient. If the question answer are over.
Yeah.
Yes, sir. Yes, sir. Yes, sir.
with
Yes, sir.
permission.
Yes, sir. Sir, there is a doubt that these CT scan that you're showing, these patients, the CTs is done before, I mean, after the steroid treatment given to them, or
After the steroids.
after the
That's a,
steroids?
see, that's a very good question.
Yes, sir.
The timing of getting CT scan done.
Yes, sir.
See, the role of CT, I told you, is maximum in surgical planning. Not to get scan done every time the patient is coming to you. That is not warranted. So that is important. So I'm
Okay.
set. Next, are you getting the picture?
Yeah,
No.
yours.
Yeah,
Yeah, now.
yes.
Yes, sir.
Like we discussed in the previous webinar, the impact of radiology. This poor fellow had gone somewhere and had a history, this lady had a history of unilateral nasal discharge on the right side. So the doctor, he was intelligent, was suspicious of a CSF rhinorrhea. He didn't even bother to put the endoscope inside the nose to see what is happening inside, and got directly the CT cystonogram done. And CT cystonogram is absolutely clear. With the report, written report, there is no evidence of CSF rhinorrhea anywhere. Okay? Then somehow it came to us with the same complaint. We put the endoscope and we found a mass lesion coming out from above, medial to the middle turbinate. So I immediately got the MRI done, and then let me tell you what is the reality behind there. Now, are you getting the picture?
Yeah.
So in MRI, once you are suspicious of a CSF rhinorrhea, I told you that day, the sequence of choice, the first sequence of choice is the MR cysternography. MR cysternography is nothing but heavily T2 weighted MRI. Heavily T2 weighted means the only CSF will be super bright and the rest of the things in the background will be super dark. That's it. So you can pick up even the smaller leaks. Now, if I go to this MRI from anterior to posterior, I will show 3D. See this. And I will tell you the reason why CT cystogram couldn't pick up. See this? Can you see some mass lesion in the right nasal cavity coming?
Yeah.
Yes, sir. Yes,
And
sir.
so bright. See now? And can you see the brain tissue hanging down? Can you see the brain tissue in continuity hanging down?
Yeah.
Brain tissue in continuity hanging down, and this is the CSF space down. So it is meningo and cephalocele. Let me show you some more good pictures. Can you see that?
Yeah.
This is the brain tissue which is hanging down, and this is the CSF which is collected below. Now, how could the CT cystonogram miss this? The reason is, I told you several reasons that day. CT cystonogram involves the injection of an iodinated contrast in the intrathecal space. Iodinated contrast doesn't accumulate so easily in the basal cisterns. If you have ever seen somebody doing CT cystonogram, you would never advocate. They literally hold the leg of the patient with the leg up and head down for 1 to 2 hours to allow that dye to go in the basal cistern so that they can appreciate the leak. For that matter, in this patient, and it works sometimes if there is a leak at that time of CT cystonogram, it can work. But the problem is, number one, this dye doesn't remain in CSF space for long, 1 to 2 hours, and that's it. Number two, see what is happening in this patient. The encephalocele, the brain tissue coming down, has plugged the defect for the dye to go down. Got my point? So on CT cystonogram, the dye couldn't come down. It couldn't detect anything inside the nose because it didn't come down. And since CT cystonogram doesn't pick up a lesion like this CSF containing, the fluid containing thing, anything, it didn't pick up anything inside the nose. So, surprisingly, the patient had an absolutely normal CT cystonogram, which is actually having a huge encephalocele. There cannot be any, reason for not doing an MRI in all CSF leak patients to get more and more information. And this is a classic example how radiology can change the management. So if you see this in three-dimensional planes, let me show you in the, let me drive. This is drive image. This is 3D image. This is the encephalocele coming, and now I will reconstruct this. Reconstruct this and see. Let me first come to the area of the, yes, this is the area where the brain is coming out, and see here. Can you see in the sagittal plane? Hello?
Yeah,
Yes, sir.
See in the sagittal plane the same meningoencephalocele hanging down the defect. Can you see very clear?
Yes, sir.
Okay.
This is three-dimensional picture of this drive image of MRI. So you have to order the 3D CIS or 3D drive images to get a good three-dimensional picture. And this particular MRI is done 0.8 millimeter. Otherwise, generally MRI is done 4 to 5 millimeter sequences are done. So that is a classical example of how the brain tissue hanging down in the continuity with the meningocele component down and the encephalocele component above, which has clogged the entry of the iodinated contrast of the CT cystonogram down the nose. Any questions?
That's the best point, because there was lots of discussion on that day why CT cystography is not recommended.
To me, obsolete. Only one word. What information you can get from CT cystonogram, you can get the same information from MR cystonogram, absolutely non-invasive, because it can pick up only those leaks which are active at the time of scanning. Where you need to pick up the CSF actively coming down. If you do an MR cystoscopy that time, I had shown you pictures, you can see the continuity of the CSF signal coming down in the nose. If the patient doesn't have active leak, intermittent leak, difficult to detect, then you have to do an intrathecal gadolinium enhanced MRI, because gadolinium stays in the intrathecal space for more than 24
hours. Yeah.
Yes.
And you can repeatedly do MRI to pick up that intermittent leak, and that repeated MRI is feasible because MRI is radiation free, which CT is not.
Yes.
So looking at these scenarios, we have to order the proper investigations in our practice to get optimal information. Any questions?
No, sir. No question.
The question for Dr. Sethi, sir, what's your protocols for this CSF cases? Satish, in the meantime, you can start this. You can prepare for the surgery. Hello.
Yes, I'm here.
Satish, yes, you can go for scrubbing.
Scrubbing.
Okay, I'll be ready in next 5 minutes.
Yes.
Sethi, sir, and sir,
this is the last
what's the
phase of the
protocol
day.
for the CSF cases? Because there is still so many people are go for this thing.
No,
transparent.
Rajiv, way back, I think, 1998, we published on this that we used to do a plain thin cut section CT scan.
Yes.
And if you saw suspicious area, and if you were not sure, instead of doing a CT cystoscopy, we advocated, like Satish said, a T2 weighted MRI. Now, we published this in, I think, 1998 in the American Journal of Neuroradiology. And in 95% of the cases, we could get a correlation between the CT showing the defect and the MRI T2 weighted coming down. So we don't do CT cystoscopy. We prefer to do a T2 weighted gadolinium intrathecal and do a gadolinium enhanced MRI scan rather than a CT cystoscopy.
What about Dr. Sethi, sir? What is your opinion regarding this? Dr. Sethi, sir,
This is the first time I heard Satish talking about CT cystonogram and how it's done and how they hang the patient upside down. So we have never done it. And basically, we do a fine cut CT scan. I think it has its advantages. Basically, if the defect is very large and you can see it on the CT scan, and MRI cystonogram, like the Satish has already described, we do that. These are the gold standard investigations, radiological investigations that we do. Beta transferrin is the routine, but the problem with beta transferrin is that we have to send the specimen overseas. We still don't do it here. And that takes a few days, and sometimes the surgery is, patient doesn't want to wait that long. So we don't depend very heavily on the beta transferrin. I think if you can see the leak, if the patient produces a leak, then we assume that there is a leak. And before I do any surgery, I want to see an active leak. The leak should not have stopped, because if the leak has stopped, then the chances of finding it, particularly if there is no defect on the CT scan and there is no encephalocele, the chances that you're going to find it are quite remote. Yeah, quite low. And this experience, this I've learned from doing a lot of CSF leaks in India, particularly. I think we don't see that many CSF leaks in Singapore, and but over the past 15-20 years that I went to India quite frequently, I would do at least 2 or 3 cases on every workshop, and my main experience on CSF leaks is from India, basically.
Okay, okay. Dr. Kirtani, sir, I would like to know, there's a question from Dr. Arshad from Bihar, that how you manage internal carotid artery injury during FESS for young surgeons. What is your suggestion?
Avoid it is the only answer I would say. I have never had the occasion to have an internal carotid artery bleeding, and that's not likely to happen in your routine FESS surgeries. When you go for tumor surgery, etc., that's when it's more likely to happen. So I really have not had a single occasion. Sati or Gaurav, have you all faced this?
I had an occasion during a skull-based surgery case, sir. I think I showed you that video as well. It was a bamboo stick.
Yes, sir. Yes, sir.
Paramita, can you hear me?
Yes, sir. We can hear you.
So I will show some videos of internal carotid injury after this on the talk of complications.
Okay.
Sir, I have a question for Dr. Kirtani sir and Dr. Sethi sir.
So, just to let you know.
Sorry?
I think Professor Aldo Stan has rejoined us.
Oh, great.
Okay.
So maybe he can answer about the carotid injury.
Aldo, do you want to answer about the carotid artery injury, how you'd manage it?
Hello. I'm back again. I'm back again.
So how was
well, it's a good question about carotid artery lesions. I have many things to do. Special.
Hello, Satish sir.
Wait, Satish.
Satish sir.
Hello, welcome sir again. Welcome. Professor Aldo Stan, welcome back.
Okay, thank you. I just answer a question of Professor Sethi about the carotid artery injury. So I have 2 points in carotid artery injury. The first one is if extradural or intradural. In the extradural case, like a lesion of carotid artery into the sphenoid sinus for a sphenoidotomy, something like this, of course, the first tentative is to stop the bleeding, packing. So you need to pack it first. You need to save the patient. You can pack it with everything you have in your home. So try to not put the blood pressure too low, because especially in elder patients. And then after finish this, if you control the bleeding, you can send the patient to arteriography. So because the neuroradiologist needs to check, especially for pseudoaneurysm. The great majority of this patient present pseudoaneurysm after this injury. So the only problem is intradural lesion. And intradural lesion is impossible to pack in. It's impossible to pack in. You need to control the bleeding using some special technique, like to put some plugs of muscle, or use bipolar, something like this, or use other tissues to try to control it. And of course, it's completely different. It's much more danger to the patient with the intradural lesion than the extradural lesion of carotid artery. That's all.
Okay.
Hello.
Yeah, Satish.
Yes, sir. Back to you, sir.
Okay, so Professor Eldestam,
Yeah.
let me give you some details of this patient. This
saw.
patient had a unilateral nasal discharge, went to somebody who got the CT cystonogram done, which couldn't pick up anything. Then we got the MRI done, MR cystoscopy to see, diagnosing it as a meningoencephalocele, which I am going to show you now. How important it is, the MRI in our practice.
Okay, okay.
And for us, CT cystonogram is obsolete. For me, it's an obsolete investigation. We never order. We have better alternative than CT cystonogram. So now, first of all, let me tell you exactly the finding. There was some, the traumatic bleeding little bit because of the contact of the suction. Now see, on the right side, this patient had this mass. See the translucent
Yes.
mass coming out of the, coming from above, medial to the middle turbinate. Can you see?
Yeah.
The middle turbinate is pushed there, and there is a mass. There is a bag. You can see the soft bag coming from above, which we saw. We have already seen on MRI how it is coming down from the intracranial space in continuity with the brain tissue. Can you see that?
Yes,
Yes,
sir.
yes.
And that is our goal. And nowadays, endoscopy is the preferred answer to address this with better illumination. So, this meningoencephalocele, we have seen there is a, this is meningocele with some brain tissue. That's why meningoencephalocele. And our goal is to endoscopically address this issue. So,
Yeah.
Professor Eldestam, in your absence, we finished one AFRS, allergic fungal rhinosinusitis, and one inverted papilloma.
Oh, good, excellent, very good time.
So,
let me ask one question about this case.
Yeah, please.
I mean, looking. What do the septoplast before? I think it's facilitate your approach.
Yes, that's a good idea. I'm thinking of doing that in case I don't get the space. So that's always a good idea to improve your access.
Yes, you improve your access.
Yes, that is always a good suggestion, good idea. Let me see if I think my access is, I'm not able to improve without doing a septoplasty, I will go ahead and do a limited septoplasty.
So Satish,
So this is going to be the last case of the day, and then we'll follow it after with this, with a talk on complications. And as you were discussing about the carotid artery, I'll show you some videos of carotid injury, which were recorded live to share with you, and the protocol to manage what we are following.
so Satish, you wanted to discuss some interesting case operated Dr. Kusum Patidar case operated 1 year back, last year.
Yeah, actually that was a diabetic patient with a frontal bone osteomyelitis and CSF leak as well. So that was a different story altogether out of this context, but it was an interesting case which we cannot forget.
So Dr. Sandeep Karmakar wants to know, is there any associated empty cella as well?
Yeah, there is an empty cell.
Yeah, there is an empty cell actually.
Yeah.
Now, in this surgery, my main tool of choice, or I would say the man of the match tool for this surgery would be cobblator. Like it was in the Pappilloma case. See now, this is meningoencephalocele. I'm using the cobblator to shrink this. See this. Secondly, as Dr. Satish said in the beginning, in his experience, one of the case who had a vessel which was retracted in the cranial cavity, which warranted craniotomy later on. When you deal with the cobblator in such areas, that avoids the possibility of such situation. Even these meningoencephalocele carry certain vessels coming out of the cranial cavity along with this, and I will show you how coagulator can certainly avoid all that complication.
Yeah.
So my surface coagulation is shrinking the meningocele. Can you see?
Yeah.
Yeah.
Now the lower part, which is away from the critical skull base region, I can see now I'm using the cutting tool. Until now I was using the coagulation, now cutting tool to segregate it from the upper part. So we can get some more space. See this?
Yeah.
I can easily separate. This tool is amazing. It's a multi-purpose tool.
Rajiv, can you ask whether there was any prior history of trauma in this patient, or was it totally spontaneous?
Not, sir. No history of trauma.
Okay.
See this part of the meningocele I removed. Later. Ultimately, I have to chase to the level of the bony defect. It's not about you find a defect and try to seal it. It cannot work. Always, you have to always go to the level of the bony defect so that we can seal it properly. And I will show you our technique of multi-layer repair in these situations. See these vessels coming from inside, little bit of the oozing. You can control with the coagulator. See that?
Yes.
So effective it is.
Yeah.
You have one single tool with so many functions.
Yeah.
This is called magic wand. This has the ability to coagulate, ability to cut separately, irrigating all the time, and has an inbuilt suction.
Is that the superior turbinate remnant?
Yes. Yes, dear.
So, Dr. Pratibha from Thane wants to know, did this patient have any neurological symptoms or signs?
No neurological symptom. This particular patient has
Nasal obstruction.
This is the part of the turbinate which is adhered to, which I am separating.
Sir, I have a question for all of you. What's the maximum number of CSF leaks that you've seen in a single patient? I think we can start with Dr. Kirtane probably.
5.
5. Dr. Aldestam, how many CSF leaks have you seen in a single patient? Simultaneous.
I'm sorry.
It's not simultaneous leaks, it's excrescences. It's not leaking from 5 places, but you have these little meningoceles coming down, and you seal one, and after a few days or weeks, another one is going to open up. So, especially in these spontaneous patients, you can have more than one sort of pseudomeningocele hanging down, and sometimes it is bilateral. So it's got to look at both sides.
It's very common. It is very common to have many places. You usually have just one place. The problem is sometimes you have a very large defect into the large meningocele into the nasal cavity, and the defect is small. Like this, for example, it's a large meningocele, and probably the bony defect and dural defect is small.
Okay.
We see that more in these ladies postmenopausal obese, where they have a very poor bone density. Empty cell typically, and if they don't leak on the same side after your surgery, if they leak on the other side, they don't blame you. But otherwise, if after 6 months they come back with a leak on the same side, they say that your operation was not proper.
Not good.
When you look front and back, you do tend to see a few more areas which are showing a little prolapse and perhaps are likely to open up later on.
Satish, so how about you?
Well, I had a patient with three simultaneously at the same time, but this is a patient with benign intracranial hypertension.
Okay. So I actually, Satish, I to ask Sam about this. Sam Leong is my boss in the UK. So we had this one patient. She was about 23 years old or 24 years old. So she's already had a CSF leak repair thrice before coming to us. And we were wondering whether or not our leak repair is going to be successful. So we decided to give her intrathecal fluorescein, suspecting that she might have more than one CSF leak simultaneously. She turned out to have 16 CSF leaks on that day. We found leaks that day. Yes, sir.
These multiple defects, classical example of high intracranial pressure.
Yes, sir. Procedure basically to fix her face. The shape of her face was a bit distraction that was done, and her skull base turned out to be a sieve. So she had 16 holes in her skull base, fixing 6 on that day. So you have to talk to Sam about this, doctor. That's what we had to do at the end of it.
Yeah, in
because she was repeatedly.
You need a carpeting and a flap.
Yes, sir. That's what we ended up.
See now, Gaurav, what I'm doing? I'm removing remnant of the superior turbinate into it and extending I have full control where I'm working.
Yes,
see?
sir.
And this is the remnant of the middle turbinate which I have removed, access this.
Yes, sir.
Now I'm using the micro debrider here, which I will control with my cobblator, but
Ireland, Dr. Farid wants to know that can we use bipolar dithermy if we don't have a cobblator?
Bipolar, yes, you can use. But see, the cobblator is so versatile. It is so quick.
Okay.
It has the ability to irrigate as well. It is very safe. You know, the overall temperature rise, giving less, I would say, collateral damage with a cobblator, because the temperature doesn't go beyond 60 degrees because of the constant irrigation. Okay. So this is what I've quickly done for the sake of exposure.
Yeah. Yes, sir.
Now, because this is what I have removed, is the hanging part, the luminal part of the meningoencephalocele, which is not so important. I could remove it like this without any, not in the critical region, I would say. And now I will make it bloodless, absolutely. I will take 70 degrees and show you the anatomy in this region. What I'm going to do, I will give me that back.
So there's a question from Canada. Dr. Vassal wants to know that could you cut the middle turbinate to improve your access?
Yes, I have
already did. He already cut it.
Okay, you've cut it.
Already done.
Okay.
Yeah.
I will go to the area where the meningoencephalocele is coming out. It is never a large defect. And I will define the bony defect completely and then plug it. What I am doing until now, what I have done, is just access.
When you plan to use a vascularized flap, head flap, etc., what's the indication? Dr. Satish?
Yeah?
What are indications to use the vascularized flap like Hadad flap or mini Hadad flap?
I have certain indications for that, very clearly defined. Number one, for the large defects. For all defects above a centimeter or so, we use a flap, number one. Number two, in all patients who are revision cases, I use a flap. All patients with defects with a high intracranial pressure, I use a flap. All patients post-radiation and all those, I use a flap. So, any patient with a defect in close vicinity to a big system like transcrival, if I'm doing the transplanum, if I'm doing all those, always a flap. So the indications of flap are always defined, and I'm so, see, the people who have revolutionized this endoscopic skull-base surgery are actually Hadad and Basagestagi, who devised that, introduced that flap, the Hadad flap, which has revolutionized the skull-base surgery. In the past, even a small defect, 2 millimeter defect, closure by the endoscopic technique would be considered as a supramajor surgery. The only concern with the defect is, only concern with the bigger resection in endoscopic skull base is ability to reconstruct. Once the vascular flaps have been introduced, Now you can resect in centimeters and you have number of choices. Now we have more than 15 flaps in our armamentarium for the reconstruction of the skull base when we do endoscopic surgery. Right from the frontal sinus to the foramen magnum, there are 15 types of flaps available and we have used them all in different situations. So the flap is something important. It has revolutionized. Now look at this. Now for orientation for everyone where I am working now. Now I will show you. See, this is 70 degree. First of all, I am showing you the coina. Can you see?
Yeah.
Yes, sir.
Yeah, yeah.
Yes. Now see the location of the sphenoid sinus. It is here. See that? Give me
Yes,
that.
sir.
Just to show you, to orient you. Gaurav, in your question, we had a case
Yes, sir.
at a high pressure leak.
Yes, sir.
And when I explored the skull base, I saw 6 meningoseals.
Yeah, yeah. Was it when I was there? Because there was a similar case like that when I was there.
That time.
Yeah,
This is
I
sphenoid
remember that case.
This is sphenoid sinus.
Yes.
Now
Yeah, yeah.
I'm coming up. I haven't done a classical ethmoidectomy.
So will you do any MR angio to rule out any vascular loop in this encephalocele?
Rule out any?
Vascular loop in encephalocele?
We assume a vascular loop always. Assume. That's why I told you we use the coagulator. We coagulate first and then resect.
Okay, sir.
So it doesn't bother, doesn't retract. Now, count dissection. Now see our area of interest is coming into view. This behind is the sphenoid sinus. That is the ethmoidal roof. See that this is nasal septum and this is the lateral wall. And this is my encephalocele. See, this is the defect. Can you see?
Yeah, yeah.
Yes, sir.
That is the defect. So now my goal is to circumscribe from all sides. I will circumscribe it from all sides to reach to the level where the bony defect is, and then I will show you, once you locate, how easily you can seal this.
Satish, Dr. Amit Kesri has joined us. He wants to ask many questions.
Yes, yes, please.
Yes.
Amit?
Yes, sir. Yes, sir. Sir, I mean, what is your indication to do an MRI, even if the bony defect is seen well and you expect that this will be the defect and there is nothing much.
Why to use additional MRI? Amit, first,
because many times sir, we
first to rule out any intracranial pathology leading to this, number one.
Exactly, sir.
Number two, to see any signs of intracranial hypertension.
Right.
Associated, because then you have to counsel your patient. Those who have signs of intracranial hypertension, sometimes that is the primary pathology, and CSF leak, meningocele, and all these are secondary manifestation of that. So you have to counsel them that closing the leak is the priority, no doubt about it, to prevent the meningitis. But then later on, we need to do something to your pressure. You have to monitor that and treat that accordingly. That's why I told that protocol in the last radiology lecture about the protocol. If what we do generally for the pressure, we don't do intraoperatively or preoperatively anything. We operate the patient 24 hours after the surgery. When the CSF dynamics is reinstated, when the CSF dynamics is stabilized after 24 hours of surgery. See, my defect is here.
Yes, sir.
See, my defect is here. I will show this. This is the defect. I will circumscribe it from all around and then we show you. So after 24 hours of the surgery, we do a check lumbar puncture.
Okay.
Why 24 hours? Because the total volume of the CSF is 150 ml and total production is over 500 a day. So CSF almost circulates 4 times of its volume every day. So whatever CSF which was earlier, which was less because of the leak, is now replenished in 24 hours of time after so many circulations to bring it to the normal dynamics of the CSF. And then when we check the lumbar puncture, we calculate according to the pressure of further plan. If the pressure is within 25, nothing else, we do Dimox and some diuretic or something like that. Nothing else. If the pressure is going up to 30, then we may have to take a call of diversion, shunting.
Lumboperitoneal shunt.
Either thicoperitoneal or ventriculoperitoneal, depending upon the patient profile, characteristics, taking the patient into decision making, because the chances of complications, everything are involved.
Yes, sir, got my answer, sir. And sir,
And
will
then,
your
last
repair
point,
material,
Amit,
sir, your repair
last
material? Yes, sir. Okay.
last point in if the pressure is about 30, about 35, then we get the MR venogram to rule out any venous sinus thrombosis. That is very important. I mentioned that
Sigmoid sinus
this year we got 3 or 4 patients stented, had a transverse sinus stenosis as a primary pathology. And you know, if the CSF is absorbed in the venous sinuses, if the
Yes, sir.
sinus is stenosed, the resultant high pressure cannot be corrected by any of these maneuvers like shunting or anything. Then you have to treat the primary pathology of venous sinuses, and that is endovascular. You need to get stented, and we got those patients which are doing very well. So the pressure management is very, very important for these patients.
And sir, will your repair be different in a case where there is an maybe a traumatic leak or a spontaneous leak with res intracranial pension? I mean, the choice of repair material.
Okay, let me show you something, and I'll come to your question. See this. This is my defect, everyone. Can you see this?
Yes.
This is the bone all around. Can you see the bone all around?
Exactly.
I'm using 70 degree for your orientation. Let me orient you. Let me orient you. This is my choana below. See here, below. This is the sphenoid sinus. Now coming to the post-ethmoidal roof, this is anti-ethmoidal roof. And this is the defect. Can you see very clear?
Yeah, yes, very clear, very clear.
With some oozing coming out of the surface of the meningo, this encephalocele. So what I'm using here? Our favorite, that is cobblator. I've used cobblator extensively in the brain. It is very, very safe, I would say. Now, give me one done. Surgical देना थोड़ा. Surgical. See the bony defect all around. Can you see?
Yes, yes.
The bony margins.
Very well, Chin.
That is essential to be delineated. The bony margins all around. And now we'll plug in our way, which I'm going to show you. Give me a small piece of surgical. बहुत बड़ा है. Small piece, छोटा देना. I'll just place a small piece of surgical for a while.
So when you recommend to go for lumbar drain in your cases, CSF cases?
Lumbar drain as indications. For me, in our practice, lumbar drain is a useful thing. Let me tell you a very funny example. A patient, this was 6 months back, came to us with a head injury.
Yeah.
Neurosurgeon examined the conscious, everything was good. 2 days after, he came to us with a CSF leak. We got the CT done. It was from the cribriform roof. You'll be amazed. had a small defect in the cribriform roof, and we just put a lumbar drain to divert the CSF from there. Since it was a fresh leak, traumatic, you won't believe, in no time the leak sealed and nothing was required in the future. So lumbar drain is what I'm trying to say is a basically diversion.
Yeah.
So in our CSF leak repairs, if you have a high pressure, temporarily to control the site of leak with less pressure over it, you can divert the pressure for 4 or 5 days. The issue is lumbar drains have their own disadvantages as well.
Yeah, it has to be.
Infection, pneumocephalus, so many things. And it is not a long-lasting answer. But yes, it works sometime because whatever seal you have given, if the pressure is not much over there for 5-7 days, the seal can take up.
Yeah.
So we generally put lumbar drains in the high pressure situations. In the major resections, I told you, where we use the vascularized flap, still we use a lumbar drain in transclival particularly.
Yeah.
Transplanum and transclival, those are the situations where you can't afford to take a chance of CSF leak. It's an individual perception. We had faced earlier a leak. That's why I don't want to take a chance. There is nothing hard and fast when to use, when to do not. But in any given situation, if you are repairing, you have a large defect and you don't have any flap available, suppose, must put at least lumbar drain. We did a case not very long back, olfactory neuroblastoma, had an entire nasal septum involved. There was no possibility of hazard flap. We had other flaps available, but since the dural defect was on one side and not very big, so we took a chance. We thought, let's put a free graft, we'll put a lumbar drain, and it worked. So sometimes you never know the indications you have to define. But yes, once you find a need of a flap and there is no flap available, must put the lumbar drain. That is something I can recommend.
And few people recommend alternate daily lumbar puncture and take out.
Let me ask the same question to Professor Aldo Stam, who has a huge experience of the endoscopic skull-base surgery. His protocol.
Your comments, sir. Your comments, sir, Aldo sir.
His protocol for the lumbar drain.
Professor Aldo sir, your protocol, sir. Yes.
I'm sorry. This is a question about the lumbar drainage.
Yes,
lumbar drainage. Yeah, for a small defect like this, especially the anterior cranial base, I don't use lumbar drainage usually. And dermal drainage is nice, especially for posterior fossa or transclavial lesion, like a clavius chordoma and a large defect. In this situation, you can use the lumbar drainage for a short period of time, at least 3 days, 2-3 days, no more than. This is very, very specific case. The great majority of the anterior skull base defect like this, I don't use it. As I mentioned before, this is a large mass inside the nasal cavity, but a small dural defect. Yeah. This is interesting. So the key point now here in this operation is to control this bleeding from the intradural space.
Professor, I would also like to know how frequently do you use the Hadad flap? What flap? Hello, Professor? Hello, Professor Aduska?
Dr. Stam?
I'm sorry, I can't hear you.
How frequently do you use the Hadad flap?
Well, good. Now I understand. For pituitary tumors, always.
Okay.
Always. And the question is, the flap is not only created for cover dural defects. You can use the flap for many things, to cover the carotid artery, to cover the desnude bone. So have many ways to use it. It's not only necessary for dural defect. But for pituitary, I use in all cases because the technique that I use is transseptal transnasal. You need to do flap in all patients. In this particular patient here, I think flap is good, but you can use a free graft as well.
Graft.
Okay.
Hello?
Yeah,
So
yeah.
will the repair be different if the same size of leak is in the sphenoid sinus, or we will use some other flap or
Yeah,
same?
see, the need of the flap is individualized. Number one,
Yes.
depending upon the patient factors, age, diabetes, post-RT, revision case, so many factors, they dictate the need of the flap. It's not hard and fast that you can categorize to every CSF leak or something. Now you can see the defect very well.
Very well, sir. And the bleeding has stopped.
And see what I have done. I have made the surroundings raw. Now there are two ways of making the surroundings raw. One is to denude by demucosalizing the area. Okay? And removal of the mucosa sometimes is traumatic, sometimes can invite complications, particularly in the cribiform area. It can open up other leaks. So what we do now, see this magic wand coagulator. I am not removing the mucosa. By means of using coagulator, I am devitalizing the mucosa to prevent future mucosils. And it is equally effective. See that? Now I have almost a centimeter area around, completely denuded. See, this is our area of defect. See this? And this 1 centimeter area all around. Can you see this? Completely denuded of mucosa. Is it visible?
Yes.
Yes, sir.
Now I will show you, we will make sure there is not a single drop of blood coming down. See, I am using 70 degree. And I have a good exposure of this region. I have a good exposure, not only of the meningocele, but the surrounding centimeters, square centimeter, I would say. See this?
Yes, sir.
Completely denuded.
Yeah.
Yes.
So that it becomes receptive to the
Graft
I place. That graft has no value but just reinforcement.
Yeah.
The only thing which has a value now in sealing the defect is the fresh fat tissue which I am going to use. That supplies the fresh fibroblast for the healing. And that is going to seal the defect. I am going to use it like something, a plug half in, half out, so that it automatically hangs over there, inside and outside, to plug the defect completely. Then we'll use a second layer of fascia. At every layer we'll be using the tissue glue, and ultimately we'll reinforce with a packing till outside. So now my first layer is the fat, and we always use the fat soaked in rifampicin solution. Now from this point onwards, at every point of time, we'll be using the materials along with the antibiotics. So the first material is going to be the rifampicin, which we have been using for years together. Is supposed to have a good effect on the airborne Staph aureus, and Staph aureus is a dreaded one, and the fat, if it acquires infection, leads to autolysis of the fat, and that can even lead to lipoid meningitis. So the rifampicin works very well. We have used in n number of cases.
Sir, will you change your scope to 0 degree for the repair, or you will, okay, you are going ahead with 70?
Boss, believe me, this 70 is the most versatile telescope I am used to. I can make it 0 degree. I can make it 120 degree. It is so versatile. See now, I can make it 120 degree. And see now, I will make it 0 degree. See now.
Yes, yes.
I can make it like a 0 degree in the corner, in the floor of the nose. So this is most versatile endoscope. And I learned this art of 70 degree from Professor Sethi. So now what I'm doing simply, I put a Surgicel inside. I'm tucking my fat inside the bony edges. Can you see?
Yes.
I will be happy once it becomes self-holding.
Do you recommend to use cartilage for the support or any this thing?
Never. Never. See, what is Surgicel? Cartilage and something can elevate the dura from below and displace the repair. It is something I'm strongly against that. See this self-holding fat. This is amazing. We have used in our, I told you 9 number of cases, and I will reinforce it because fat is so soft to handle. So I will reinforce with a Surgicel, and here Surgicel works like anything. We welcome the side effect of the Surgicel, that is fibrosis.
Yeah. There's a plus point here.
And that helps in holding the fat in place, you know. Yes. Now see, this is self-holding. Can you see?
Yeah.
Yes.
Can you see all around?
Yeah.
Yes.
This is holding itself half in, half out. Can you see clearly?
Yes, sir.
No support at all. And this is what I want. Now, my next is this tissue glue.
Sir, would you take a Valsalva challenge at any point of time, or you are happy with your?
100% happy. If I have a slightest doubt, I would do that. If I have a slightest doubt, I would use after that topical ferrocin. That can show you if the CSF is leaking. See now, after the tissue glue in place, can you?
Yes, sir. Sir, where is the exact location of this leak, sir? Dr. Prakash Monk also wants to know.
Location of?
Where is the location of this leak?
Leak?
Crib.
The defect.
Posterior cribriform.
Defect. I think they want to know where the exact location of the defect is. If it's in the cribriform or...
Yeah, it is in the cribriform.
Posterior.
I said you, this is the sphenoid sinus.
Yeah.
This is the sphenoid sinus behind, you can see.
Yeah. So it's extending from anterior to posterior cribriform?
Yeah, it is less than a centimeter defect, boss, not very big.
Yeah, not very big.
And in meningoencephalocele, you'll never find a big defect for that matter.
Yeah.
Because once the meninges go down, it is like a Bernoulli's phenomena. They attract more and more tissue because of the negative pressure.
Okay. So usually it has a narrow neck.
Yes.
Unlike that Agra case, 8 centimeter defect.
Exactly.
Yes. So okay. Yes. See now, this is just reinforcement now, nothing else. My job of sealing was with the initial fat, soaked in rifampicin. Can you see that?
Yeah.
And this is the reinforcement. This is the facial lata, soaked in rifampicin again. Can you see?
Yes.
Yes, the color.
See the flat surface so receptive to the graft. Can you see very clear?
Yes, sir.
Yes.
Absolutely. And this entire area is raw from inside.
Yes, sir.
You have seen 1 centimeter around which I placed this.
Yes, the fascia is covering the raw area completely.
Completely. Now the tissue glue again to the margins, particularly superiorly.
So there's a question from Nikhilesh Tiwari, Bangalore. In case of multiple leaks, will you feel putting the peritoneal shunt would be better than repairing the defect?
I have already answered in multiple leagues. Nikhilesh Tiwari, I know, is a neurosurgeon. He has been us as a fellow last year. So Nikhilesh, you have seen that situation here. Multiple leaks means high pressure. And then you need to do a proper skull-based carpeting, I would say. Proper skull-based carpeting and look for the high pressure monitoring post-operatively by all means, by fundal examination and all if needed, the treatment for that. Now see what I'm using. See again, earlier, see the facial layer. Can you?
Yes, sir.
Yes.
Now my next layer, see what it is.
Sir, gel form.
It is a gel form. For the reason I'll tell you. See this gel form. Gel form, I will soak it with a ciprofloxacin solution. Next antibiotic. Gel form sticks so well, and this should be beyond the size of the graft. So to hold the graft completely in place. See how it is sticky too. See how sticky it is. Can you see?
Yes, sir. Yes, sir. Yes, sir.
Yes.
And the beauty of the gel form is to hold water 25 times or more than its weight. 5 times of the weight of the water it can hold.
Yes, sir.
And give uniform pressure. See now, I am soaking it with a ciprofloxacin.
Yes, sir.
And it swells up.
Yes, sir.
And this will give amazing uniform pressure. Gaurav, you have seen me several times. This is our standard technique.
100%. I remember doing this in one of the workshops as well. Remember, you had to catch a flight, so I had to do the repair at the end.
Sir, do all patients require lumbar puncture check for CSF pressure?
Yeah, if you have a suspicion of a high pressure, clinically, intraoperatively, or on preoperative MRI, then.
Okay.
Now see, this gel form soaked in ciprofloxacin, stick to. Now this is going to exert uniform pressure over the inner layer, the layer underneath this. This is amazing. Now the next layer is I am going to keep this pressed for, you can say, 4 to 5 days until the everything inside takes up. So what I am going to use, I am going to press with 2 perpendicular marrow cell pieces, and when we remove the marrow cell, it should not stick to the underlying material. What I am using, you see here. I am using a sila stick to cover the marrow cell.
Yeah, that's the.
Another option would be to put this in the middle finger of your glove, like cut the middle finger of the glove, put the marrow cell into that so that it doesn't stick.
This vertical marrow cell is going to press. See this? It is going to exert a uniform pressure. Can you see this?
Yeah.
And this marrow cell has the ability to swell up, and this will exert uniform pressure. Now it will change to 0 degree, and I will hold this marrow cell. See this?
Yes.
This is the inside marrow cell. You can see very clear.
Yeah.
See, it started swelling up. And what I'm going to do now, I will swell it up with another antibiotic, that is betadine. See how it swells up. See that?
Yeah, beautiful.
And now this soft uniform pressure will exert till outside to pack the nose thoroughly. See this? This pressure like this till outside the nose. Fill up with a there's a betadine and pack with a dressing from outside to keep everything in place. So it is like a 7-layer repair holding from the skull base to the anterior layers. So nothing can displace it, even the bombardment cannot displace it. See now, everything?
Right,
so our layers of repair, the initial layer soaked in rifampicin and the Sergi cell to hold itself, completely seal it. glue, then a fascia beyond that all around, soaked in rifampicin and glue over it, then a full layer of gel foam beyond that, soaked in ciprofloxacin, and then interposing a silastic and keeping one over another Merocell till the anterior nares to hold the entire assembly for 4 or 5 days. That's it. Nothing else is required.
Sir, the important point is not to, when we start repairing, when I was training my senior residents, I saw that when they start repairing, keep the layers. The first layer is the important layer. We have to take care of that layer when you put the another layer. If you do,
yes, the first, the most important layer.
Yes, sir.
Satish.
Hello.
Dr. Mudit Mishra is asking how. Hello. Mudit Mishra is asking how must is to use the tissue glue. Hello.
Don't know.
Satish.
Jaldi. Hello.
Dr. Satish.
Yes, boss.
How it is must to use tissue glue? Is it must or is it any other option? If you don't have any tissue glue, then without tissue glue or with the tissue, what is the option? Yeah, and I would like to ask Kitnes also.
Okay.
Previously, we never used to use glue.
I'll tell you the alternative, which we have used many a times. The next alternative, what we have done in many cases, is the patient's own blood and the platelet-rich fibrin layers.
Yeah.
We draw almost 40 ml of the blood of the patient. We have this thing, what that machine is,
centrifuge.
Centrifuge in the machine, and at the same 100 RPM, we make the membrane out of it. It leaves the erythrocytes out and the rest of the layers along with the leukocytes and platelets with a serum in, and we compress it and make it a membrane. You can make a huge membrane and it is platelet rich, which has a good ability to provide growth factors for healing. It has been proven, it works very well. If you don't have tissue glue, you can do that and it works. We have done many times, it works very well.
Sir, another point is that you can recently Professor Alok Thakkar was here with us. So what he used that he make very small pieces of fat, and it was then like a liquid gel. He just did with the scissors, small scissor, and the fat globulus become a kind of a seed, and then he put it in the syringe, and then he just sprayed it, and it stick it like there. So that was the one point I learned, that he said if the fat is not available, if the glue is not available, you can also use that.
Yeah, maybe I have not used, I don't know.
Sorry, your experience, your experience, because you have done thousands.
I think we had initially no glue, so we used to take the help of the Surgicel and gel foam, as he showed, and then you give pressure from below with the Merocell, and it worked. But today glue is fairly easily available, so I don't see any reason, if you're doing a case, why you should not take that advantage of the glue. It's not very expensive. I think it's about 6,000 rupees or so. So I think it's fairly easily available, and there is no reason why you should not have. In the sense, having the right instruments, to do the right job is important. And those were days when it had to be imported. Today it's available in stock. Most hospitals would have it. Your neurosurgeons also have glue they use. So I think you should use it as an added insurance. But if you don't have it, you can do the same thing what he showed you just now. What is important in that repair is that part of that tissue which you put has to go beyond the defect. It has to go intracranially. That is important. Once it gets jammed, even if you don't have glue, you can use the Surgicel and gel foam to stick it in place and put Merocell pressure from below. That's what we used to do, but now we use glue in every case.
Sir, are there any reported neurological deficit once the encephalocele is excised?
Encephalocele.
This tissue is dead tissue in any case. What was outside that narrow opening is not functioning brain, so that is no issue at all.
It doesn't lead to any problem as such.
Okay. So Dr. Sanjay Helale from Mumbai wants to know what is the solution of venous sinus thrombosis causing raised ICT and CSF leak?
Yes, is a huge role. Venous sinus thrombosis can lead to highest pressure elevation. The reason is simple. How the CSF mechanics is, CSF is formed in the ventricles through the choroid plexus. It passes through the ventricles, the lateral ventricle, third ventricle, fourth ventricle, and then finally gets absorbed in the venous sinuses through the subarachnoid villi. In the sinuses, there is a gradient. For the CSF and the venous pressure, there is a gradient. If the venous sinus is stenosed with a high pressure inside, it will not allow the CSF to absorb. The gradient will be reversed. And in that situation, you have to revert the pathology of sinus stenosis, and the answer is endovascular stenting to get back to normal.
Okay, sir.
Any more questions? And do we go ahead with the talk?
Yes, sir. Sir, there's a question from Abu Dhabi. Dr. Yusuf wants to know that how can be the anterior ethmoidal artery retracted to the brain that dictate craniotomy as it's a distal portion?
Anterior ethmoidal artery doesn't really retract in the brain. I tell you the reason behind it. It can retract in the orbit because orbit is a closed compartment with loose tissue around the artery. Only fat and then inside the muscle around the artery. In the brain, as it passes through the lateral lamella, it is surrounded by a thick layer of dura. Not very thick, but a continuous layer of dura all over the intracranial course, and then it comes out back in the nose again. It doesn't go to the intracranial structure directly. Only thing, it gives a branch anterior falcine artery there. So it is encased in the dural layer, which doesn't allow it to retract. So practically it cannot retract in the intracranial space. Number one, it remains extradural. It gives a branch anterior falcine artery, and then after coursing, passing through the olfactory fossa, it comes back again in the nose. It doesn't go subarachnoid. So there is no question of giving any intracranial bleeding out of that retraction.
Okay, sir.
Well, actually, there is one case that, not my case, it is Scott Graham's case, where it actually retracted inside the brain. And this patient underwent an endoscopic sinus surgery and everything went fine. There was some bleeding from the anterior ethmoidal artery. They cauterized. Next day, the patient was unconscious. And when they did the MRI scan, they found that there was intracranial bleeding and they had to go and do a craniotomy.
Classic example of unfortunate surgeon.
Yeah, so I think it is may not be that common, like for the reasons that you mentioned, but it can happen.
Yes, that's a good point, sir.
I think we can move on to the next topic.
Okay, so we move on to the concluding session as we discuss in 3 webinars about the pros and cons of sinus surgery, so many situations, radiology, surgery, and finally, this cannot be completed, any topic cannot be completed if you don't discuss about the complications. And not only complication, this is the most important aspect. We will discuss the prevention of the complication, that is more important. And most important is management in case they happen to occur. We have discussed in all 3 webinars the fine points about emphasizing the role of anatomy, understanding the details of the 3-dimensional anatomy, the role of radiology, 3-dimensional radiology in understanding the area where we are operating, and that has a huge role in preventing complications. Of course, the surgical experience matters. There are certain situations which are high risk in terms of giving complications. So it can happen to occur. It can happen to occur with the most experienced surgeon also. Complications do happen to occur in the most ideal conditions. What we are supposed to do is to promptly diagnose them and handle them and treat them promptly to prevent further implications. So this talk is all about handling the complications. The complications can be, obviously, look at the CT scan. We have been discussing these all through. These paranasal sinuses are in close proximity to the skull base, close proximity to the orbit, all through the carotid artery, optic nerve, and so many areas. And that makes this sinus surgery a potential source of complications. So we can divide the complications into intraoperative and postoperative. For the sake of discussion, we can divide into orbital, cranial, and postoperative complications separately. Anyhow, so let's go ahead first with the orbital complication, which can be divided for your convenience into minor and major. Paramita, you have to stop me. I have this 3 hours talk. You have to stop me when to stop. Okay? According to the public demand. So the orbital complications are major and minor.
Still, we have more than 5,000 people.
Oh, really? So crazy.
5,600 something.
Okay, great. I'll try to go little quickly, but this is such an important subject. I have a separate 1 hour presentation on management of carotid artery injury. And that is so important. In our series of thousands of skull-based cases, we have seen 4 cases of our own cases where we injured the carotid artery intraoperatively in endoscopic surgery and could manage, fortunately, all of them. So that's the experience I want to share with you as well, because that is the most serious complication one can think of, and one should be able to manage that promptly, otherwise difficult to save the patient. So orbital complication, there are certain predisposing factors. We have discussed all these all through. Predisposing factor, and here the surgeon has to be very, very careful in this situation if he is thorough with the preoperative radiology. Like if there is dehiscence of the lamina papracia, if you are using a powered instrument and working along the lamina papracia, sometimes you may not realize that you have entered the orbital cavity. And powered instrumentation is so useful to carry out the work. You have seen the role of microdebrider, but at the same time, if not used properly, can be the big cause of problem. If you are using in the orbit, enter into the orbit accidentally, it can debride the entire orbit in less than 2 minutes. So you have to be very careful. If there is dehiscence of lamina papracia, if there is revision surgery anywhere in the body are always challenging, fraught with the distorted anatomy, fraught with more bleeding and more loss of, I would say, landmarks. So you have to be extra careful. Extensive disease again makes you disoriented, particularly when there is excessive bleeding and distorted anatomy. One special situation, hypoplastic maxillary sinus, to mention here in orbital complication, because it can be a source of problem if it is not identified and taken care of properly. And another thing is general anesthesia. This is the past when people would talk about the general anesthesia is not as safe as the local anesthesia. And the reason was obvious, because if the surgeon approaches the skull base or orbit, whatever local anesthesia you would give, the patient will invariably experience the pain if you try to breach the orbit of the skull base. And that kind of a feedback from the patient is totally lost in the general anesthesia. So you have to be more careful in general anesthesia, and particularly in the orbital cases or when orbital complication we talk, we need to instruct our scrub nurse to keep an eye on the patient's eye if there are any undue movements of the eyeball with the instrumentation of the instrumentation inside the nose, or if there is any sudden proptosis or anything happening to the patient, so the surgeon can immediately concentrate on that and solve the issues. So these are the predisposing factors we need to be aware of. Coming to the minor and major complications, I listed one by one quickly, looking at the time. This complication which I am going to show you is the most common complication, and everybody in their life must have experienced this complication to a certain extent. In the medical colleges also, the junior colleague can do this. So this is one of the complications which is most common and essential to understand. See what the surgeon is doing. Using microdebrider without taking the landmark in view, in consideration. See, it's just kept on debriding and reached inside the orbit. Fortunately stopped. and see on ballotment of the eye from outside, the surgeon was in the orbit. It was the orbital fat prolapse. And this is one of the commonest complications one can come across, to have an accidental entry into the orbit. I will show it again. And here, the mistake is so obvious. We always do take the landmarks like uncinate and all, and see the surgeon started with a divider to the uncinate, went into the orbit. I showed in the live surgery how close the upper part of the uncinate to the orbit is. And you have to be carefully removing the uncinate, defining the lamina, and then go along that and see what has happened here. So such kind of a complication, if happens to occur, believe me, it's not a major complication as long as you realize and stop immediately. And in that situation, you can, what you need to do is, you don't need to fiddle too much into that. Just leave it. Allow the whatever the blood is coming out to drain into the nasal cavity. Do not pull or push. Don't do this monkey business of pulling whatever the fat is coming out or pushing whatever back the fat into the orbit, whatever has come out. Don't do anything. Just leave it. Just keep an eye on the patient's eye to watch for the proptosis.
So one point I want to add, what Kirtane sir had said in the start of the program, is that the cutting edge of the debrider blade should be visible. In this case, it was not visible if you actually replay the video.
I would say that has come from the Kirtane sir as a message, take-home message.
Yeah.
Always keep the cutting edge of the micro debrider under view. Keep the telescope along the micro debrider. It's a two-handed coordination. One hand micro debrider, one hand telescope. When you are introducing the micro debrider, your telescope should go in along. When you are removing the micro debrider, telescope should come along. And wherever you are using the micro debrider, keep the telescope close to it to keep an eye on the cutting edge of the micro debrider blade. So for the management of this problem, this is not a major problem. Just keep an eye and make sure that you don't pack. Let the blood drain into the nasal cavity. That is not significant bleeding. Those are the small veins of the fat, inside the fat, which tears, and they stop with over the period of time. And ask the patient in the post-operative period not to blow hard, to allow the extravasation of the blood in the periosteum, and always, since you have entered into a sterile zone, to give antibiotics to prevent orbital cell. Another thing is, once this has happened, you don't need to stop the surgery. What you can do, leave this area, relax for a while, go to the other areas and keep operating. Make sure that you don't enter into this area again with a micro debrider and ruin the condition again. That is something required. Otherwise, that is not an indication to abandon the procedure with this complication. Okay? See what happens post-operatively with this complication. This is some sort of the orbital emphysema or some sort of periorbital ecchymosis because of the extravasation of blood, and it settles on its own for the period of couple of days without needing of any active intervention. See this? And this is how it settles down on its own. Any questions? Do I go ahead?
Yes, sir. You can go ahead.
Yes, sir.
So quickly moving on to the next one, that is medial rectus muscle. You see this CT scan, how medial rectus is all along in contact with the paranasal sinuses. This is the medial rectus muscle in the entire length all along the paranasal sinuses. The difference is, see this, observe this, what I'm trying to show. This is medial rectus muscle. As you go posteriorly, it comes more and more close to the lamina papracia. Anteriorly is a protective pad of fat between the lamina and the muscle. So even if you transgress the lamina, this is what the fat which prolapses, and you saw in that video, previous video, how the fat was prolapsing and the muscle was still preserved. So, but as compared to the previous complication, this is not a minor complication, this is a major complication because of the associated diplopia it gives. And that is most frustrating to treat. There is no straightforward answer to it. There are many ways, but still this is most frustrating conditions to treat. And these are the some of the scans of different ways of damaging the muscle. I'll see this. The muscle was entrapped in the bony fragment when the orbit was entered, and this the muscle got involved into this bony fragment and got paralyzed. And see this video in the posterior ethmoid. After removal of the lamina, there is no fat. There is directly muscle in the position with the bony lamina papyracea. So you have to stay more careful in the posterior ethmoids as compared to the anterior ethmoids. And this is another CT scan post-operatively showing the complete transaction of the muscle. And this is a disaster because the resultant diplopia to treat 100% is beyond imagination to treat. So these are another example of transaction of the muscle. So what you can do once this kind of a complication happens to occur? Diplopia is, I would say, imminent. It is going to happen. Most of the time, the muscle is entrapped and you release the muscle and the muscle is by and large preserved. It can come back to normal or the period of time. What you can give to prevent further inflammation, the antibiotics and steroids. Antibiotics and steroids, and let the muscle, the situation improves. But if the muscle is further damaged and trapped, you can release the muscle, you can repair the medial wall, or if the muscle is transected, then it's totally an ophthalmologist call. And they do a lot of procedures to treat this condition. Treat this condition, like they put a hangback suture to the other muscle. They put inject botulinum toxin in the contralateral muscle to paralyze the contralateral muscle, or the transposition of the oblique, superior or inferior oblique muscles or something like that. So these are the procedures they do, but this is totally ophthalmologist domain. It is not our domain and it is their call. But this is certainly a major complication. This we have discussed already a little bit. This is to show the anatomy of the nasolacrimal duct. See this, how it is anterior to posterior as it goes. So what I showed in this, see this, when you use the reverse biting, it should not be turned up where it is close to the nasolacrimal system. It should always be, like I showed in the previous video, engage your reverse biting and turn it down. Turn it down to stay away from the nasolacrimal system. So the management, many times it goes unrecognized. If you are, and most of the time it happens when you are using a reverse biting, and if you are not careful, you bite through the nasolacrimal duct. Ideally, you should stop when you come across the hard bone, because this nasolacrimal duct is formed by a very hard bone of frontonasal process, and then you need to stop once you come across. If you bite through, then the resultant scarring can lead to a problem, but most of the time it goes unrecognized. If you recognize this intraoperatively, what you can do, ask your patient to, you call the patient for frequent syringing to prevent the clot formation and resultant scar. And if it is not recognized and happens to occur, the scarring happens to occur, patient may come few weeks later with the epiphora, and then the final answer is endoscopic DCR. Am I audible?
Yeah, very, very audible. Suppose we find out that it is damaged on table, can we put a stent in same sitting?
Of no value was, by and large, because the resultant effect of injuring the duct is because of scarring. The scarring is the end result which leads to problem once you have injured the nasolacrimal duct. So once you have realized what you can do, you can prevent that fibrin plug and scar formation by means of regularly syringing. So you can wash away anything such happening, and if you don't recognize, the patient may come back with the scarring later on with the epiphora, then you have to treat with a DCR. The next one is a very important complication which we have been discussing, is the anterior ethmoidal artery, and you can see it in this diagram, the both anterior and posterior ethmoidal arteries. See, these are the branches of ophthalmic artery. This is ophthalmic artery. This is the first branch of the subarachnoid segment of the carotid artery. That is the internal carotid flow it carries, and this is the anterior as well as the posterior ethmoidal artery. And the anterior, mostly which is damaged, you can pick up on a very good fine section CT scan. depending upon the pneumatization, as a canal which is coming from the orbit to the cranial cavity. That is orbito cranial canal.
Cranial canal.
So you can pick up by, there's a CT scan in the axial plane also. In a good axial plane, you can see the entire course. See, I kept this to show you, to answer the previous question what Dr. Paramita asked about, and what Dr. Sethi was mentioning, that it can retract into the intracranial space, but though it is very, very uncommon, I heard for the first time. The reason is this artery from here leaves the orbit, enters the lateral lamella to enter the olfactory fossa. From here it runs in a encased in a dural envelope anteriorly to come down in the nose again. It doesn't enter into the subarachnoid space at all. Tightly adhered to the bone, and that makes a, I would say, impression here that is known as the ethmoidal sulcus. And here it gives off a branch to the fox cerebri as the anterior falcine artery. So you can pick up this vessel in the axial, and sometimes it is lying in the mesentery, much below the level of the skull base. So when you are walking under the skull base using powered instrument, you have to be careful. And so this is the video provided initially to me by Professor Sethi. Boss, your video. See,
I think he had to leave. I think he had to leave.
I'm still around, but that's not my case.
He's there.
I got from you this video. You provided me.
Yes. You can see there is a small laceration.
Yes.
It's not truncation.
And that's what Professor Sethi was saying, to use a suction bipolar. Suction bipolar. If you have a good suction bipolar, you can certainly seal it in no time. Otherwise, such a small rent, believe me, if you don't have even this, you just leave a small layer of Surgicel and press it with a Merocell for 2 minutes, and it stops on its own. This artery is a very small artery. It doesn't bother much with such small rent. This video is to show you this injury just close to the lateral lamella. This is dangerous. This injury, which is so severe to have injured a vessel here, is good enough to injure a very fragile lateral lamella. Very thin, fragile lateral lamella to give a CSF leak. So you have to be very, very careful. And the answer is same. Now, why we are so scared of this vessel? It's not because of the bleeding, because of the resultant implication. And this is one of the most dreaded complications, which is a potential of giving a permanent visual loss if not managed promptly and effectively. And this is what I am here to discuss, the intraorbital hematoma, how this hematoma can happen to occur. If this vessel coming from the orbit, I told you, it is not encased in any dural envelope or anything inside the orbit. Inside the orbit, it is loose lying in the fat. So it passes through the loose fatty tissue. So if this vessel happens to get transected at the entry into the ethmoidal roof, close to the orbital exit, it can get retracted, and then it can lead to this kind of a sudden proptosis and hematoma. This eye, and this we need to understand why it is so important, because eye is a closed bony compartment from all around, except anteriorly, which has a fibrotendinous diaphragm. See this, 7 bone forms the orbit from all around, except anteriorly, which can expand to some extent, otherwise the rest of the orbit cannot expand. Even an extra 5 ml accumulation of blood inside the orbit can be good enough to give complication, to compress the critical structures, the optic nerve and the vessels supplying the optic nerve. So to understand this visual loss physiology, the normal pressure is 10 to 20 and the volume is 30 ml. If there is increase in the orbital volume, I told you, even the 5 ml is good enough to compress the optic nerve itself, or the central retinal artery, or the posterior ciliary vessel supplying the optic nerve. So how can you diagnose? If you keep an eye on the patient, then you'll find a rapid proptosis developing. That's why you need to instruct your scrub nurse always to keep an eye on the patient's eye if anything of such happens to occur. And then if there is a rapid proptosis and sudden tension in the globe, the eyeball gets fixed, then it is the time to act fast, because it doesn't give too much of time to save the vision. And here we are fortunate. We human beings are fortunate as our retina has a capacity to survive ischemia for longer duration as compared to the brain tissue. Like in the brain tissue, if hypoxia extends for more than 5 to 10 minutes, it undergoes irreversible damage. But in the retina, we have enough ample of glucose storage in the vitreous, and the metabolism of the oxygen, the glucose metabolism different from the brain. It can sustain the hypoxia even for 90 to 100 minutes. But that time is even short. If you don't realize in that time elapses, it can be a disaster. So if you do the fundal examination, there could be optic nerve failure or retinal shutdown. But for the final diagnosis, the cutoff point, what we need to know is whether our optic nerve has undergone permanent damage or not. If it has undergone permanent damage, then obviously we have to act fast, and it's difficult to save that. Idhar karo. Idhar karo. Idhar karo. अरे नीचे कर दो यार, इसको कर रहे यार नीचे इसको. हाँ. So in that situation, the test what we do intraoperatively, even general anesthesia, under general anesthesia, is the afferent pupillary reflex test. So what is afferent pupillary reflex test? Huh? Laptop क्यों नहीं आ रहा? आ गया?
Now it's coming.
Coming? Yes.
No,
Is
it's
it
okay.
coming?
No, it's okay.
Yes,
Yeah,
yes.
coming.
Yeah. So what is afferent pupillary reflex test? That you can do intraoperatively on the table. This is what this particular situation gives a situation of a Marcus gun pupil. So to understand that, simply the optic nerves are the afferent, and they go to the pretactile nucleus where the fibers decussate to the opposite side, both sides, and then to the Edinger-Westphal nucleus, again decussate to the opposite side, and from there the efferent in the form of oculomotor nerve go to both sides. So what happens? In such eyes, if you test with a light reflex, since the afferent have gone, there is no light reflex. But if you throw the light in the other eye, because the efferents are intact and the fibers decussate to the opposite side, in spite of the eye, the optic nerve not functioning, if you throw the light to the opposite eye, you will find the reflex in the same side eye, the affected eye as well. That is Marcus gun pupil. That is afferent pupillary reflex, and that is diagnostic that you have lost the vision. And as long as the afferent pupillary reflex is coming, you have a time to restore the vision by means of all those measures to either orbital decompression, canthotomy, whatever. But that is the time period you have to save the eye. And even in this era, I've been seeing many of the patients coming to us who are operated and had lost the vision. And this is something very, very important for the sinus surgeons to know, to protect the eye, to preserve the eye in such unfortunate and difficult scenarios. Still you can preserve the eye if you know the management. So management, as I said, the orbit is a all around bony structures, and whatever extra blood which is accumulating, you have to manage both ways. Either you can increase the volume of the orbit to accommodate extra blood and it doesn't compress, or you can increase the blood volume. You can increase the blood volume inside the orbit. So what you can do is इधर करो. Yes. So what you can do, you can increase the volume of the blood. That is more feasible, because reducing the blood volume in the orbit is not so simple and it is not so effective. But still you have to try everything in that scenario. You have to decrease the blood volume in the orbit by means of giving IV mannitol. You can give corticosteroid to reduce inflammation, or you can give Dimox, you can give topical timolol, you can do so many things. It doesn't work much, but still for the sake of doing it may work a little bit. But the thing which can work is the orbital massage, provided the patient has not undergone any ophthalmic surgery recently. You massage the orbit to allow the vessel to go into spasm. See, this vessel once starts bleeding, this is artery. You cannot catch the artery inside the orbit. If you try to go and catch the artery inside the orbit, you'll worsen the situation. So what all you can do is, you can pray God for the vessel to stop bleeding. Orbital tourniquet is what? You can compress the orbit, release, compress, release for the artery to allow to go into spasm. Those are maneuvers which can help you. But the most important thing in the emergency situation which can work is the increasing the volume of the orbit. So there are many ways you can see the listed how you can increase the volume of the orbit. The most effective and the fastest one you can carry out in less than 10 seconds. Just take a scissors and cut the lateral canthus and allow the orbit to I to prolapse anteriorly, and this will immediately reduce the intra-orbital pressure significantly. And even if this doesn't work, what happened? Yeah, if this doesn't work and still the pressure is building up because of the ongoing bleeding from the artery, what you can do further? See, after the canthotomy, what you see there, the zygomatic bone. Wait till the zygomatic bone retract inferiorly, and then you'll find the inferior canthal tendon. Take a scissors and cut the inferior canthal tendon, which is holding the eyeball further, and I will completely prolapse outside. And that will further reduce the pressure. Most of the time, 99% of the time, properly done canthotomy, and if required cantholysis, are good enough. Until then, the vessel stops bleeding, and you can save the eye. But even those maneuvers do not work, and still the artery is bleeding in the unfortunate situation, what you can do is endoscopic decompression. We have an endoscopic field open. Just go inside with the endoscope, remove the lamina papracia, and make the cross hatching on the periorbita and allow the fat and the orbital contents to prolapse inside the ethmoidal cavity. And that is something which will reduce the pressure immediately inside the orbit. Even if the artery is bleeding, it will drain the blood inside the nasal cavity. It won't allow it to accumulate inside to result in pressure again and again. And most of the time it works. Why it is not the first choice? Because it may take time. The canthotomy can be done in less than 10 seconds. And that is the first treatment. It has no side effect. Once it heals, you won't even appreciate the scar. Even if the bleeding doesn't stop or the compression doesn't stop, what you can go sublabial and go to the floor of the orbit and take the floor bone down inside the maxillary sinus to give further decompression in the extreme situation. But you should be able to know all these maneuvers to save the eye in these unfortunate situation of this complication. Every sinus surgeon should be able to handle that situation.
Canthotomy heals by itself, or do you need to do something afterward?
Pardon?
The canthotomy heals by itself, or you need to repair it afterward?
No need to, boss. It is such a fine, it is a crease in the line of the lateral canthus.
Yeah.
You leave it, you don't even have to suture it. It falls back in place and there is hardly any scarring. It heals in no time without giving any significant scarring.
Okay.
Okay, sir. Also, there's a question in the management of this medial rectus injury. How does muscle transposition work in regard of innervation and movement coordination? It's a question from UAE, Dr. Isam.
It's difficult. I told you that is a call of ophthalmologists. We don't do that.
Yeah.
And according to them, these are very difficult procedures with no control over the final outcome. That's why this is a very frustrating complication, I would say.
Yes, sir. And so one more question, Dr. Pranita from Warangal wants to know that if we are sure that NLD os damages, can we do DCR in the same sitting?
Not to, because all NLD damage do not give permanent epiphora.
Okay, yes.
Less than 5% result in a final symptomatology of epiphora, 95% heal without any issues.
Okay, sir.
You don't need to do DCR at the same time.
Okay, sir. Okay, sir.
Any more?
No, sir.
So coming quickly to the next one, that is optic nerve injury. So optic nerve, we all know, we saw in the dissection, in the surgery, that it passes in the posterior lateral wall of the sphenoid. If one of the posterior ethmoidal cell, generally what happens, behind the posterior ethmoid is supposed to be sphenoid. If one of the posterior ethmoidal cell over-pneumatizes over the sphenoid and beyond that, what happens? This sphenoid sinus is pushed infiromedially And this cell is going above and beyond the sphenoid sinus. So what happened? The optic nerve comes to lie in the lateral wall of this cell rather than the lateral wall of the sphenoid. And while doing a post-sphenoidectomy, if you don't realize and keep on going behind to look for the sphenoid, you can easily damage the optic nerve. That's why the technique we use, which we propagate, you have seen today, the moment you go behind the go behind the the basal lamella, stay medially, look for the superior turbinate, stay medial to the superior turbinate, identify the ostium, and stay anterior to the ostium while doing a post-sphenoidectomy. Because in any given ONOD situation, if you stay while doing post-sphenoidectomy anterior to the sphenoid ostium, you cannot damage the optic nerve at all, even if it is ONOD. That is the best way to prevent the damage to the optic nerve. And you can pick up this ONOD situation by all planes of CT scan. In the coronal, you will find a horizontal septa, sagittal is classic, and in axial, you can find a very good relationship of the optic nerve and the cell. You have some of the pictures where extensive disease, fungus, pressing on the optic nerve, patient coming with a vision loss, and the optic nerve very, very decent inside the, projecting inside the lumen of the sphenoid. A lot of people calculate the probability of optic nerve, prediction of the optic nerve injury by means of the relationship of the optic nerve to the sphenoid sinus, whether it is in the wall, whether it is dehiscent, whether it is projecting, or whether it is passing through the lumen. You can, according to the radiology, you can stay more conscious while dealing with the area around the optic nerve, the sphenoid sinus. So, in any given situation, injury, if happens to occur, either it is direct, physically injuring the optic nerve, or the indirect, which transmits the into the optic nerve, and that leading to edema in the optic canal, which cannot expand, leading to nerve compression. Whatsoever, traumatic, post-surgery, whatsoever, the optic nerve injury is again a very difficult thing to treat and predict. But the management is by and large same, to start immediately the bolus dose of steroid along with the maintenance dose and get scan done meantime. If there is any bony spicule, impinging, fracture line, you may have to immediately explore. If doesn't, wait for some time. If the condition doesn't improve or deteriorate, in spite of not having any fracture line on anything, still there is indication of optic nerve decompression. And there is a controversy whether to slit the nerve or not. We belong to the school of slitting the nerve to give more effective decompression, though you have to be careful not to injure the ophthalmic artery or worry of the CSF leak and other things. But yes, that gives a more effective decompression as compared to not slitting the nerve. So that is how you can manage the optic nerve situations. Then the carotid artery, let me show you. I had shown you that day already. The video of the carotid artery.
Yes.
I think I don't need to show it again.
No, I think we've already seen it.
Yeah. So many a times, see, the carotid artery injury involves a lot of things to understand the anatomy and the anatomical variations. See, these scans, how the carotid artery has a huge kink in the parapharyngeal space, almost close to the level of the mucosa in the pharynx. See how in the nasopharynx the carotid is coming in the midline.
Yes.
They are doing some pharyngeal surgery. It can be a disaster if you don't know this fact. So you have to stay careful. The loops and kinking and all these things are very common in the parapharyngeal space of the segment of the carotid artery, though mostly in the lower parapharyngeal space. Because in the upper parapharyngeal artery has to straighten up to enter into the carotid foramen of the temporal bone. So around the tonsil, in the region of the tonsil, most of the loops and kinking and all these things happen to occur in the carotid, where you have to stay more safer. These are the kinking of the, see how severe kinking of the parapharyngeal carotid artery you can see. Now, coming to the endonasal surgical perspective, the carotid, we always propagate this concept. Look at the CT scan. this is the arch of the atlas. These are the longus colli muscles. See that? Longissimus capitis muscles. And then this is the tumor or the nasopharyngeal space otherwise here. See, this is the muscles. These are the muscle and this is the arch of the atlas. What do you believe when you are working in this region? Take the reference of the surface of the muscles. As long as you take the reference of the surface of the muscles and stay anterior to it, whatever laterally you are going, if you stay in the plane of the surface of the muscle, your carotid is almost a centimeter behind. You don't need to bother about that. And this is a very, very important parameter to stay safer and do a complete job rather than terrifying with the carotid artery while working in this region and do a subnormal job for the fear of carotid artery. So carotid, if you see the course, by and large, is a parapharyngeal, it ascends towards the temporal bone, and there's a small vertical course, and then anterior to the cochlea it turns the genu, and there's a big horizontal course, and then at the foramen lacinum again ascends up to become the cavernous carotid. That we should know. In all dissections, we should try to dissect the course of the complete carotid to get used to the course of the carotid artery, how it ascends, and the petrous, horizontal and vertical course. In the ear, you can see the carotid, how it turns. See this horizontal, the vertical genu, this is cochlea, and then turns anterior to become the horizontal carotid artery. And these are the course of the horizontal, and then the foramen lacinum to go up. Some of the dissection, and then after that it becomes the vertical cavernous, posterior genu. You see here the posterior genu, horizontal anterior genu, and then the supraclinoid and subarachnoid. And this is the portion which is most important for the sinus surgeon where the carotid is injured. This is the area which is injured most often by the sinus surgeon. In the sphenoid, this area of the carotid, this is optic now, this is carotid, this is opticocarotid recess, and this anterior band of the cavernous carotid is most liable to be injured by the sinus surgeons in the sphenoid sinus. So we need to understand the anatomy of this region. See this vertical carotid, posterior genu, horizontal, anterior genu, and then supraclinoid. And this anterior genu is most susceptible to injured by the sinus surgeon. We need to understand and how tortuous is the course of carotid artery. See how tortuous the course of the carotid artery. The reason is the tortuosity is very important in planning the stenting of the carotid artery in case of unfortunate rupture of the carotid, because all those metallic stent cannot pass through this tortuosity of the cavernous carotid to apply onto the vessel wall. It can dissect the vessel, and that can be a bigger disaster. So this tortuosity is important factor. See this endoscopic picture. This is pituitary, this is optic now, and this is the anterior band of the cavernous carotid, which is at risk by the sinus surgeons. This is the pituitary, and on the other side of the paracellular anterior band of the carotid. Hope you are oriented what area I'm
yes,
which is susceptible to be injured.
Yes, sir. Sir, there's a question from Dr. Vinod Felix. He wants to know that is it safe to use coblator in the intradural tumors?
Which tumors?
Is it safe to use coblator in intradural tumors? We have used it in few scenarios and other tumors. Wanted to
Yes. Vinod Felix is an amazing skull-based surgeon. I know him.
Yes.
Believe me, he is a source of inspiration for many.
Yes.
And his question is valid. I have already told several times, it is safe to use on the brain itself with no issues. We have used several times without any implication. Rather, it gives less collateral damage as compared to the bipolar cautery, I tell you, because it is constantly irrigated and it works on a bipolar principle as well.
Okay, sir. Sir, inferior orbital decompression can cause diplopia. Dr. Yusuf from Abu Dhabi has.
Yes. Any orbital decompression will result in some or other extent of diplopia, any orbital decompression. Even if you do medial, you can reduce by keeping a sling intact or reduce by doing a little less decompression or some other means, but the diplopia is going to happen with any orbital decompression. It may settle down over a period of time once the fibrosis takes place. but the diplopia is imminent.
Okay. Dr. Arshad wants to know that anterior ethmoidal artery comes back to nose after giving the anterior falcine artery. Is there any landmark for this?
Yes, Arshad.
Yes.
Arshad is again from Bangalore, a dear friend. Master, and I've visited his center.
Of everything.
Amazing, amazing. So his question is again very important, and I have in the cadaveric dissection several times shown the flap based on the nasal segment of the anterior ethmoidal artery after traversing the brain coming back into the nose. Once it comes on the upper part of the nose, you can take that area of the nasal septum 1 centimeter on either side down to the floor as a flap based on the anterior ethmoidal artery, and that we use. That's a very good flap to close the septal perforations. You can use for the skull base as well, but it is very good. So the area where it comes into the nose in the upper part, you can relate to the level of the axilla. It is above and behind 1 centimeter above and behind the axilla, where it exactly comes down in that vicinity back into the nose. And from there, it goes again up to the dorsum of the nose underneath the nasal bone at the junction of the nasal bone and upper lateral cartilage. So that area is important.
Okay, sir. Okay, sir.
So after that segment, the next is the cisternal segment. This ICA, as it goes up in the subarachnoid segment, there are 3 segments of the intracranial part. The first, it gives the ophthalmic artery and the superior hypophyseal artery. Then the next segment from ophthalmic to posterior communicating, which joins the posterior cerebral, that is communicating segment, and then behind is the anterior choroidal artery. So there are a number of branches. After that, it divides into anterior and the middle cerebral. This middle cerebral is the main vessel supplying the the temporal lobe of the brain, passing through the sylvian fissure. So this is how this vessel forms the anterior communicating complex above the chiasma, and this is how it divides into anterior and middle cerebral artery. So entire course of the carotid should be, I would say, a skull-based surgeon should be well versed with. The what you call this circle of Willis, we must be aware of, and in any given situation where the tumor is invading, abutting, or in close proximity to the carotid artery, we have to be careful about looking at the cross flow at the level of circle of Willis in case of, in any unfortunate event, if we happen to injure the carotid artery, because accordingly then we have to take a call to deal with that situation. So this is the circle of Willis, how the posterior circulation from basilar and anterior circulation from 2 carotid are joined together by the communicating vessels to form a circle. And this circle, anterior and posterior communicating vessels forming the circle of Willis, the integrity of the circle of Willis is very important. In case you sacrifice the one carotid, if the circle is patent, you can have a good cross flow from the opposite side and the patient can remain asymptomatic. So that is important. So about after this anatomical part, there are a lot of concerns about the carotid artery injury. So what are the concerns? Carotid artery, we know, is a major vessel, blood loss. It can lead to pseudoaneurysm formation. Once it is injured, can go in spasm, thrombosis, embolism, carotid cavernous vena. All these are dreaded complications once the carotid is injured. And this series of events are dreaded to the patient if carotid happens to get injured. So management involves a proper preoperative assessment with the planning. As I said, the cross flow management, the assessment is very important. Operating surgical maneuvers are very important to work around the carotid artery with a blunt instrument, with the diamond drills and all those, rather than pulling the bony spicule and all that. And the post-operative assessment and management of the, in case the vessel happens to injured, we should be able to handle it promptly and immediately with a team. It requires a teamwork. So pre-operatively, we should be very much familiar with the anatomy, imaging, and the collateral circulation. Imaging, what imaging we need? When the carotid is a concern, when the tumor is in close proximity to it, good high definition CT scan, MRI, MR angiogram, CT angiogram, DSA is a gold standard, digital subsection angiography, which can find out even the minor changes on the carotid wall. And the most important, in case you want to confirm the cross flow, for sure, is the balloon occlusion testing. So, collateral flow, that is the most important. So, like we are doing any case where the carotid is involved, and that's a very routine phenomena in tumors of the skull base, you need to thoroughly assess this, because the entire post-operative outcome, in case the vessel is sacrificed, depends upon the cross flow. Many ways, if you go to literature, there are hundreds of ways to assess the cross flow. But I tell you practical 3 ways what we take into account in our practice. One, first is a balloon occlusion test under hypotensive condition. That is most important. Second is the venous phase difference on either side after occluding with the balloon. If there is too much of venous phase difference, more than 2 seconds, that means the flow is not adequate. And third is to put another balloon on the opposite side with a catheter and see the stump pressure. Back pressure after occluding the carotid on one side and back pressure beyond the catheter on the opposite side. If the back pressure is more than 2/3 of the systolic pressure, that means the perfusion is good from the opposite side. And those three together constitute almost over 90% sensitivity that if the patient passes these 3 tests, is unlikely to have a stroke. Otherwise, any single test listed out of here is not more than 80%, 75 to 80% sensitive. If you do any single test out of that, the chances of stroke are still 25%. So we have to be careful about assessing the collateral flow. Now, when carotid, we talk of carotid injury, there are certain factors which are considered as the high risk factors. Anatomically, if there is a decent ICA, bulging vessel, you'd say if you're walking the sphenoid, it's a kissing vessel coming close to each other, displaced by the lesion itself, or the sphenoid, any septa attached to the vessel, or any vessel wall abnormality, thinning, like it can happen due to previous treatment. It can happen in acromegaly. There are high risk, aneurysm, pseudoaneurysm, so many things. So tumor which invade the carotid, their characteristic, as I mentioned, acromegaly are high risk because they induce changes in the vessel wall itself. The carotid become more attractive and come close to each other. Post radiation, post bromocriptine therapy, or so many factors which may make the carotid high risk, and you have to be very, very careful. These are the situations that the carotid is bare, without any bone in the sphenoid. See the kissing carotid almost coming close to each other, and see all this. These are the classical examples that you have to be careful. In pituitary cases, if you have a smallest doubt, you should get a angiogram to see if there is any pseudoaneurysm or something, which could, if happens to rupture, can lead to a major complication. So you have to be careful about tumors which circumferentially invade the carotid artery, involve the carotid artery, is where the wall becomes ectatic. You never know how much of the changes in the wall, and when you try to remove the tumor without controlling the carotid, can be disaster. These are the tumor situations where the carotid is involved, and you have to be very, very.
Sir, can I ask a question?
Yes, please.
Sir, when we do pituitary surgery,
yes,
the hypophyseal artery, when it is a branch of the carotid artery, so I mean, how to prevent injury? Because in one patient, it happened that we were able to control it intraoperatively by bipolar coagulation, but later on, 2 weeks later, the patient developed pseudoaneurysm. So, how to prevent that, and do you have any experience with this?
As far as the hypophyseal arteries are concerned, are unlikely to be damaged in the pituitary surgery. I tell you the reason. There are 2 groups of hypophyseal artery, the inferior and superior.
Inferior, yes, sir.
Inferior hypophyseal is a branch of meningohypophyseal trunk. It arises from the posterior band of the carotid and go towards the pituitary on either side and form a circle around the sella.
Sella, yes, sir.
And the superior hypophyseal comes from the first cisternal intracranial segment, the subarachnoid segment, and they form an arcade around the the pituitary stalk and the chiasma. So when you deal with the pituitary tumors inside the sella, you are practically away from these vessels which are outside all around. So generally we don't damage unless because of the manipulation or something you induce or happen to be spasm in these vessels. That is beyond control. So spasm is something you can't realize, you don't realize, and that is beyond your control. If you know there is a spasm, you can give some vasodilators, but you don't know what is the reason behind those vessels, whether they have gone into spasm. There is no way to pick up. But by and large, these vessels cannot be injured in a regular pituitary surgery if you follow the protocol and stay inside the cella.
Okay. So actually neurosurgeons at my place are very used to use the curette. So that might be something that
your neurosurgeon is one of the best in the country, Dr. Bihari.
yes.
I know him. He's from Jaipur. I know him very well since my MBBS times. He's a brilliant guy, and see what amazing work he's doing in PGI there. You must be knowing well.
Yes, sir. I mean, he is the one who give us all the training and give the backup when we're running.
Simply
so
amazing.
Even we damaged carotid artery once in a angiofibroma, and I could not think that we would have saved the patient if there will be no Professor Bihari in the operation theater.
He's amazing, simply amazing. So these are the high risk situation we have discussed already. You can see the regions. So what are the options in high risk situations? Either don't do the endoscopic surgery, do an open surgery, or assess again with a balloon occlusion testing if feasible, or you do a prophylactic occlusion. If the patient passes the balloon occlusion test, you coil the artery and do it. We do many a times for the lesions which involve the carotid artery, and if you find the cross flow is good, we coil the intraluminally the vessel proximally and distally beyond the lesion, so that even if you lacerate the vessel, the bleeding will not happen. Or if the flow is not good, you can give a bypass, prior bypass before dealing with the lesion, so the ischemia doesn't happen. Or you can keep a neck control if you have an intervention radiologist facility in your hospital. Like I give an example. Dr. Madhusudan in Bangalore recently in a workshop, what he did, he had a tumor I was demonstrating in the workshop was an adenoid cystic carcinoma of the high infratemporal fossa, and it was involving the petrous carotid, horizontal petrous carotid. And since it was a post-RT case revision, I was little reluctant to operate endoscopically. That was a relative contraindication. I said him, boss, it may rupture lacerate the vessel. Well, don't worry, I'll keep a catheter right inside the lumen. The moment it ruptures, I'll inflate. Don't worry. We did a case, and once see this kind of a facility you have, you can do such cases. And another thing is a pre-op stenting, and this concept is different. Suppose you have a kinking of the vessel involved, all this, and the cross flow is not good. What you can do? You, before removing the lesion, a month or more than that before, you put a pre-operatively a stent inside the vessel, proximally and distally beyond the lesion. These are nitinol stents, in the lumen of which the intima forms in few weeks. Neo-intima forms. So what happens now when you remove the tumor from outside? There is no question of lacerating the vessel, but the thing is you have to wait for at least 4 to 6 weeks for the tumor surgery after the stenting until the intima forms. These are the various options in case you are operating for a high-risk situation. So another thing, this is important, for every segment of the ICA, there are certain reliable landmarks which you can rely upon. Like for parapharyngeal, endonasal surgery, Eustachian tube has a relationship with the carotid like a mother's lap. It covers the carotid like a mother's lap. It's an amazing, single amazing landmark for the parapharyngeal carotid from an endonasal perspective is Eustachian tube. Then for the petrous portion, it's the Vedian canal, which is one of the most important, and the V3, which crosses the carotid artery. Anterior to it, comes from the middle fossa to the infratemporal fossa, like a horseshoe leg. Then the foramen lacerum portion, again, the Eustachian tube, and the most important is the Vedian canal. Vedian canal is the most important landmark in most difficult situation in the endonasal perspective. And for the paracellular, obviously the OCRs, the medial and the lateral OCRs, you have seen in the pictures how useful the landmark they are once you are doing the endonasal surgery in that area. So one should be well versed with finding these landmarks and relating to the carotid artery for the given situation in that region where you are operating, and take the help of this. And these are the, as I mentioned, surgical tips when you are working close to the carotid artery. So these are very, very important so that you can avoid injuring the carotid artery, like using the diamond bug, not to twist the bone pieces, traction, and all these things to be avoided. And most important, the monopolar cautery to be avoided. Stent, as I said, is contraindicated in certain situations. Leave it. Now, showing some of the examples of the carotid injury that you can see this case, and see, I'll tell you what was the mistake done. This is the pituitary surgery, and see the surgeon what is doing, using a curate. We never advocate using any sharp instrument inside the sella. Our principle is to use two sections and suction elevator. That's it. See, the curate happens to lacerate the carotid, and see what happens then. The kind of bleeding is so difficult. What you need to do in certain situations, use two suckers to keep the blood away. See this? Use two suckers to keep the blood away and see the site of laceration. And once you see the site of laceration, then you need to pack something immediately, whatever in your hand. If you have gauze piece, if you have cotton ball, if you have Surgicel, Marocel, whatsoever, you need to close, press on the rent to stop bleeding. This is one example. Another example, see, this is another classical example, the mistake what surgeon has done. See the instrument, this is being used inside the sella, and this is a through biting forceps for a fibrous pituitary tumor. And see this, what happened? What a disaster. See this through biting, which being unaware of where it is using, and what happens to lacerate the carotid, and the disaster. So the bottom line is not to use any sharp instrument inside the sella. Another one, this is, you know, there's a small tear in the carotid, the rent, and see here the surgeon, in that situation, use the monopolar cautery and happen to close it. Time being, it's not a final answer because it can lead to pseudoaneurysm, other issues can open up again, but somehow could control. And this is something important, how to manage the carotid in that particular situation. So what you can do intra-op if the artery happens to get injured. Quickly, I'm just going quickly. First and foremost thing is to pack immediately with whatever material you have in your hand. But use two suckers to keep the blood away. Find the laceration and right exact over the laceration you need to pack, not to overpack to lead to cerebral ischemia. And anesthesia team works together to maintain normal tension. What you can do in case of severe pressure, what you can do additionally, you can go in the neck, temporary, go in the neck, harvest a muscle patch, the sternomastoid, go to the common carotid and put a temporary clamp, bulldog clamp, temporary, so that it can reduce the pressure, and then you can come back in the nose. Wherever you put anything, now you are prepared with a muscle patch and other material, Surgicel and all. Remove whatever pack you had put in initially. Now the pressure is going to be less, can be managed easily. This is time being 5 to 10 minutes, and then put a muscle patch in relation to the wall and put fibrin glue and Surgicel balls over it to prevent the bleeding. And that is give you enough time, going to give you enough time to manage further. And because ultimately what you have to need to do is, in such injury, you need to transfer the patient to the endovascular suite for the angiogram and for the management about the studies of the cross flow and all that. There are a lot of clips described in the literature, not very practical. You go to the PJ Omal's publication showing a lot of giving experience of handling the induced carotid injury on the sheep models, and that gives you a like a experience of a live carotid injury which you have managed in a live sheep model, and those are important to understand too for your practice. I am not saying that those are bad, but one should experience those. So what happens when the patient is shifted to the endovascular suite? The need is you need to control immediately. You need to see which area of the vessel is involved, any pseudoaneurysm formed, patient can be given antiplatelet or not, and then you have by and large options. If the collaterals are good, the best answer is occlusion of the vessel by the coiling. That's it. That's the final answer to this. Final and the best answer. But if the collaterals are not adequate, either you have to put a stent to maintain the flow or do an emergency bypass. But in any given situation, you cannot go like cannot and catch the vessel. It is next to impossible. I told you, okay. So
John Shadow from Australia, Satish.
Yes.
Dr. John Shadow from Australia.
Yeah.
Which vessel you prefer for bypassing?
There are many ways. We can external carotid, like Gaurav said, we can take, or if you have a good caliber, this thing, superficial temporal, you can give a bypass to the middle cerebral from there. That is the shortest route. Or you can take a graft from the radial artery and put a bypass from anywhere to anywhere. A lot of reports have described using the maxillary artery as a good caliber for the middle cerebral artery. So any of such vessels can be used, but the vessel should be high flow to maintain the need of the vascularity required. So cover stent, you can put the stent conforming the vessel and the flow is maintained. But there are a lot of disadvantages in adjusting the size. They are metallic. To go to the tortuous vessel is difficult. It can result into problems. They require antiplatelet lifelong. There are so many things. I'm not going into detail, looking at the time. And if pseudoaneurysm happens to occur, then this is the most important complication. When the vessel is injured,
Hello?
Hello?
Dr. Satish Jain?
Hello?
Hello?
I think it's cut. Okay, I'll ask a question to Dr. Gaurav. How do you deal with, it's a question from Rahul Shah in Surat. He's asking how to deal with cobblestone appearance and polypoidal mucosa in maxillary sinus, particularly along the floor.
It's quite simple. You just have to open up the sinus pretty wide and then allow them to rinse with steroids. That's pretty much it. That'll take care of the cobblestone appearance on its own.
Okay.
I think sir is back. Satish boss?
Yeah.
Yeah, okay, you're back. Yeah, let's continue.
So I'm just finishing it off early.
Yeah.
So this is the pseudoaneurysm. This is the major cause of a disaster. What happens? You happen to have injured the vessel wall, which may not have manifested that time, or manifested and you packed and realized that it's over. It can lead to pseudoaneurysm formation, which can burst any time, and that is a disaster. That is fatal. In that cases, you have to again follow the same principle: balloon occlusion test the cross flow. If good, occlude the vessel, otherwise stent or something like that. Then if stents are not possible because of the tortuosity, then flow diverter are the stents. Very costly. You can conform to the any vessel situation, though difficult to place, but these are very important. And then finally, you have to take, you are ready, leave on the intervention radiologist to take a final call. Thank you.
Thank you so much, sir.
Sorry for the being so fast.
No, definitely.
Amit is still there. And
there are no questions, sir, right now. I mean, we've answered mostly all of them. Sir, many in between surgeries, many surgeons wanted to know the post-operative irrigation, the solution, what is the exact solution that you give, the quantity,
To begin with, we use the budesonide aqueous solution, the same budesonide which is used for nebulization for the asthma, respules. So what we do, since it is topical, they use 1 liter of saline and mix 2 milligram of budesonide. That amounts to 0.5 milligram of budesonide per 250 ml, which is the fluid required for irrigation every day. So you are ultimately giving a 0.5 milligram of steroid every day, that too in a topical form. So that remains quite safe for the long-term use without any systemic side effects.
So can I add a point here with your permission? With your permission, Satish sir. So in Vancouver, we did a long-term budesonide study because we've been following up patients for almost 8 to 9 years now. And from our cross-sectional study, we found that there is a 3% chance that even with topical budesonide, the patient can develop some amount of HPA axis suppression.
But
So
it is not published so far in any study. It is not. The studies which I have gone through.
Yeah. This is what
using the
internal data that I'm telling you.
Using the budesonide for more than 2 years.
Yeah.
So many studies published. No one else could pick up any effect on the HPA axis, any suppression or anything.
So now what we do as a routine is we do a bone densitometry every year or 2 years, and we do tonometric study.
Imagine that patient requiring the budesonide for years.
Yeah.
That too topical. Now, if you don't use the budesonide and using the oral steroid, what would happen to the patient? Imagine.
No. They have to use it, but we just have to keep an eye on it. That's about it.
Yes, and for that matter, as I told last time, practically, according to the situation of the mucosa, you have to take a call of reducing the frequency and concentration. You don't have to use as a blanket all for the life.
So it's the minimal dose required to keep the mucosa healthy. That's what we need to use. That's about it.
Sandeep wants to ask, Miss, one question is there. Can we put local, while finishing the case, can we put local steroid in the form of gel form over there? Or we can we give local steroid in injection form in the after doing surgery, mucosal injection of local steroid?
After the surgery?
Yeah, just after finishing the.
Yeah, we always pack with the steroid packs in the ethmoid cavity after the surgery.
Which steroid pack means? What do you use? You use Marisol soaked with any steroid?
Soaked in triamcinolone, dexamethasone, or any steroid, whatever. Steroid is
Feroz Khan from Dubai. He wants to know, can this Manuka honey can be used for the ear also, ear and chronic cavity infection? Or
I have used it all over. I have been able to, save so many cochlear implants, developing biofilms, to develop biofilms using Manuka honey. I demonstrated at several places, and it is really wonderful. You can salvage implants also anywhere in the body. Even now, I have a lot of discussion with orthopedician, and one of our orthopedic colleagues was so excited, and he could salvage one of the orthopedic implant with the Manuka honey. It's important.
Good. Amit was there. Amit, I think he just joined us for some time. Where is gone? Amit? Anybody? Any questions?
Sir, you deserve a huge applaud from all of us.
Round of applause. Yes, sir.
Yes.
Definitely.
Exactly, sir.
After operating 4 cases, you have the stamina to do a complications lecture.
It was
just like olden days.
All 3 cheers for Dr. Rajiv Pachori.
No. All team.
Compose, always
Dr. Rajiv Pachori, sir.
He deserves everything.
And
we did the best from you, boss.
We could not believe, sir, you would have finished 4 cases in this short duration time. You finished.
4 hours.
You finished. You explained us well, and I think all these 4 in this series of chronic rhinosinusitis, the 3 parts that we had, the main aim of that we had decided of this series has been fulfilled, has been accomplished. And
we have record, I think, maximum attendance today. And thanks, Gaurav, for the wonderful discussion. And
today I am so happy to have our own teachers, Professor Kitne sir, Satish sir, and Professor Aldo Stam. And they are amazing people who have done phenomenal work. I'm so happy to have them here today with
wonderful.
us. They made us our day memorable. And thank you, Gaurav. Gaurav has been a
Sir.
powerhouse of,
Yes.
energy.
Yes.
No, definitely,
And
sir. It's all your teaching.
And last but not the least, again, truly, truly grateful to Sun Pharma for their tireless efforts in organizing and hosting this amazing event that brought all of us together in this arena. It's a treat for us in this COVID-19 pandemic situation that we got today.
Yeah, I think Paramita deserves a round of applause for taking all
Absolutely.
those
She's
questions. It
Exactly.
is a
I mean,
very difficult job what she's doing. It's a very difficult job.
Thank
with
you.
all three, four eyes.
Gaurav, our job is
We
most
have to keep
difficult.
all the
On one side, she has to concentrate what I am talking. Other side,
Exactly.
she is getting questions. On
Yeah.
other side, she has to ask questions. She has
Yeah.
to segregate questions according to the
Yeah.
importance and the topic.
Exactly.
Most
Exactly.
difficult job. Thank
Yeah.
you.
in between
Hats
fighting
off
with
to
me,
you.
in between fighting with me.
Thank you, sir. Thank you so much.
Okay,
Yeah.
thank you.
And thank you,
Okay,
Amit,
good
for
night.
your active involvement. Amit is always
thank you, sir. It was
Amit is our
actively
pleasure.
involved with his interesting questions benefiting everyone. Thank you.
since the starting he was with us.
Thank you,
Thank you,
sir.
sir. Thank you, Dr. Satish Jain.
Thank
It was
you, Mr.
amazing.
Amrishji.
Yes. Sun Pharma, do they want to conclude the session? They want to say anything? Is there anyone from Sun Pharma?
Yeah, I'm there.
Yes, sir. Thank you so much.
Yeah, it's my pleasure. And it's actually, I had been patiently listening each one of you for complimenting each other. For me, at least, it's the teamwork which was actually most important. I think all of you deserve applause. All of you have done a wonderful webinar. For the first time, actually, I had been, into webinar. We had been conducting so many webinars, but for the first time, I have seen such a decent number of viewers, which has crossed over 5,000. So credit goes to Dr. Jain, Dr. Pachauri, Dr. Gaurav, of course, wonderful moderator, Dr.
Paramita.
Thank you, and
Thank you.
wish you all the very
Thank you.
best.
Thank you.
We shall meet personally
We'll
very
meet
soon.
on Sunday, 10
Definitely.
p.m.
Sunday I'll be there.
10 a.m.
Thank you. Thank you all once again.